Can you hear me?
Larissa, you can be heard. You can be heard. You are audible.
Thank you.
We'll start with some introduction.
Good morning, everybody. This is Dr. Monica Pansari, surgical oncologist. We welcome you all once again on day 2 of our SPOC conference. After having an extensive session yesterday, we are going to restart our day 2 of quite a knowledgeable sessions. So to start with, we'll have first session, which is on scope of research and challenges in prevention of cancer. Speaker for the topic is Ms. Larissa Nagraj Singh. She's VP Business Development, Asia Pac Icon Clinical Research. She's going to be speaking from Singapore. She's life science leader with 25 plus years of experience in pharmaceutical and CRO industry in Asia. The moderator for the session is Dr. Vivek Srivastav. Dr. Vivek Srivastav has worked as Director for Enteral Nutrition Development Center at Fresenius Kabi. He has got more than 14 years of experience. Over to you, Ms. Larissa and Dr. Vivek to take on the session.
Hi, good morning, everyone, and thanks SPOC for organizing this and giving this opportunity. And yeah, this is going to be very interesting because what Larissa has to talk about, it's something which comes from her experience of 25 years, and I believe she will be directly pointing on that how her experience has been in last 25 years working with a team. And Larissa, what I would investigator, sponsors, and patients.
Thank you so much. I think your voice was breaking, but if I understand,
shall I repeat it for you?
Yeah, it would be good if you could repeat the question, and I could take it from there. Thank you.
You come from with the clinical research experience industry, and it has been 25 years for you. So just wanted to know your notion. What is your thought process? That how do you see? What is your observations with the relationship between the patients, sponsors, and the investigators in clinical research?
Thank you so much, Dr. Vivek. So what I would do is I'll answer your question as I get along in my brief presentation. I really want to remain within the time because there's a lineup of very competent speakers post my presentation. So what I've done is I've just shared some of my personal views. This is not representing my organization, and I represent myself in this call. And I'm a strong advocate of alternative, holistic, ever-encompassing approach to treatment. And I believe we as an organization, as a society, are responsible for our own well-being as well as the well-being of our citizens around the world, global citizens. So what I did was I just wanted to set a perspective on what I see around myself. You know, being in the research industry, there's a lot of conversation about running ethical clinical trials, trials with high quality. There are a lot of molecules in development. And there is a very positive intent by both the researchers, by the doctors that are sitting in this room and maybe attending globally, to basically bring forward, in collaboration with the sponsors, that could be pharmaceutical companies, biotech companies, medical device companies, to get good products in the market. And intent is to make life of patients, subjects, more livable, and there should be some value in life. But as you can imagine, this is a very complex space. There's a lot happening. Each individual is exposed to environment, within the society, within the family unit, difference in nutrition, mental state, childhood development, how the parents have looked after the children, the habits that have formed. And yesterday we had very good sessions that I could very fortunately enjoy yesterday. And most of my speakers shared the same thing. Several studies done to prove a good lifestyle, a holistic lifestyle can actually extend your life. And the purpose of our life is to basically, in fact, there is a god for that also, and that's called, Shojing, who is basically Lord of longevity. But we also see a lot of books published, a lot of work done in this space, and I would really recommend all of you to pick up these interesting books and TED Talks to further gain insight on how we can extend life and how 50 to 60% of cancer deaths can be prevented. Moving on with this, I also want to set a perspective. Even though I'm from the research space, and I and my colleagues from the industry may have been and would have been involved in clinical trials that are listed here. And this is a very fresh data. It's out of 2021 BMJ data. That one of our track is we are obviously expecting a quick approval for some very cutting edge products that can actually save patients' life very soon. So the FDA, the regulators, the EMA are all actually giving approvals called expedited approvals, so that product can be brought in the market quickly. But as you can see, that post-approval commitment has shown that some of these products don't even meet the endpoint once they are in the market. Some have to change their labels, some have to actually withdraw the product. And we've actually seen some of the companies voluntarily withdrawing the product. So I'm not trying to be negative. I'm just being positive in two ways, that the intentions are good. The intention is noble. But I think we as an organization, we as a team need to work through a process where the patient understands the risk, the patient understands the benefits. Some great products come out, but we are also keeping a very, very close eye on how the product is behaving in the market. So observational studies have become very, very important. In the near future, we will see that increase in the observational studies, post-marketing surveillance studies is going to be very important. But also as important is what markers are we trying to measure? What surrogate markers are we picking up? And as I move along, I'll show you that there is a lot of studies going on. And one of the most challenging aspects of a cancer prevention studies is, one, we really don't have clear state of the disease that we see at the very beginning. How does the disease really present before the symptoms are presented by the patient? How do we check the markers? Although the good news is that genetic profiling has become very common. Yesterday, a lot of speakers picked up this topic, bioanalytics, gene pooling, gene analysis. These are going to be the future. And I really recommend to the public who are listening to this, do your profiling, do your testing, so that at least you know what the risk factors are, at least keep a monitoring of your health. And I would like to add over here, every individual's responsibility is to manage their own health. I mean, we as a society, as an organization, as a global citizen can only bring forward some of the strong points of how you can live a good life. But as they say, you can force the horse to come to the pond, but you cannot force him to drink the water. So it is the responsibility of each individual player to make sure that they are following certain good practices. I remember yesterday, one of the doctors mentioned about smoking, how bad the smoking is, the tobacco habits. And these are all which are well-known factors which have actually proved to cause cancer. So when you know these triggers, when you know these signals, what are we doing to prevent those taking forward and turning into cancer? Cancer as such is quite a complex disease. And as I would say, if you compare with diabetes, let me give you an example. In diabetes, it's very easy. You know the sugar levels, if they're controlled, if you exercise, you tend to have, you can prevent or delay the onset of diabetes. There's been a study which is very interesting on a nurse team, where they found menopausal women who were losing weight, had less obesity, had a lower risk of forming breast cancer. So these are some easy examples that we see, but otherwise complex indication may not have a clear endpoint, may not have a clear marker that we could work towards to see how long the cancer will develop and what we can do to prevent it. My slides will be available to everybody. This is a very long topic. I want to, as I said, 15 minutes, so I want to keep there. There's been a very interesting study done by Wilson and Jugner, and they have listed down what are the studies that we should select for studying the prevention of cancer. Everything cannot be done. Every aspect cannot be picked up. So there are some guidelines, and I think industry should, this is a very, very old paper, but I think it has, see, it's 1968. But even today, when I was reading it, it has so much of validity, so much of importance. And I think we have been ignoring some of our work that we've done before. And maybe that is what we need to do, is bring forward some of that work and merge it with the new area that we are focusing at the moment, which is personalized medicine, genetic testing, and biomarker analysis. So all that stuff. From the CRO perspective, clinical research perspective, clinical trial perspective, we have come to a conclusion over the years where the problem lies. Why are these trials not being successful? What can we do? And I think this is my call to the medical fraternity, where if they see a trial is being shared with you and you've been asked to participate in a clinical trial, do look at the design of the study. Do look at the concept of the study. Sometimes some companies, because of the fact that they are so blinded with their product, they're so much in love with the product that they may not go beyond to really see if it is really applicable for the standard of care. I mean, are we able to use it in combination of other drugs? Are there any testing, or do we have enough equipment to do certain evaluations? And I strongly recommend, please push back. If you feel that the study is not well designed, if you feel that this protocol doesn't have adequate measures to protect the safety of the patient, please push back. Because you do two things. One, you reduce the cost of running the clinical trial. Who is the ultimate player in paying for those clinical trials is the patient. And we don't realize, but in the beginning, it is like, oh, the sponsor's paying. But no, it's a patient, because the cost of the drug will be built and based on the trial cost. So as a medical team, you might as well do that and push us to go back. To the patient population, the subjects, to our society, my ask would be, there is a very important document, a legal document called the Informed Consent Form. Please read that document. It is one of the important documents that shows what your commitment is going to be. What are your benefits? What are your risks? And what happens if you actually, unfortunately, have a side effect? So I think that is an important piece, and your compliance to the study, because if you do not comply to the study, if you do not follow the process, the trials are so well regulated, you become a non-evaluable patient. This means your data cannot be included in the larger piece of the data, which is again waste of money. So if you are not serious, you're not committed, please do not participate in a clinical trial. But if you participate, then please do so with full consciousness of what you're supposed to be doing. This is a very busy slide, and I leave it to all of you to read whenever you want, and you can always connect with me. But I can tell you, we have post the approval process, post the study sites are activated, when the studies are when the patients are actually coming in the trial, we are trying to become more and more efficient. And one of the most difficult pieces, we bring up many sites, many hospitals to participate in a clinical trial. But what happens, some of the hospitals don't recruit. And there is a study that more than 50% of the selected hospitals don't recruit. That again is a cost to the study. That again is a cost to the patient. So if you don't have the time and commitment to participate in a clinical trial, I would really request you again to decline a study rather than go ahead and participate in a study. So that would be one important aspect. My last slide, and I think we'll open it up for questions. What should we do next as an organization, as a world citizens collectively? I think we have to work more in team spirit, because sponsors, they have their own path, their own intention, but we need to make the cancer-free world. So what are the markers? What are we doing? How are we bringing it about? It's a very big task. It's a very big ask, but baby steps if we take, we should be able to achieve. Limitation, I saw yesterday somebody presented on Teflon products, Teflon utensils. What kind of water you are taking, what kind of exposure you're giving to your children, what are you doing with plastics? don't use plastics for your children. So there are many things you could do in baby steps to, in the long run, make it more suitable so that cancer gets delayed or actually gets eradicated, which is, I think, a dream, at least not in my lifetime, would be ever possible. But each step that we take would be important. I think the investment from the government, the social enterprises, and crowdfunding, all the people involved, preventive trials are very, very expensive. As I said, it's difficult to get an endpoint. It's difficult. It's a long duration studies. They take a lot of time because symptoms of cancer are not visible or developed at very early stages. So we need to follow it. As I said, interesting study in the very beginning of my session was on happiness. It took them 75 years to prove how a person could live a long life. 75 years to come up with a plan of how to be happy. That is the duration it takes to really come up with a final report for a preventive trial. But we need to see if we can get some more markers, some early detection signals. And last one, but not the least, is a holistic life, which has been discussed a lot yesterday. I think there was topic on yoga, nutrition, and all these points. I personally feel with the development now, the personalized medicine is going to play a very critical role. And that is linked to the genetic testing. So all the therapies that we're coming up with now are very targeted to patients who are responding to treatment better because of the genetic profiling. Earlier, the trial participants were exposed to large number of trials. They would show certain physical parameters, some blood reports, some I would say investigational imaging tests, but some of them would not respond because their genetic makeup was different. Personalized medicine will be the one which we will see as a future development. And I think I want to just close my presentation with Grandma P. Papamal, who has lived a long life, 105 years, Padma Bhushan. She shows the way. Organic farming, peaceful living, simple life is what will lead us to a better life in the future. So with that, I end my presentation and hand it over to, and I want to thank Dr. Nanda for bringing this topic up. It's very close to my heart. And I hope we are successful and we grow as a family and spread this message far and wide. Dr. Nanda, Dr. Vivek, back to you.
Thank you, Larissa. It was a really lucid explanation with the help of your slides. You mentioned about and in a very kind way. That's really important to understand. And I think a lot of the focus should be given on the prevention strategies for the cancer. We are running behind the time, so I would end up here. Thanks to Dr. Dutt and then the organizers once again. All right. Thank you.
Any questions on this topic? Thank you, Lara. Again, actually, one interesting thing that you showed us, 1968, they did show one paper. So it looks like we lagged in looking into that paper. So good that SPOC Foundation is bringing that back. So let us see how we can proceed with some clinical trials with your help. Thank you very much.
It's my pleasure. Thank you very much for inviting me. Thank you.
Thank you, Ms. Larissa and Dr. Nanda. We'll move on to our next session now. Our next session is topic of the next session is role of vaccination in cancer and newer innovations. Speaker for the topic is Dr. Sudhir Bargona. He's Vice President of Clinical Development, Capricorn Therapeutics in USA. Moderator for the session is Dr. Rajiv Vijay Kumar.
So I'd like to invite Dr. Rajiv, good friend of mine and consultant medical oncologist at BGS Global. Over to you, Dr. Sudhir. Not joined it. So what do we do?
We have got the speaker for the next session. So I would like to invite Dr. Jayanti Tumsi to come over. And so we'll move on to our next session. Dr. Jayanti is lead surgeon breast oncology at Apollo Hospital, Bangalore. So I would request Dr. Jayanti to take over. Moderator for this session is Dr. Preeti. So I would request, she's a general surgeon. So I would request her to come over and moderate the session, please.
How do I change the slides? Sorry.
Good morning, everybody.
Can you make it full screen?
Jayanti is a good friend of mine and very dynamic oncosurgeon.
Thank you. Thank you, Preeti. And at the outset, I congratulate Dr. Nanda and her team for putting up such a magnificent conference. Hearty congratulations and thank you very much for having me here today. Well, I know in the audience there are doctors and as well as non-medical. So there was quite a big confusion in my mind as to how do I deal with the topic which has been given to me, which is a very, very medical related topic. So I will talk about a lot of studies, etc. But in the end, there will also be a message for people who are non-medicals. So the topic that I will be speaking on, this isn't working. Can I do it here? Okay. So the topic that I'll be speaking on is infertility, IVF treatment, and risk of breast cancer. So all over the world, this is showing something else. Click on the laptop. Okay. So for decades, breast cancer has been, can I not have it here? Yeah, okay, now it's come. I will do it, please. Yeah. So for decades, breast cancer has been the most common malignancy among women worldwide. We all know that. The breast cancer epidemiology has made substantial progress during the recent decades, revealing various risk factors, and I'm sure a lot of it has already been discussed, for diseases which are hormone related as well as non-hormone related. Hormone related risk factors encompass endogenous as well as exogenous exposure to estrogen and progesterone. So the inherent risk factors that have included younger age at menarche and older age at menopause, postmenopausal obesity, nulliparity, and older age at first birth. The endogenous estradiol levels have been associated with increased risk of breast cancer in postmenopausal women and also in premenopausal women. And on the contrary, oophorectomy has been associated with decreased breast cancer risk. The exogenous hormonal factors, as we know, include oral contraceptive pills and hormone replacement therapy, which is given for menopausal women. Now, recent meta-analysis has pinpointed that hormone replacement therapy is positively associated with increased breast cancer risk. Now, both exogenous and endogenous estrogens and progesterone have shown to affect breast cancer. Now, since in vitro fertilization procedures temporarily cause decreased estradiol and progesterone levels, which happens during the downregulation of the natural cycle, and strongly elevated levels which are seen during the stimulation phase. So the question is, does IVF influence breast cancer risk? Knowledge about possible long-term influences of ovarian stimulation for IVF on breast cancer risk is still scarce because use of IVF came into use only since 1980s. All over the world, about 48.5 million couples have problems with pregnancy, and many children are born with the help of fertility treatments. After cancer and cardiovascular disease, infertility is the third most common disease. With increasing numbers of couples delaying parenting attempts, the prevalence of infertility is certainly on rise. Now, assisted reproductive technology is one of the most important strategies used today to increase the chance of fertility among infertile people. The ART uses many medications and techniques to increase the chance of fertility. Now, in ART, what is mainly used is ovulation-inducing drugs are among the most important drugs used for the treatment of infertility, which affect the ovaries by increasing the levels of estrogen, progesterone, and gonadotropins. In recent years, there have been many debates about the relationship between these drugs, infertility treatment, and breast cancer. Changes in endogenous hormones that occur following the use of these drugs have raised many concerns about the safety of these treatments. Now, due to increasing infertility and subsequent increase in the use of fertility drugs, understanding the long-term effects of these drugs is certainly important. It also raises the following question: can the use of fertility drugs in the long term cause breast cancer? Now, in general, cancer occurs, as we all know, as a result of division of mutated cells. Therefore, the hormone or any factor that stimulates the growth of the cells can affect the occurrence of cancer. The relationship between steroid hormones and breast cancer is well documented. Estrogen, progesterone are steroid hormones that are produced following a series of biological responses and are derived from cholesterol. Estrogen, which is one of the most important female sex hormones, is produced in ovaries and the adrenal cortex. Free estradiol and albumin-bounded estradiol are associated with an increased risk of breast cancer and can enhance the progression of metastatic breast cancer. High levels of estradiol and estrogen hormones in women with breast cancer contribute to the progression of metastatic disease. Estrogen, in addition, can contribute to the onset of cancer by affecting mitosis duplication of epithelial cells. Increasing mitotic activity can play a role in increased probability of mutation and DNA damage and reduces apoptosis and growth of early tumors. The role of gonadotropins in the occurrence of breast cancer has also been very well established. High levels of LH and FSH can cause exposure to uncontested estrogen in the menstrual cycle, which contributes to an increase in breast cancer. On the other hand, stimulating the synthesis of mitogenic growth factors by gonadotropins can contribute to the growth of breast cancer cells. And in addition, high levels of gonadotropins predict a weaker prognosis in people with breast cancer. Now, breast cancer, as we all know, is a multifactorial disease, and several risk factors are involved in its onset. The majority of breast cancer are hormone dependent. Several studies have pointed to the etiologic role of endogenous and exogenous hormones in increasing the risk of breast cancer. Therefore, the possible relationship between ovulation-inducing drugs and increased risk of breast cancer has been the subject of discussion. Compared with normal ovulation cycle, estradiol concentration increases up to 10-fold in ovulation stimulation cycles. So there have been umpteen number of studies that have gone through to know what is the risk of breast cancer in people who use the fertility treatment. So I have just given a gist of the various studies. The result of a cohort study on 8 lakh women showed that the risk of breast cancer increased in individuals who gave birth following ART. However, there are also limitations to these studies. In this study, confounding factors such as age of menarche, family history, history of breastfeeding, and obesity were not controlled. In another cohort study, the risk of breast cancer was increased among individuals who used ovulation-inducing drugs, although this risk was not statistically significant in primiparous women. In the result of another case control study of women between 35 to 64 years old showed that although the use of fertility drugs was not associated with an increased risk of breast cancer in general, the relative risk of breast cancer in people with FSH and LHS use for more than 6 months or 6 cycles was about 2.7 to 3.8. Another case control study found that IVF treatment after the age of 30 years was associated with an increased risk of breast cancer. However, the characteristics of breast tumors in subjects treated with IVF did not differ with the general population. Although the results of above studies suggest a relationship between infertility treatment and the risk of breast cancer, a large population-based cohort study done between 1991 and 2010 stated, regardless of infertility treatment, the risk of breast cancer in people who are incapable of conceiving normally is increased by 2 times. Meanwhile, many researchers at the same time could not show a positive relationship between fertility treatment and breast cancer. The result of a cohort study of 98,000 women aged 40 to 65 years showed no relationship between the risk of breast cancer and infertility treatment, the type of treatment, the type of drug, the age of the person at the start of treatment, and the duration of treatment. Another study suggested that infertility treatment may be associated with an increased risk of breast cancer among women with a family history of breast cancer. In a cohort study of around 50,000 women, no relationship between the duration of fertility drugs use, the time since the first use of drugs, and the risk of breast cancer was found. The results of a cohort study pointed to the potential association between family history and the use of ovulation-inducing drugs in the incidence of breast cancer. In general, according to the results of related studies, the relationship between fertility treatment and breast cancer has not been proven so far. So these are plenty of references which I went through before putting up. So in conclusion, I would like to say that yes, it is important to determine the relationship between the use of fertility drugs and breast cancer. Due to the correlation between hormonal and reproductive factors and breast cancer, much more attention has been paid to the relationship between the use of fertility drugs and breast cancer in the recent years. Although this relationship is theoretically justifiable, the complex and multiple factors that are involved in the onset of breast cancer make it difficult to determine the definite relationship between the use of these drugs and breast cancer. In spite of relationship that exists between the ovulation-inducing drugs and breast cancer in some cohort studies, the results in general showed no significant increase in the incidence of breast cancer by infertility treatment. According to the results of most of the studies, there is no definitive relationship between the use of fertility drugs and breast cancer, and only some observational studies have pointed and proved its relationship. So the following question still cannot be answered: are fertility drugs safe? Although the small sample size, short-term follow-up, and lack of control over confounding variables are some of the most important limitations of such studies, more studies are needed to achieve a better result. However, one piece of recommendation would be regular breast self-examination and clinical breast examination by an experienced clinician while on infertility treatment, and having a high level of clinical suspicion is absolutely essential. Since a large population of people who use these drugs are young, long-term follow-up can better detect the onset of breast cancer among them. At the end, the relationship between infertility treatment and breast cancer incidence still remains an open question. Sure, questions are guaranteed in life. However, answers may not be. But in general, I would just like to say that so far, there has been no risk associated with infertility treatment. However, we cannot take it lightly because we still need some more studies to prove it or disprove it. And hence, whoever is on infertility treatment or the doctors who are treating, doing a clinical breast examination regularly and encouraging the women to go through breast self-examination regularly is extremely, extremely important. Thank you so much for this opportunity. Thank you very much.
Yeah,
Plenty.
Dr.
I've
Shaker
seen
here.
plenty. Yes, I have seen many too. And though studies say that there is no risk, but I have seen that most of the times it's because of lack of clinical suspicion by the doctors and as well as the patients. They are generally very young and the clinical suspicion is very low.
I think I should like to add, I have seen quite a few
Yes.
IVF patients. The only thing is that before IVF, I would suggest all gynecologists to do a complete breast examination, a breast sonography, because many a time when you go into the history, even before the IVF, many patients have noticed a lump. So at least in my 4 decades of experience, the last 1 decade, I've at least seen 8 patients who are all very young. And I felt very bad because those tumors were a bit aggressive. And by the time the child is 1 year, we have lost patients. So the message to the gynecologist is what Dr. Jayanti said. They have to assess. And I think in Apollo, we usually, I think our gynecologist, used to send patients to us for examination, and then they put them on IVF treatment. And as she rightly said, we have to have a good follow-up of these patients.
Absolutely.
Thank you.
Yeah.
Yeah, Dr. Rajshekhar here. Sorry for joining late. It was an exhaustive coverage. Thanks, Dr. Jayanti.
Thank you.
Yeah, I definitely feel probably over a period, long-term studies may throw light that there is a relation, because the origin of tumor is very much related to hormones. So when these infertility treatments, when we deal with hormones, definitely there must be some risk factor. That is the thing which goes on for further studies. Long-term studies, probably randomized studies is not possible, but long-term studies. And because now infertility is also increasing, and we also see breast cancer is also increasing, so need more studies. But definitely, as she said, and I have few gynecologists who always do this breast examination, obstetricians who always do this breast examination before starting the treatment. So that's a good message to carry on.
And
Thank you.
also
Thank you very
while
much.
on treatment, and also while on treatment. Thank you. Thank you.
Yeah.
Very wonderful message. Especially, I think you should target the non-medical population, because usage of OCPs and medical termination have become an easy way out for the present generation.
True.
So, and the gynecologists also, the IVF treatment should be very much justified then only.
That's true.
So many times when they come to us, probably they could have postponed it and counseled them first before going for the other. I think bottom line of this main society is lifestyle changes, what is required. Thank you, Jayanti.
Thank
Any
you.
more questions?
Monica, you wanted to
I wanted to ask probably the number of cycles which they undergo.
that also is important.
That is extremely important. Probably most of the time what happens is that patients, they go to one gynecologist, they wouldn't reveal their history for the next gynecologist. They would have already undergone IVF number of cycles and ovarian induction maybe 2-3 times with the previous gynecologist.
Right.
And with the desperation of having babies, probably they go to next gynecologist without revealing their past history. But they have already undergone ovarian induction.
Yeah, but
So probably
also
that-
studies
yeah.
have shown that the number of cycles, the type of drug used, it does not have any.
doesn't have any
Yeah.
impact. But probably what we have seen in our
Yes,
experience is
yeah.
that more the number of ovarian induction cycles, more is the risk for
Right.
developing cancer.
Yeah. And another issue which develops is when they develop breast cancer, it's a precious pregnancy
Exactly.
and breast cancer. So it adds
Both
on
go
to the
happen,
more
yes.
complication of treating
Absolutely.
it. Yes. Yeah.
Thank you.
Thank you so much. Thank you.
Hope you are
Thank
planning
you.
to publish your studies.
I hope so. We are collecting data in that regard. Thank you. Thank you very much.
Thank you, Dr. Jayanti and Dr. Preeti. Thank you, Dr. Rajshekhar Jaka. Dr. Rajshekhar was moderating the session online. He could join us a bit late. He's a senior surgical oncologist, a robotic surgeon, very well known in the city, and he is my senior as well. So he has won many various awards and recognitions. Thank you, Dr. Rajshekhar Jaka, for joining us online to moderate the session. So we'll move on to our next session now, which again is a very interesting session. And I would take extreme pleasure and honor in introducing our next speaker. He's Padma Shri, Dr. P.K. Chaube. He's going to be speaking on bariatric surgery and its impact on reducing breast cancer, cancer. Dr. Pradeep Kumar Chaube belongs to the cadre of pioneer laparoscopic surgeons in India. He has graphed his career with singular determination to develop, evaluate, and propagate minimal access metabolic and bariatric surgery in India. The advent of laparoscopic surgery with his hands became a point in India's medical history. He established the Minimal Access and Bariatric Surgery Center at Sir Gangaram Hospital, New Delhi, 1996, which was the first of its kind in Asian subcontinent. At present, he is the chairman, Max Institute of Minimal Access, Metabolic and Bariatric Surgery at Max Hospital, Saket, Delhi. So I would welcome Dr. Chaube for his session. Moderator for the session is Dr. Ramesh.
From one bariatric surgeon to another bariatric surgeon. Dr. M. Ramesh is a very famous surgeon, laparoscopic surgeon in Bangalore, like most of us would know. He works at Fortis Hospital, Bangalore. He's a renowned surgeon with more than 30 odd years of experience in minimal access surgery. And he's one of the few surgeons who established bariatric and metabolic surgery in India. The world-renowned Bangalore Endoscopic Surgery Training Institute and Research Center was established under Dr. Markham's administration. He's trained over more than 1,600 practicing surgeons from over 5 continents and has been involved in several innovations, including the best endotrainer, virtual reality laparoscopic surgery simulator, and the circulation pump used for training in minimally invasive surgery. He's established the country's first fellowship course in the field of bariatric and metabolic surgery affiliated to the RGUHS Karnataka. Dr. Ramesh would be moderating the session online.
Over to you, Dr. Chaube and Dr. Ramesh.
You can start, sir.
Yeah, good morning, everybody. And thank you very much for giving me this an opportunity to be part of this very great academic event. And I'm glad to be with my other colleague, Dr. Ramesh, and I'm sure a lot of you in the audience. And thanks, Dr. Nanda, for taking this initiative and inviting me to be part of this academic event. I would like to share my screen and I hope you are able to get my first slide. Is it there?
Yes.
Okay. So I bring greetings from our Max Institute of Laparoscopic, Endoscopic, and Bariatric Surgery, now added with the robotic surgery for common diseases in New Delhi. And we are here with our team. And I'm very happy that we could sort of be here talking about the bariatric and its relation with cancer. I think this is one of the very common slides which is shown by me or all the presentations across the world, which talks about the risk of obesity. And if you look at this, the list of the problems are exhaustive. But it's very difficult to find somewhere the word written about the cancer. As you can see, the cancer is mentioned here, and you will find that many of the studies have not been including this as one of the risk factors. So look at this. I think, what are the friends of obesity? Unfortunately, we call friends of obesity, though in fact, it should be the foes of the obese person. But obesity is mostly seen and related with diabetes, related with cardiac problems, with obstructive sleep apnea, PCODs and its problem, joint-related problems, etc. And all the trials, major trials, if you see across, we also conducted this trial, what is known as a metabolic outcomes, because in obesity, you give a lot of importance to the metabolic outcomes. And these are our trial also was started in 2006. And now we compared our results more than 10 years, and it shows the hypertension resolution, dyslipidemia resolution. But I think what is missing is we always talk on those issues and we do not include another very, very important and very a factor which should always be included. And many of my talks have included, and that is the cancers. I think the cancers, as we all know, the world, we are seeing the more patients of malignancy appearing on the horizon, maybe because of the better diagnostic facilities or the better medical management and the surgical management. But still, we feel that it has been projected less than what we expect and what is the ground reality is. Tobacco, of course, tops the list of it, but obesity is only second to the tobacco consumption, because for decades we have been harping and promoting and also discouraging the tobacco use in all forms, may it be smoking, may it be tobacco in the pan or in the nasal mucosa absorption, or in the form of any type of product. So I feel that this is a good opportunity maybe, and it's a good platform to talk about the obesity as the one of the very important, of course, after the tobacco, as a preventable cancer. So we mostly talk about the diagnosis and management, but I think this point I would like to drive to our audience, that it is one of the preventable factor which can take away a lot of the problems. Now we see that commonly related cancers are post-menopausal breast cancers and endometrial cancers, and male, the prostatic cancers. If we see the post-menopausal, it's endometrial, colorectal, kidneys, thyroid, pancreas, and the list goes on and on and on. So, but we must also realize that the onco cancers should be given the importance. And one of the few importance, the list of the, practically all the malignancies are seen to be more prevalent in obese patients. However, when we talk about the 40% of all the cancers which are diagnosed in the US, we can contribute directly or indirectly obesity as one of the causes. And 20% of the cancer deaths in women and 40% in men are because of the obesity-related issues. Also here, it very clearly indicates that women who are obese are more likely to get the malignant angle to their diagnosis as well as the death. more severe the malignancy, as we see the population, more and more younger group of patients are becoming obese and morbidly obese and super obese. This again gives the importance that our younger generation who are going to get obese is likely to have more chances of malignancy if obesity is not managed properly. This is a little complex diagram. I know it may be a little difficult for us to really describe each and every aspect, but what I have tried here is the mechanism which is a direct pathways for this. And this is the cells of the fat cells which have got estradiol and inflammatory cytokinins and adipokinins imbalances, which is, we all know, is one of the major factors in producing the malignant changes in various parts of the tissue. It is not only the direct pathway, but also there are indirect pathways like insulin resistance and IGF and hyperinsulinemia, etc. So I think if you look at both the charts combined, you will agree that there are the direct methods and mechanisms which can produce the malignancy, and there could be the lot of indirect evidences also. Now, I think it is important that we always talk, as I mentioned, that bariatric surgery for improving the metabolic conditions. But I would like, in a forum like this, I think we have to emphasize that bariatric surgery and cancer reduction as a preventive method. And it is definitely much, much more needed in female patients as compared to the male patients. And it's to be emphasized on the younger generation rather than on the senior generation. Now, various studies which are available, and you can go through those studies, and as recent as 2020 studies, which very clearly mentions that 33%, up to 33% decrease in cancer incidence can be achieved by as compared to the obese patients. So if you compare the two groups of, one group is of obese patients, another is the normal weighing patients, up to 33% decrease can be brought by the bariatric surgery. Now, also to emphasize that bariatric surgery and cancer reduction is more relevant. It's not that only way, but it is definitely more relevant for estrogen-related cancers, very clearly the breast and the endometrial cancers. And again, I will repeat that the females are more prone for this as compared. When we talk about the cancer reduction, I think each 10% reduction, 10%, just the 10% reduction in the weight of a patient not only improves the metabolic conditions, but also reduces 10% chances, a 10% weight reduction reduces the chances of almost about 14% in causing the cancer that way. So these are a few aspects. I think only about 2% of the post-bariatric surgery patients will develop cancer, whereas 8.4 more than 8% in the non-surgical group. Now, we know that here we should see that how long the patient has been obese. The duration of obesity plays a very important role, and the lesser is the duration. So that clearly indicates that the patients who are morbidly obese or super obese patients, they should opt, or they should be given an opportunity to get their bariatric surgery at the earlier stages, rather than just waiting for years and years to get on to this. Now, the patients who are obese, if unfortunately they develop cancer, obviously it goes without, it's very logical and reasonable to understand that they will need more doses of chemotherapy, and they will need their outcomes are likely to be very, very poor as compared to the normal population. So I think it's now getting more and more endorsements and popularities that gastric bypass, one of the gold standard of bariatric surgery, has been proved over a period of time the most effective approach to the incidence of hormone-related cancers apart from other types of cancer. So this is the gastric bypass, and just by the way, I wanted to mention that in our institute, when we started the bariatric surgery in the country almost 20 years back, gastric bypass has been our gold standard. And in our team, about 95% of the patients bariatric surgery we do is the gastric bypass. It gives you a gold standard weight loss and reduction in the comorbid industries. And also in reference to today's discussion, we know that gastric bypass gives much better protection and management in preventing the cancer and also treating the cancer. Of course, in males, we talk about the prostatic malignancies, which we have already discussed. So melanoma, etc., I think I'm sure you are more familiar, though it may not be very common, the melanomas and hematological malignancies, but definitely this is something which we have to take the future vision. And as we know that we need to do introspection as a medical fraternity to give importance to the malignancies which are becoming more and more common. And we have been talking about the local treatment of breast cancer and the systematic management of the breast cancers. But I think today we should start thinking, and there are a lot of pointers which are talking that can the bariatric surgery be considered as adjunct treatment for at least breast, endometrial, and prostatic cancer in obese patients. So maybe I think in future, we will be talking about the bariatric surgery in preventing the cancers in one way, and also as an adjunct apart from the chemotherapy, radiotherapy, and other these things. And some of the data have shown that the 71 Roux-en-Y gastric bypass procedures are required to prevent one incidence of cancer. But however small or little it may be, it definitely is a very, very significant number. And I bring greetings for my team at Max Institute at Saket, New Delhi. And once again, thanking you about the opportunity for giving me this time to just speak a few words about the cancer and obesity. Thank you very much.
Thank you, sir. Thank you for a fantastic lecture. It was a very comprehensive lecture, which covered everything starting from the reasons why we think there is cancer. You mentioned about the inflammatory process. You mentioned about the hormonal changes. You also mentioned about the metabolic reset that the patients can get. You also looked at the amount of significant changes that weight loss is bringing up in cancer prevention. And there was a introspection to see whether bariatric surgery would also reduce the inflammation and probably give a better prognosis for patients who have already developed cancer. So that is one thing that we all have to look at. Patients, I just wanted to ask you, have there been studies of bariatric surgery being done for patients who have cancer, and have they fared better? Have they had a better results of cure of cancer or longevity after a bariatric surgery?
Ramesh, I think it's a very relevant what we are discussing today. And just to tell you that we at Max Institute at Saket, we have got a very important and very um, uh, uh, academic center of oncology under Dr. Harit Chaturvedi. And we have not been able to work in this direction, but definitely we have done a couple of cases in the past who developed malignancies, and where we did a gastric bypass. We have no comparison, but I think it definitely reduced the post-operative problems which they are going to face, especially in the initial stage 1 diseases. And we added gastric bypass to them after the conservative breast surgery, and reduced their weight. And definitely it helped them in, at least this is an observation. I would not be able to provide it scientifically, but it has been our observation that the doses of chemotherapy and radiotherapy reduces significantly, and definitely that reduces the side effects for them in coming, and also the quality of life once they lose about 20-30 kg of weight. Unfortunately added by the malignancy regime, definitely gives us a lot of encouragement to be a little more liberal with the management of such situations.
Yeah. Thank you, sir. That was a very good initial observation that you have made. I think that would pave way for more scientific studies in that approach. Are there any other questions that you would like to ask Dr. Chaubey? Anybody on the floor? So if we do not have any questions,
Thank you, Dr. Chaubey, sir, and Dr. Ramesh. It was a wonderful presentation. I deal with a lot of breast cancer patients. I really see clinically a lot of correlation between breast cancer and obesity in my clinical practice. So I am doing actually some study right now in last 3 years, whatever number of patients, total number of patients and total number of obese patients. So I plan to do this prospective study further, and I'll come forward with some perspective on this. But this was a really wonderful presentation, sir. Thank you very much. Thank you, Ramesh.
Yeah, thank you, Nanda. I think you've done a great job by starting giving an initiative to integrative medicine to give a holistic view to whatever we have been doing. Whether it's Dr. Chaubey, me, or you, we've all been technicians doing some technical work and developed our skills and done bariatric surgery. But in bariatric surgery, we have proved that long-term weight loss has a huge effect in reducing inflammation, resetting metabolism, reducing malignancies. So it would be nice to hear from you about your studies in future. It's very, very fortunate that Dr. Chaubey is amongst us. He's not just a leader to us, not just a leader in our country, being one of the rare Padma Shris of our country as a doctor, treated so many presidents of India and all the VVIPs, including Dalai Lama. But he has been the international president of Bariatric Society, the IFSO. And he giving his talk and sharing his wisdom has been great. We are really fortunate to have you here, sir. And thank you, Nanda, for such a great initiative.
Thank you, sir. Thank you all.
Thank you very much, Ramesh, and thank you, Nanda and Monica, for I'm sure I will wish you all the best for the studies. And if need be, we will definitely be very happy and delighted to collaborate with any of our studies which are conducted. I'm sure it will bring different dimension to the bariatric surgery and also obesity-related malignancy. Ramesh has been with us for almost 3 decades now, and his skills in training and teaching and his passion is greatly admired by the nation, and also internationally is renowned teacher. So thank you very much and have a wonderful academic event, and all the best to the organizers, and congratulations for such a great teamwork. Thank you very much and have a good academic event. Thanks.
Thank you, Dr. Chaubey, sir, and thank you, Dr. Ramesh. I think it was a very insightful session, especially as an oncologist. We all know that how important, we keep seeing so many obese patients coming with the malignancies. So probably, as we know that in prevention, we keep talking about risk reduction surgeries with genetic mutations and all that. Probably in bariatric patients, obese patients, this might come up as a preventive or risk reduction surgeries in future with the evidence coming in. Thank you, Chaubey sir. Thank you, Ramesh sir, for the wonderful session. We'll move on to our next session now. Next session, speaker for next session is Dr. Girish VB, who's here with us. He's going to be speaking on prevention of leukemias, lymphomas, and recurrence. He's a senior consultant hematologist and hemato-oncologist and BMT physician at Fortis Cancer Hospital, Bangalore. He's got an extensive experience of more than 14 years with more than 300 successful bone marrow transplant procedures done. I would invite Dr. Girish to take on the stage.
The moderator for the session is a very good friend of mine. We fondly refer to him as Professor. He's one of the smart Alex in the medical oncology and the hematology fora right now. And he's very well admired by his friends, colleagues, juniors, and a lot of lady counterparts as well. So, Dr. Vishwanath.
First of all, thank you for having this conference, and thanks for giving me this topic. When I heard the topic, I think I thought whether is there any way we can prevent it, but then I had to really search, and I found few things. So anyways, I'll not go into it, but there are few patients also listening to it. So for them, this is the slide, leukemia. And when there is abnormal production of white blood cell, we call them as leukemia. And there are 4 types: acute myeloid, acute lymphoblastic, chronic lymphocytic, and chronic myeloid leukemias. So if you see, generally acute lymphoblastic leukemia, they are common in the pediatric age group. Then AML, both in pediatric as well as adult. And there are a few cases of CLL where we see most of them in the elderly age group, more than 55 years, and CML generally in the elderly. But that's not true in India. These are the common symptoms which we see. Then lymphomas, it is a swelling of lymph glands. So how do we really differentiate? And these are the few key differentiating factors. Lymphoma being less aggressive and acute leukemias being more aggressive. So, okay, I can do that. Yeah. So there are basically there are few overlapping situations in this, and in leukemia, mainly they are less prevalent than lymphomas. They are defined as progressive and malignant disease of blood forming. So whenever patient comes, generally this is the question, why this has occurred to me, and we have to tell them few risk factors. There are few risk factors for these leukemias and lymphomas. So basically, we all commonly know that radiation, few infection, chemical exposures, previous chemotherapy history, genetic conditions, and smoking. But there are no proven methods for outright prevention of leukemia. But there are ways to reduce the odds that you might develop the disease. So there are few environmental factors, and we need to be aware about it. So there are some elements like benzene, which probably we do not know where exactly they occur, but they are found in paints, wood stain, varnish, then various solvents, some resins, glues, plastics. So whenever we see them, I think we should read some instructions on those bottles or packets. Then coal and petroleum combustion, the pollution, then cigarette smokes, all these are actually having some benzene in that, and which are probably getting inhaled, and when they are processed in your lungs and your liver, ultimately it went to bone marrow and causes certain toxicity which leads to acute leukemias. So avoidance is the best form of prevention, but this is not always possible. We are all exposed to it. So make sure that we read labels, follow precautions, and refrain using the products when children are present. Second important thing is formaldehyde, which probably we don't know where exactly these all are present. So there it is found in few of the baby shampoos, then some washes, eyelash glues, and some cosmetics. This one thing I found very interesting, that whenever there are this wood, MDF wood, which is commonly known, this has been used. This is a compressed wood. So this actually emits formaldehyde fumes consistently. And so definitely we don't know what is the amount and what exactly is the toxicity, but this definitely has some correlation with acute leukemias. Then there are these clothing line where these are all compressed and wrinkle free. Then there are some room air fresheners, some wallpapers. All of these are treated with alcohol while preparation, and they do emit formaldehyde. And this again has some correlation, and there is some clear-cut evidence that these formaldehyde emitting things may lead to acute leukemias, especially AML. Then pesticide we are all aware of. There are some home garden pesticides which have been found to be associated with leukemias whenever they are exposed. The children are exposed in utero. Young children exposed at home, adults exposed at home, or the people who are using it at the job. So these are the few things. Gardening chemicals, the chemicals applied for professional pest services, some fertilizers, some weed killers, some insecticides, some shampoos used to treat head lice, and flea killers for the pets. Then this radon gas, this has a clear-cut evidence of developing a chronic lymphocytic leukemia. The paper published in Future Oncology, this was a short communication. So they have found that a few of the houses in the US were having high residential radon levels. So FDA has given certain guidelines to control these levels and to bring down the CLL incidence in those regions. Then there are certain infections, EBV, HIV, HTLV, which all lead to certain kinds of lymphomas and leukemias. Last week, a paper published in Blood, a very recent one, where we have found that APML is also related to some sort of viron which gets in your body, and it stimulates PML rara. And most of the recurrences happening in a good risk APML also have some correlation with this virus. So this virus integration is stimulating APML recurrences. Then there are certain medical treatments where X-ray, CT scan, most of the patients do ask whether I do have a risk of developing some sort of leukemias or not. So the weighing and risk and benefit, we have to explain them. Obviously, the benefits are more than the risk. Then radioactive iodine, these have increased risk of leukemia, but it does not mean you should avoid radioactive iodine therapy. It should be the risk should be considered and alongside the benefits. So probably this patient might be monitored closely. They should be taught about what are the common signs of leukemias and should be monitored closely. Radiation therapy, chemotherapy, yes, but there are no option when the cancer is there. You need to take the treatment, but you need to monitor such patients closely whenever they are having certain drugs and toxicity related to marrow. So when we know these are the risks, there are few smart choices which we can make in the lifestyle. Probably you should read every time whenever you buy. There are some stickers there which can guide us whether these have any hazardous or any toxic chemicals in the product. Second thing is keeping good ventilation at home, using the right measures, using gloves, your mask at the workplaces, probably reduce the risk. Then there are few plants which commonly are kept at home. I found few plants which can actually help in removing benzene. So these are the commonly used household plants which we can have at home, and probably we can help them reducing the benzene levels in the house. Then these are for formaldehydes, probably money plant, Boston ferns. These are all commonly used plants, and we can use this to reduce the level of formaldehyde and benzene exposure which we have. So they have some figure given which I found in one of the articles where 15 plants for 2000 square feet house probably will be sufficient. So what healthy habits that can be maintained? So we know all these things are possible. This has been repeatedly told to the patient. Then so there are certain dietary things. This interesting paper which was published in Hematologica in 2018, they have found that Western diet has direct correlation with increased incidence of CLL in few of the patient, and changing it to Mediterranean diet probably will help reducing the risk for such patients. So food included in the typical Western diets are high fat dairy products, processed meat, refined grain, sweet convenience food, and high calorie beverages. These needs to be avoided. Then there is sucralose. This is found in most of the sweeteners which are available, and it has been found to reduce the number of bacterial flora in the gut, and then there is a risk of increased risk of lymphoma in such patients where they're using artificial sweetness. Then physical activity does impact, and there is around the study done for 1.4 million people. They found that more physical activity was strongly associated with lower risk. So almost 3 to 4 fold increase in the risk of AML and CML has been found with sedentary lifestyle. Then smoking, definitely there is a clear-cut association between AML and other myeloid malignancies, especially MDS and AML are quite common, and there are many studies which are there to prove. So most of the cancers which we came across are MDS and AML. Then HTLV, sex, and then no usage of syringes, especially the drug peddlers, they have these kind of infections and get most of the leukemias. Obesity, but not the overweight people, they have some incidence and increased mortality in patients of leukemia. So how do we stop? How do we prevent this? So there is no single cause, and there is no one size fits for all these people to prevent this disease. But we can avoid exposure to benzene, formaldehyde, both of which are closely linked to AML, which is quite deadly. So risk of exposure to these carcinogen is the greatest in the occupational setting. And then I'll just briefly touch about how to prevent the recurrence. Probably we all know the patients, whenever first present to you, you have to hit very hard, give right doses so that there are, we need to take down disease burden to the minimum level. So what we nowadays use is something called as MRD, which has been there for every disease. In acute leukemias, it's there. In lymphomas, now in myelomas, most of the diseases we are using MRD. So the moment you have disease, you bring it down to below detectable level. That is when they become MRD negative. The chances of relapse are further reduced, and probably if we maintain them in MRD negativity, there is a chance of cure. So this is a study before MRD detection. They used to relapse early. Now with MRD detection, we can intervene and we can give personalized therapy. to bring it down again, make them MRD negative so that relapse can be delayed or even prevented. There are few strategies for leukemias, especially in AML. These are all in post-transplant setting, the patients who have undergone transplant and we don't want them to recur. They are especially very high-risk groups. And these are few recommendations for FLT3 positive in high-risk patients and then MRD. We are using maintenance FLT3 inhibitors, then azacitidine, that is and then there are new IDH inhibitors which are going to come, and probably we can put them on this maintenance therapy whenever the patient are in a post-transplant setting or post-treatment setting, whenever they have some mutations. Thank you.
Thank you, Dr. Girish, for that very insightful talk. I think he's done a lot of research and he's done justice to this very tough topic. And especially those interesting ones like the MDF boards emitting formaldehyde and some interesting plans which you showed which can prevent exposure to benzene. Very insightful. And now the floor is open for discussion.
Thank you, Dr. Girish. In fact, when I was discussing to my team about this topic, Vishwanath said, "Madam, I don't think there is anything that can prevent," he said initially. This was super.
No, that's what I feel. That's why I gave the disclaimer.
Some of them refused to give this talk,
Okay.
and I must really compliment you for what you did. And one more correlation I want to ask you is, formaldehyde and benzoin is used very much in the surgical setup. You know, so the OT, the thing. I have seen 2 surgeons dying of AML. One is very well-known surgeon of Bangalore. And another one is my far friend. So have you seen any correlation between hospital staff, OT staff, clinic staff with AML? I think, okay.
Cardiac, especially the people who are using in the cardiac OTs and where these even some cardiologists, I have few cardiologist patients who have developed CML.
Okay.
Incidence of CML has definitely high in those populations.
Okay. Yeah. And X-ray technicians.
X-ray technicians.
It's known, right?
It's known.
Yeah, thank you. All right.
Ma'am, I have a question to Apsi ma'am. She's part of ICMR. So, ma'am, most of the times we see once we diagnose these patients, in the hindsight, we would have figured out these risk factors. So how do you think at an epidemiological, at the population level, how do you think we can reduce exposure to these chemicals and how do we go about? So it's very easy to talk about prevention, but easily said than done. How do we start?
It is very difficult to look at the environmental pollution. That is what you are telling. Because one thing is that most of the, I think Larissa said correctly, that prevention trials and collecting data for these cancer etiopathogenesis and all is very, very difficult because it's multifactorial. As Dr. Nanda said that surgeons are exposed to formaldehyde and benzene and all, but there are so many other shampoos and all those things also have. So there are so many confounding factors, but you could create a database and look at what Dr. Nanda said. See who are the people who are working in the OTs, or when you get leukemias, in that you can work on various, finding out various causing factor. That's what cancer is so multifactorial etiopathogenesis, very difficult to pinpoint. Yes, with great difficulty, they have managed to say tobacco is a cause. But still there are people who are telling why are non-smokers getting, see, like that. So it's a very tough job, but still you could create a database. All your medical oncologists and all who are treating hematologists and all, looking at what are there definitely etiopathogenesis? Like as he rightly said, you can look out for all these benzene products, formaldehyde products, and I think you can create. ICMR is now doing that pattern of care for leukemias and lymphomas. I think everybody is entering, but there, you know, in the pattern of care, we have not put all the etiopathogenesis like that. If all of you collaborate and create one, I think ICMR would love to help, especially NCDR. The present director is very enthusiastic at looking at all these things.
And Dr. Girish, what do you think about doing next generation sequencing? These days, these labs are coming up with NGS panels for high risk population. To figure out some driver mutations and all these things. What do you think about that?
Then again, see, it is a very costly test, and putting across at-risk population, yes, probably if they have some certain kind of, because it, as Madam said, it is multifactorial. We can't say ki, just because of benzene exposure or formaldehyde exposure, this is happening. Yeah, so the patient will be continuously correct.
Do a genetic profiling. I think it will become a very distressful thing. If you find some vague genetic thing, it will become very for the person.
There are no drugs which can prevent.
And
Sorry.
Girish, one more thing, yes, ma'am is now talking on integrated therapy. A lot of these cancers you're discussing are pediatric too, right? So we are planning to do one pediatric cancer prevention group itself for just an integrated therapy.
Okay.
So maybe
Probably
anyway,
that time, I think we need to know, take a proper genetic history, doing a genetic counseling, doing a prenatal testing, wherever we found some kind of a target mutation in the family, then we can say, okay, this fetus is carrying this kind of a mutation probably. But then again, it medical, legal and other stuff, ethical stuff also, because we are not 100% sure that kid is going to develop cancer in the future, because every mutation probably can be silenced, cannot be expressed. There are many things which are there. So we can't really pinpoint. For hemophilia, thalassemias, yes, we do know that there is a mutation, this thing is happening, we have to abort the fetus. But here in this case, we need further a lot of data. How many patients who are fetus are having this kind of mutation and developing disease? So probably need to go into details, collect more and more data, and then we can probably have some answer.
I think if there are no more questions, we can move on to the next session. Thank you, Dr. Girish.
Thank you, Dr. Girish and Dr. Vishwanath. It was a very, very interesting session, a very tough topic to have handled. You handled it very brilliantly. Thank you. Next topic, the speaker is Dr. P.P. Bapsi. Madam is one of the Bhishma Pitamas of medical oncology in India and in South India. So she has served as the HOD of medical oncology at Kidwai and was a professor at Apollo Hospital. Now she's an advisor at Apollo Hospitals. And she's also right now an advisor of Prameya Cancer Support Program. So where they use a lot of holistic therapies to use integrated therapies in cancer care. So Madam would be talking about holistic therapies to prevent cancer.
Moderator for session is our own dear Dr. Nanda. So I would ask her to come and start chairing the session. Dr. Bepsi, please take over the session.
At the outset, I would like to thank Dr. Nanda, Dr. Vishwanath for giving me this opportunity. One would wonder that after 4 decades, why have I branched towards this? It's a question for myself too. I thought that I would stop active practice of medical oncology and then look at other things which can improve the quality of life. In a busy 4 decades practice, I never looked at any unmet needs of the patients. And then with my good friend, Dr. Sandhya, we decided that we will create a program called Sahai for Women. Next. So what are these integrated therapies for cancer prevention? The first disclaimer I want to tell that cancer is multifactorial and it's very difficult to know which is really causing cancer. The second disclaimer is that I am not an yoga therapist, but I have gone into the research of yoga for about 6 to 8 months and looked how we could use yoga therapy for cancer patients. So with this, so don't think that I am a yoga therapist. I have done literature survey, did discussions with the yoga therapists, and then we decided few things for cancer patient. So cancer prevention, preventing disease occurring and recurrence, that is the topic given. And everybody has spoken about surgery, radiation, chemotherapy, obesity reduction, and all. And yesterday's topics were very interesting. Dr. Vineet Gupta and a young yoga therapist also spoke. They have done a lot of work. And Dr. Nagendra, Dr. Nagaratna in 1984, when I was running the chemo ward at Kidwai, we did the first study for chemo-induced nausea and vomiting. She was after us to integrate yoga into cancer at that point of time. And I remember going and giving few lectures to those yoga students at Dr. Nagaratna's place. So integrated therapies, what we are thinking are psychological counseling, yoga, meditation, diet intervention, physical therapy, music, dance, and art therapy. All these have a definitive impact on stress, emotions, acting on directly on the immune system. The framework, do we have evidence to incorporate in cancer prevention and management? That is the question today. I would like to address whatever the data which is available, I would like to discuss with you people. Next. So what is this holistic intervention? Treatment of the person as a whole takes into account mental and social factors and not just treating the symptoms of the disease. Next. So what are the prevention strategies? There is two group of patients, two group of people. One is cancer occurrence, trying to prevent before cancer occurring, lifestyle modification. And we know from ICMR data that in India, 40 to 60% are preventable. No tobacco, removing stress, improving immunity, physical exercise, and diet modification. Now, once cancer occurs and how to prevent recurrence. So the best will be a good surveillance. Our patients fall out of therapy. So compliance to treatment. Because of side effects, we might have to modify the dose. Controlling weight and obesity, try to remove stress and thereby improving immunity. Next. So we know already all the speakers have been stressing on environmental causes for cancer and primary prevention. We know tobacco causes 25 to 30%. Diet and obesity causes 30 to 35%. Infections 15 to 20%. And environmental pollutants. Next. So briefly, even though yesterday diet was dealt very well, just a little bit from my angle, how I have thought of diet and cancer. Let me reiterate few points. We know there are dietary carcinogens, aflatoxin, heterocycline amines, nitroso compounds, and polycyclic aromatic carbons. This aflatoxin and moldy food, way back in 1985 at Kidwai, we did one study on cancer esophagus, especially in the Gulbarga region, where they used to store rotis for a month, these ragi rotis, and they found that there was a mold which occurred, and that was one of the etiological factor for a little higher incidence of cancer esophagus in that area. Next. There are metabolic tumor promoters like insulin, estrogens, oxidative stress, inflammation, and IGF-1. So we know that these are existing and these could probably promote the tumor. Next. Everybody is very sure that fats and sugars are culprits in carcinogenesis, and they are culprits in several things, several diseases, cardiovascular and other diseases, diabetes, and so many other systemic disorders. So these two have to be controlled in our diet. Next. Again, diet and red meat. This has also been shown that they have heterocyclic amines produced during the cooking of meat are carcinogenic, especially those which are, grilled. And there were several controversies on microwave ovens. I think there are not definitive proof regarding microwave, but in Indian cooking, we use a lot of oil for all these red meat. And that could be a possibility, or directly cooking over coal fire along with oil could be very hazardous to the people. Next. Alcohol, again, it's a risk, moderate risk, but 10% if you drink a glass of wine daily. Again, they say that it's been well associated with colonic cancer. And there has been association of cancer of the mouth, esophagus, larynx, and throat cancer. The most important thing, most of the people who consume alcohol also take tobacco, smoking. So we do not really know who is the culprit. Next. Then we have a good news. There is tumor anti-promoters. We have folic acid, which can reduce the DNA damage to a great extent. We have antioxidants in our food, which can delay the DNA damage and reduce the promotion of the tumor. We have phytochemicals. We have low-fat plant-based diet. All these can be utilized in our regular diet so that they can act as anti-promoters. Next. Especially the phytonutrients, which helps in detoxification, acts as anti-proliferative, acts as angiogenesis inhibitors, immune stimulants, and these antioxidants have become very popular because of the recent pandemic. Next. So we have promotion in one hand and protection in the other hand. So a low-fat, high-fiber diet, adequate protein, adequate calories, whole plant foods, omega-6 was ratio between 6 and 3 in the ratio of 2:1, and physical activity all can have a protective factor for regular persons. Next. So you have to have a wellness thali, a balanced diet of fruits and vegetables, fiber-rich carbohydrates, protein, and fats. So this is the first part where we have to modify our lifestyle, our eating habits, so that we could prevent various cancers. Next. So this is just to break the monotony. The doctor of the future will give no medicine, but will interest his patients in the care of the human frame, in diet, and in the cause of prevention of disease. Next. Now, the other aspect, what does cancer do? It has a great impact on the immune system, stress, mood and psychological states, on the weight of the person, and other comorbid conditions. So if we remember this, then we can put various ways to prevent cancer. Next. So the question is, could holistic intervention help to prevent recurrence? By improving the compliance to treatment. As I told you, 40% drop out, and in other remaining, we try to modify the dose. That's because they have a lot of side effects and the quality of life is not good. So some try to break cycles and come back after a long break, both for chemo and radiation. Helping to cope with side effects of treatment and improving the quality of life is the most important thing, because our goal is patients should complete treatment at the proper time with a proper dose. Naturally, if somebody gets cancer, you can't say they are very happy. They will be having anxiety, depression, which often leads to discontinuation of treatment. They decide, oh, why should I take treatment? I've not done any harm, but still I got cancer. Where is the need? So such sort of anxiety and depression will need a good psychological counseling. Improving the energy levels so as to complete the planned treatment, removing stress interfering the internal milieu, and also improving the immune system. So let's look at how we are going to do it next. So we know that all these will require intervention. Oncologists and health professionals working with these patients recognize the need to intervene to break this vicious symptom of disease symptom cycle. Evidence show interventions decrease depression and anxiety and increase self-esteem and help patients to adopt an active approach, coping strategies. In addition, quality of life is improved, immune status, and thereby we improve the survival. Next. So stress management techniques. I think the first speaker, Vineet Gupta, mentioned so much on stress. So stress management techniques that have proven helpful include progressive muscle relaxation, diaphragmatic breathing, guided imagery, and social support. In our country, there is no dearth for social support. In a family, if one person unfortunately gets cancer, the whole family comes for discussion, and also sometimes it's a bit troublesome, but still there is a large family to support the patient. Programs before treatment have enabled patients to tolerate therapy with fewer reported side effects. Next. Now, as an oncologist, as a treating physician, we would always love to have evidence. So in these holistic therapies, what is a group of holistic therapies which have got evidence now and those which have got promising evidence? So present evidence is physical exercise, modification of diet, yoga, and meditation. Whereas promising evidence is music, dance therapy, creative art, and spiritual support. Next. Now, few studies which I would like to tell you is yoga reduces stress. Cancer patients and survivors experience stress similar to that endured by a military veteran. So an increase in positive emotions such as calmness and a sense of purpose in more than 50% of subjects have been proved with the following of yoga. Next. We have yoga and weight management. In addition to bariatric surgery, I think without any interventional therapy, probably yoga to a great extent can manage weight management. So there are studies which have told that obesity is a key, if not the largest indicator of both cancer incidence and recurrence. Next. Symptom management, as I told you, if we can improve the symptoms, then compliance will be better and thereby recurrence chances will be less. Next. There has been a study that effect of yoga on natural killer cells in breast cancer patient has shown that there is an increase in natural killer cells in the yoga group. Next. Then we have evidence-based studies of yoga and cancer. A cancer therapies that seek to strengthen the immune system are increasingly proving to be helpful in fighting a wide variety of cancers. Next. So we have your mechanism of action of yoga intervention. Depression causes abnormal diurnal cortisol variation. So if we could tackle depression, yoga is also known to modulate the neuroendocrine pathway and psychoimmune axis, thereby restoring the hemostasis. So we have some sort of evidence which says that yoga has got some action on the internal milieu. Next. So role of yoga is threefold in action. It could look at the symptom management, psychological status, mind and sound resonance. Several research studies have shown that it improves the quality of life, symptom reduction, thereby compliance of treatment is much better. Next. So this one thing as scientists, as treating physicians, we should understand that the relationship between yoga and science, ultimately science and yoga should not be seen as competing. While yoga and medicine provide very different perspectives on health and disease, viewing the world through both paradigms can help us to see reality more clearly and helpful to make more skillful choices. Next. The next most important thing is physical activity. Can I take a few more minutes? How does physical activity reduce the risk of cancer? It lowers the levels of sex hormones, prevents the high blood levels of insulin, reduces the inflammation, improve the immune system, and helping to prevent obesity. Next. So we have evidence to say that exercise and cancer risk has come down, especially several studies have been worked on breast cancer. Next. We have also evidence in colonic cancer. 43 of the 51 studies demonstrated decreased risk of colon cancer in the most physically active participants. Next. So what are the benefits of physical activity? We have the studies have shown in breast cancer, 42% lower the risk of death, colorectal 30% lowers the risk, and prostate cancer 33% lower the risk of death. Next. Is physical activity beneficial for cancer survivors? Yes. Exercise training is generally safe for cancer survivors, and that every survivor should maintain some level of physical activity. Next. Now coming to a lesser known dimension, the evidence available for the effects of art therapy, music therapy, and interventions in patients with breast cancer. I made Dr. Vishwanath to start this music therapy for adjuvant chemotherapy patients, and I think he's recruiting some patients on this music therapy and adjuvant chemotherapy. There are 20 randomized controlled trials, 9 studies evaluated the effect of art therapy, 11 evaluated the effect of music therapy. Definitely, they have been shown to improve anxiety, depression, pain, fatigue, and other cancer-related somatic symptom management. All this pushes the patient for better compliance for treatment. Next. So the overall results, art and music therapy show effective opportunities for breast cancer patients to improve the quality of life and psychological stress. Next. So next comes spiritual. There's always a confusion between religion and spirituality. Both are different sects. Next. So the impact of spiritual well-being is also associated with lower levels of depression, shown to promote better psychosocial adjustment for cancer and completion of treatment. Next. So finally, to prevent diet, exercises, sun exposures, smoking, alcohol, adopting various new things like physical exercises, yoga, all will add on to improve in preventing cancer and probably preventing recurrences. Next. So finally, I would like to conclude, holistic therapies play an undeniably beneficial role in disease prevention, recurrence, and progression. It is time to relook at strategies to integrate them in the conventional approaches to disease prevention and treatment. Next. We did a preliminary study from Pramaya. We have a group of people, yoga therapists. I had to take class to the yoga therapist because I don't want my patients to have fractures, and also sat, Dr. Sandhya and myself have sat and looked at what are the things they are going to advise patient. And a first study on 365 patients, we got the best poster award at European School of Medical Oncology in 2019. Next. Next. So I would like to reiterate, it's a multidisciplinary team management. It is like a symphony where each instrument is played harmoniously on the same score rather than same note. We might not have robust data as on date like we have for phase 1, phase 2, phase 3 clinical trial for drug, but prevention trials, as Larissa said earlier, it's very difficult to conduct. We have to integrate and see how best we are giving quality of life to a patient's compliance, trying to prevent cancer to a great extent. Thank you. We have now a longer program called Reboot Your Life, which is about 9 weeks intensive session. And we have recruited some 70 patients. We had to analyze the data. Thank you, Dr. Nanda. Thank you, Dr. Vishwanath, for giving me an opportunity.
In India, we don't have integrated therapy as a separate department. In USA, we see that. I had an opportunity to meet Dr. Gary Dung, who is HOD of integrated therapy in Memorial Sloan Kettering. And Samara Mahindra started one special company called Carer Group, especially to do integrated therapies. But it involves a lot of people taking care of the patient. You know, in group classes, if you do, we have started a group yoga classes for some of our patients at a minimum cost. But when individual physical treatment happens, it costs money for integrated therapy. Insurance doesn't cover it. That is becoming an issue. I think you brought down a very important point that we should make it as a part of our treatment in our setup too. I think integrated therapy should be a part of the department itself. I think we should train people for that. And thank you very much, ma'am. It was very motivating for us.
Only one thing I add, it's very difficult to bring this integrated therapy into a hospital. Many patients do not like to go back to the hospital. So in a neutral environment, it might be a better approach.
Ma'am, actually, one more thing I want to say, because two of my best friends, one who spoke on the stage also yesterday, they consulted this Dr. Gary Deng. One was a stomach cancer patient, and they're also thinking of giving high dose vitamin D and omega-3 fatty acids, some enzyme therapies from mushrooms tablets. He's been prescribed from Memorial Sloan Kettering. So are we different? How are we different? Because we know all celebrities going to Memorial Sloan and not coming to, because treatment is same. I'm sure whole world it is standardized. We have all drugs available. We can import most expensive drugs. Why are they going there for the treatment? Of course, maybe the setup and cost is so high over there. I found out because I was discussing to Dr. Gary Deng. I had an opportunity to host him for dinner. We talked for a long hours. He says, maybe Dr. Nanda, I think it is, we have this as a separate department. So people come to us. I think it is a separate total department itself, ma'am. You can put it in the medicine department, or, you need not put it in the as a cancer department or with affiliated with cancer, but it can be under medicine. People go to diabetologists, people go to, so they can go to integrated therapist. Maybe there is a scope for it. That's what I say. But yeah, yes, ma'am. I agree with you. Yoga now, we are doing as a Zoom classes for our cancer patients. Ruchika, who is a yoga therapist, she's taking classes for them. And actually, in my observation, the arm pain, back pain that my post-cancer surgery patients used to complain, that has reduced a lot. because I used to deal at least 3-4 months with arm pain, hand pain, give them pregabalin, painkillers. We do that round the clock. But immediately after 1 month of surgery, they start yoga class, and that pain has come down a lot, I think, in my personal
We have
experience.
in our sessions, we have a separate management of lymphedema care, pain, all that is, you've incorporated all that.
Yes, ma'am, it comes under integrated.
Thank you.
Thank you very much. Yeah.
Good morning, doctor. I have a question as well. Here, in front.
Oh.
Yeah. Good morning. This was honestly the bestest presentation that I saw and heard, and I'm so glad that I had the honor to hear you. Fantastic. I am short of words to say what you presented. Huge respect to you for that. And I just wanted to bring out about 2-3 points here. So I'm a yoga therapist and health coach. Water therapy also works wonderful, and simple ways of using a wet towel for the patients helps to relieve a lot of pain that they're going through. So probably water therapy is something that could be integrated for cancer patients as well. That is one. The second is also dealing with emotions, which plays a major role. Exactly. They have a lot of ups and downs in how to still be in the positive frame of mind with whatever they're going through. Unfortunately, we are taught how to deal with everything else besides our emotions. So that is a key learning, and that would really help the cancer patients, especially still living with a feeling of gratitude, which is lacking with most of us, actually. So I think these two things play a major role. And I had a question where you had the perfect thali, that the slide there. It talks about, again, there, dairy and, milk. Whereas the previous slide of yours talks about being on a whole food plant-based diet.
See, the vegan diet people are now following.
Yes.
We cannot totally adapt that to our people. And another thing, cancer patients during the therapy, I just allow them to eat whatever they want, because their appetite is low, they have nausea, they have vomiting. So during treatment, we never allow them, say, don't eat, drink milk, don't eat, take ice cream, don't take gulab jamun. I would usually tell them, take whatever you feel like, because post chemotherapy, I mean, it's miserable. When I used to treat in 1980, 81, we never had good antiemetics. People who used to see me in supermarket used to vomit. Such was because I have given them chemo. Just seeing me, such a psychological distress. So we have to adapt a thali for our patients, our people who are taking our diet. We can't just say off curds, off milk, very difficult. But there is data.
Absolutely.
That is there.
Yeah, because during chemo, the body is really weak. And then again...
No, that's what we allow them to take concentrated. They'll say, no sugar. They will tell, no, for diabetes, no sugar. They're not eating anything. We require calories. So during chemotherapy, we usually advise, try to eat whatever you feel like best. Try to maintain calories. Try to maintain proteins. Otherwise, we have to substitute. Chemo is not that easy at all. And if the dietitian, we always have a big fight with the dietitian. She will come and write high protein diet. That smell only patient will vomit. So we have to treat them individually. What is it there? What is happening to them? Okay, I think we are taking too much time.
Thank you very much.
Thank you, Dr. Babsi. Just to put in a word, we at BGS, along with the Sri Ayurveda, Vivekananda Ayurveda Samstha, we are doing actually starting off a study where we are looking at yoga prior to chemotherapy and yoga as a maintenance therapy to see whether there is any effects. And we are trying to look at the cellular and molecular aspects as well to see whether there's pathological complete response. So we're going to have 3 groups. True.
All that should be standardized for us to really assess.
Correct, ma'am. We are doing that first specifically for breast cancer, then afterwards for other different cancers, because we'll have a set of exercises for particular for this. Then we are planning to expand that. So that's something that's actually now started off along with SPOC, which we've been discussing in our groups as well. So we're looking for some exciting days ahead and where we can actually standardize this procedure as a during adjuvant or neoadjuvant therapy as well. Thank you. The next speaker.
So speaker for the next session is Dr. Santosh K. Devdas. He's going to speak on geriatric cancer prevention. He's Associate Professor and Chief Stem Cell Transplant Physician at Ramaya Medical College and Hospitals. I would invite Dr. Santosh to come over the stage for this next session. Moderator for the session is?
The moderator for the session is Dr. Meena Kodandram. She's a geriatrician and she's an executive advisor for the SPOC Foundation. She's a director of the MS Ramaya Chemicals and Fertilizers Private Limited. And she's also a part of the MSR Biotech Private Limited, which produces tissue culture plants that are disease-free and high yielding and also considerably reduces the cost of production. So welcome, Dr. Meena.
Good afternoon. Good afternoon, everyone. Good afternoon. Last few years, we have seen an exponential growth in aging population. And today with us, we have our eminent Dr. Santosh, who is going to give us a little bit information whether there is any correlation between age and cancers. Please, Dr.
Thank you, Dr. Meena. Thank you, Dr. Nanda and SPOC for giving me this opportunity. In the next 10 minutes or so, I would try to give you a flavor of what is happening in the area of prevention only in geriatric oncology. So geriatric oncology is a subspecialty of oncology, which focuses on treating elderly people in a better way. For regulatory requirements, a definition of old age is 65 years. However, we know that young people can be functionally not very fit and maybe not be able to tolerate treatment or maybe more sick, and vice versa. A older person may be very fit functionally, mentally, and do well overall in life. So as the population of the world increases, by year 2050, we'll have a population of 9 billion and over 1 billion population of people who are more than 65 years. And that is why it will be more and more important in future for us to really look into the problems of the elderly, both as a public health measure and also as a personalized care. With reducing incidence of non-communicable diseases, communicable diseases and improved care of non-communicable diseases, there is significant increase in life expectancy worldwide, and people are going on to live for more years compared to the past. The incidence of invasive cancer increases as one ages, as we all know, and the maximum incidence of cancer occurs between the ages of 65 to 69, and then later on it tapers off. Total number of cancers projected to increase from up to 45% in the next 2 decades, and 70% of all cancers will occur among adults aged more than 65 years. the lifetime risk of receiving cancer diagnosis is as high as 40% in a Western setting. And with the increase in number of and the lifestyle changes in our area of the world, even in our countries, the incidence of cancer would be as high as in the West in the coming future. So old age and cancer, as we know, are intertwined between both of them. If you look at the hallmarks of aging and the hallmarks of cancer, the commonality is genomic instability and increase in mutation rates in the cells, and also increased and sustained proliferative signaling among the cells, which leads to cancer in the elderly. So the United Nations and the World Health Organization has declared the coming decade as a decade of healthy aging. In 2020, for the first time in history, people aged more than 60 years outnumbered children younger than 5 years. And proportion of elderly is going to increase in the population from 1:8 at present to 1:5 in the year 2050. Because of these increasing numbers, the Geriatric Society of America did recently publish a series of articles on cancer prevention in the elderly, which was a kind of a neglected field for many, many years. One can prevent cancer or cancer death by various strategies. We could try to reduce the incidence of cancer as a public health measure. Also, try to catch them early and cure the early cancers and not let the cancer grow. We all know that once somebody gets older, there is a good chance that he develops social isolation and loneliness. And a famous neuropsychiatrist called Dr. Dilip Jeste quoted famously that optimism and social engagement are two pills that may increase healthy lifespan by up to 10 years. And social isolation and loneliness would definitely influence cancer risk by poor health behaviors. And there is also some evidence that pro-inflammatory gene expression pathways are activated by social isolation and loneliness. Psychosocial and behavioral interventions and increase in meaningful activity and social connection has a potential to slow cell aging and cancer development. There are various methods of meditation, which Dr. Bapsi was alluding to, and mindfulness-based stress reduction, cognitive behavioral therapy, relaxation techniques, and biofeedback, which have the potential to reduce the incidence of cancer. This has been extensively discussed regarding the reduction in environmental exposures, which one could strive to achieve, especially in elderly patients or people. There is one more determinant in elderly people as their place of where they live. People living in rural areas have poor access to various services, and increasing this access of better preventive services and better social conditions may reduce cancer risk. And definitely health literacy is something that improves access to health, better access to health literature, and understandable health messaging would definitely reduce cancer risk among the elderly. This is an example of very clear-cut cancer messaging wherein the person who is consuming the message understands the benefits of stopping smoking or tobacco cessation. So there is a huge area of need that organizations like SPOC or the government can look into to reduce risk of cancer prevention in elderly. There is a requirement for increased research and building healthy communities with better access to preventive services and environmental exposures, eliminate health disparities like urban and rural divide in access to healthcare, and better health literacy, evidence-based clinical and community preventive services with improved cancer screening and tobacco cessation services, and empowering people to make healthy choices. And one should not forget the caregiver concerns. Many would agree that taking care of a old mother is much more difficult than taking care of a young child. So this is something that one may have to address in also taking care of elderly people. There is a word called ageism, which means that people are discriminated only based on their age, irrespective of where they live or what social strata they belong to. That is also a huge hindrance to cancer prevention in elderly. Just because somebody is old, they should not be discriminated against in various ways by the society, and this would definitely reduce the incidence of cancer. In this area of ageism, this is a publication that study that we did last year, and we presented in American Society of Hematology, where we looked at the limited use of stem cell transplantation in a fit elderly patient in multiple myeloma in our center. When we compared patients of about 80 to 85 patients of multiple myeloma, patients who were aged more than 65, though they were as fit as young people, were offered stem cell transplantation less often compared to patients who were less than 65. And stem cell transplants were done in less patients who were more than 65 compared to stem cell transplants who are done in patients less than 65. However, what is interesting is, irrespective of the age, patients who underwent stem cell transplant, either young or old, did much better than patients who did not undergo the stem cell transplantation. Changing gears, I will talk a little bit of cancer screening. I know this has been extensively discussed in the last few sessions. There are 5 cancers which have shown to reduce the risk of where if you do the screening, there is a reduction in cancer risk. However, the elderly population may be neglected in all these cancers, and at some point of time, just because of the age, cancer screening services may not be provided to these people. However, the guidelines and the various agencies doing this, giving these recommendations, do advise to continue the screening up to age of 77 years in a fit patient for lung cancer, and up to 75 years in patients, in people for prostate cancer, and up to 84 years in breast cancer, and 75 years for colorectal, and up to 60 years in cervical cancer. I'll conclude with this slide. Population of elderly will boom in the times to come. Cancer in elderly is and will be a significant public health problem in times to come. There is a renewed focus in preventing cancer in elderly people, and prevention efforts include strategies to reduce social isolation, reduction in environmental exposure to carcinogens, better access, better social conditions, effort to improve health literacy, and avoiding ageism, and continuing the screening for cancers even in the elderly. With this, I will stop, and I thank the organizers for giving me this opportunity again.
Thank you, Dr. Santosh. Well researched and compiled topic. Of course, and you hit on the target when you said neglected population, ageism, discriminated. The only thing they say when you take an elderly person is he is well preserved, or you don't treat. You're past 70, why do you need treatment? Well said. I hope that the mindset of the oncologists and the patients change for good, and definitely from SPOC, we are going to address it. Thank you so much, Dr. Santosh.
Thank you. Thank you so much.
Dr. Santosh. Yeah. Very well spoken. So I have a comment. So according to the guidelines, cervical cancer, now they're saying beyond 60 years, you can stop screening. So what is your take on that? So I know you've dwelled on that, but.
Yeah, the lag period for developing cervical cancer is very long. So they've advised to stop the screening at 60 years. Unlike other cancers, which tend to grow faster, even after picking up early. So at 60 years, if there is no pap smear is negative, if the HPV is negative, it's safe to stop screening for cervical cancer. However, we should continue screening for other diseases which the screening has shown improvement in outcomes in terms of overall survival.
And one other question about what is your take on low dose CT scans for screening lung cancer? Lung cancer.
Definitely, the studies have shown significant improvement in outcomes if the lung cancer is picked up early in a smoker with more than 20 pack years of smoking, more than 50 years of age. We are yet to take this up in a big way, at least in our center, or I'm sure in many of the centers in the city or in the country. The lung cancer screening is something that is an area of need, and which needs more education of the society for us to for it to be more effective.
In this connection, in fact, in the last 1.5 years, during the COVID times, I saw through 3 or 4 patients actually who are diagnosed with early lung cancer. Otherwise, most of our lung cancer patients are diagnosed very late. 3 to 4 patients we diagnosed pretty early. It was incidentally diagnosed because the patient had COVID, had a CT scan just for COVID. So again,
that's true. That's true in our center also, that we've had suddenly a spurt of thoracic surgeries for lung cancer and adjuvant therapy referrals. Directly going to medical oncologist.
Santosh, do you like to create like a protocol in such a manner that, old age group, this investigations minimized to a certain extent where the cost effect is not there, cost burden is not there? And should we do that? You think like till 100 years, because nowadays people are living 90, 100 years. We don't have big protocols.
Yes, ma'am. We can look at one particular disease. We can choose one disease rather than looking at all the we can actually look at lung cancer and see if we can pull off a good screening effort in our country.
Thank you.
Santosh, one last question. Chemoprophylaxis has been a raging topic in cancer prevention last 10-15 years. Do you use aspirin in your patients to prevent cancer in the elderly? Is there enough data, and if yes, in which cancers?
That's a very good question. I didn't cover that specific topic of chemoprophylaxis. Aspirin has shown it's in a mixed way that it reduces the risk of colon cancers. However, the recommendations are not very clear. Guidelines are not very clear about using aspirin in everybody that we come across. Maybe, especially with somebody with polyps, you're a gastroenterologist. You could elaborate on that.
It is known that oxidative stress injury is known to cause cancer. We have a lot of proven studies now, how it changes the epithelial surface of the cells and how it will allow the carcinogens to get into the reach into the cells. So maybe aspirin reduces the oxidative stress because it's an anti-inflammatory and long term when it is given. So I see the connection here. Thank you.
Agreed, ma'am. Thank you.
Thank you, Dr. Santosh and Dr. Meena, for a wonderful session. We'll move on to our next session. Speaker for the next session is Dr. Sumita Shankar. She's Professor, Department of Plastic Surgery at Government Medical College, Guntur in Andhra Pradesh. She's going to be speaking on role of public awareness and hygiene in cancer prevention. So we would invite Dr. Sumita, and I would request Dr. Nanda to be sharing the session, to be moderating the session. Dr. Can we, Dr. Shankar, please come on the stage to moderate the session. Dr. Shankar is medical professor at ART Plus Center, District Hospital, Tumkur in Karnataka. So I will hand over the session to Dr. Shankar.
Good afternoon, everybody. It's a very important topic, the role of public awareness in cancer prevention. All Indians have witnessed an effective IEC from the nation's head. The yoga, what we are speaking, the diet modifications, what we are speaking, everything was limited to certain few people of the society. But a strong political commitment, strong government commitment since the Yoga Day. Our Honorable Prime Minister promoted yoga internationally through UN. Since that day, yoga has been dispersed into the community. Whatever come from the West, we accept it easily. And thanks to that initiative. Similarly, we have seen very good hygiene improvement through Swachh Bharat initiative, through Namami Ganga program. So education is the solution for all the problems. And through an effective education, IEC activity from the nation, from the government, a strong political and government commitment will be beneficial for asserting a behavioral change. Behavioral change is not a dramatic process which occurs in a day or two. It may take weeks, months, decades, some centuries. Hoping for that, I request Dr. Sumita Shankar and Dr. Limilia Jamir to take over this session. Thank you.
Thank you very much, sir. Is my slide visible?
Yes, yes.
Good afternoon, everyone. I'm Dr. Lima, and I'll be presenting today on behalf of our team. We are all aware about these terms, public awareness, hygiene, and cancer prevention. However, let us take a closer look today and gain new perspective. The word hygiene is derived from Hygeia, the goddess of health in Greek mythology. Goddess Hygeia is depicted with a serpent in her hand. As we all know, the serpent depicts the art of healing. Goddess Hygeia is also mentioned in the Hippocratic Oath. Hygiene also finds its origins in ancient, traditional, indigenous medicine of India, and the general hygiene practices are mentioned in Ayurveda as well. Hygiene broadly refers to conditions and practices that help to maintain health and prevent disease. Broadly, hygiene is practiced at the personal, domestic, community, or environmental level. Personal hygiene pertains to oral hygiene, maintaining clean nails and feet, bathing, washing hands after toilet use, clean clothing, and practicing cough and sneeze hygiene to prevent disease. At the domestic level, there should be clean air in a clean home, proper storage of food and water, proper waste disposal. And at the environmental level or the community level, there should be safe drinking water supply, sanitary housing and drainage, proper excreta and waste disposal, vector control, market of food outlet hygiene. However, poor hygienic practices can cause infection and then chronic inflammation, which trigger inflammatory pathways in the body, causing mutation and then cancer. As we all know, oral, lung, pancreatic, gastrointestinal, and several other cancers are caused due to tobacco, chewing, or smoking, with the underlying mechanisms such as chronic mucosal inflammation, periodontitis, and impaired mucosal defense barriers. Gastrointestinal cancers can also be caused due to intake of unhygienic food and water, which contain infectious agents and carcinogenic chemicals. Genital cancers are also caused due to poor genital and sexual hygiene, which may be due to infections with HPV virus or Trichomonas vaginalis. Cervical cancer, which is the second most common cancer among females in India, is due to poor hygiene, unprotected intercourse with multiple sexual partners. And we know that healthy vaginal microbiome protects females against these cancers. Therefore, steps should be taken in order to promote healthy and hygienic behavior. Circumcision has also been found to have a protective role in penile cancer. Coming to skin cancers, in India, there are some cultural practices and personal habits which cause these life-threatening cancers, such as prolonged and unprotected sun exposure, the Kangri cancer in Kashmir, and chronic wounds or repeated trauma causing Marjolin's ulcer. So what is the status of hygiene in India? As per the National Family Health Survey 5, the latest report, only 5 out of 18 states or union territories surveyed had 100% toilet facility in rural areas. The lack of access to water supply and drainage facilities are bottlenecks in both rural and urban areas in India. As we all know, the Government of India launched the Swachh Bharat mission in 2014 in order to enable a hygienic, clean environment in the country. What happened and what was reported and what was real at the grassroots? There was misinformation, misinterpretation, and people used some of these toilets as storerooms. So it's very important how we deliver our messages to the public. Some of these points can be that it should be relevant to the population, culturally sensitive, yet it should encourage change for the better, and it should be behavior change centered, not just a top-down approach. So it starts with awareness and then motivating the people and then taking action. Public awareness can be targeted at the individual level and with a group of people and then taking a mass approach. At the individual level, it can be through personal contact, make home visits, or through social media, sending messages, sending health promotion messages, and then it can be facility based. When there is a group of people that you would like to generate public awareness on, it can be through workshops, lectures, demonstrations, seminars, panel discussions, or through role plays at the local level. Mass approach, it can be through television, radio, social media, print media, audio visuals in public places, using folk media, public events such as these, screening camps, and finding role models such as cancer survivors, celebrities, public leaders who can take public awareness to the next level. So, coming to levels of prevention in the context of hygiene and cancer, I'll take you through very important steps where we can learn how to approach the public. So at the primordial level, that is before the emergence of risk factors for cancer, suppose there is no practice of tobacco chewing, but still the strategy should be at the individual as well as public level on civic sense or on healthy behavior. At the primary level, when the risk factors are present but cancer is not, that is, there are outlets selling tobacco or there are people who chew tobacco, the strategy should be mass awareness and targeted high-risk category interventions and awareness programs. At the secondary level, now cancer has been diagnosed, there is need to halt the progress with prompt treatment. So the strategy should be focused education, that is specifying the need for early diagnosis and treatment. At the tertiary level, now the cancer has progressed to advanced stages. The strategy should be to ensure hygienic practices in palliative care and rehabilitation through reconstructive surgery. So I'll take you through each one in the coming slides. At the primordial level of prevention, the risk factors are not present, but it's important to get people interested and go where the people are. Organize programs by age group or occupation, and there is a need to start young in schools or play spots where the children go out to play. And for other age groups, where the adults are in the parks or they watch television, in the movie halls, malls, workplaces, etc., conduct mass awareness programs. Among young healthy people, you can even organize marathons such as this depicted in the picture, or you can even organize occupation-specific events. The next step, primary level of prevention, This is when the risk factors are present, but cancer is not. People have started chewing tobacco. So as we see, in 2020, the government of India came up with new health warnings on tobacco packs as per the Cigarettes and Other Tobacco Products Packaging and Labeling Amendment Rules 2020. So these are the new images that the government wanted the tobacco industry to display on the tobacco products. Coming to the next level, risk factors are present, carcinogenesis has begun, but people are not aware, or they might be aware. The strategy should be early diagnosis and treatment. Like for example, in the case of cervical cancer, we must educate the lay public in the language that they understand. Allay fears and encourage women to get tested. We have seen that so many women are afraid to go for a pap smear test or even participate in the screening camps. However, the first step should be to speak in the language that they understand, make them aware why it's important to get tested. And also we can encourage survivors to volunteer in experience sharing, that it is not so scary and they can overcome the disease if diagnosed early and prompt treatment is taken. So a common problem of cancer patients is, this is a quote, "My family and village managed to raise resources for transportation to the city hospital and for my treatment, but I had no money left for food and accommodation. As we know, cancer treatment can take months at the hospital and people are left in dire straits. So there should be, services to provide additional services and related information to enable treatment adherence in order to prevent progression to advanced stages of cancer." So this is another level of prevention. So as we see in the image, inform patients about accommodation, educate them, and then also navigate them through the hospital or nearby services that are required, and also about the transportation facilities that are available in the city, so that they don't leave treatment midway, causing further progression of cancer. Coming to this tertiary level of prevention, this happens in advanced stages. So the strategy is usually to limit disability. And as we know that palliative care usually starts at this point, there is need to support the patient and the caregivers in maintaining hygiene, as their immunocompromised state can make them vulnerable to secondary infections and non-healing of ulcers. As we see here in the picture, what happens at this stage? Due to the tumor, reconstructive surgeries are required along with chemo and radiotherapy. So this image is of a reconstructive surgery conducted by Dr. Sumita. Now coming to some good news. On the flip side, hand washing was considered to be among the best preventive measures against COVID-19, and mass public awareness on hand washing, face masks, cough or sneeze hygiene led to nationwide uptake of hygienic practices, and public health people are really happy to say in this regard. However, sustainability of this behavior change remains to be seen. So the way forward, COVID-19 pandemic, post-pandemic, the immediate post-pandemic months is an opportune time for public awareness as people are mostly home and are receptive to listen. However, monitoring mechanisms should be available to sustain this behavior change, and there is need for intersectoral and interdisciplinary collaborations. Relevant research should be done in order to inform policy, and there should be continued advocacy efforts for legislation. Let hygiene become a way of life. I gratefully acknowledge the opportunity by Dr. Sumita for allowing me to present this. Thank you.
Thank you, Doctor. It's a wonderful, appealing session. The session is open for discussion. Any questions? I suppose no questions. I thank Dr. Limelia Zabir, Dr. Sumita Shankar, and Dr. Nanda, SPOC team for providing this opportunity to ensure there is no substitute for the public awareness in cancer prevention. So we should educate the public as they are the, as a mass public awareness definitely is our practice. Thank you.
Thank you very much.
Lemia Jamir, she was also the one of the speakers for the previous session. She is Assistant Professor, Department of Community and Family Medicine in AIMS, Guwahati. Now we move on to the next session.
So let's move on to the next session. It's my pleasure to invite my professor from Kidwai Institute of Oncology, Dr. Govind Babu, and who is currently one of the senior most medical oncologists in the country. And he's a consultant at St. John's Medical College and HCG hospitals. And sir is having a lot of awards and publications to his credit. And he'll be talking on family history of cancers. Is it significant?
Moderator for the session is Dr. Mahesh. He's a senior consultant surgical oncologist from HCG Hospital, Bangalore. He's also an oncoplastic breast surgeon and robotic surgeon. I would hand over the session to Dr. Mahesh to carry it forward.
I know, yeah. Hello, good morning, everyone. First of all, I would like to congratulate SPOC for conducting this unique program. I think this will help both the patients and also the doctors so they can understand the cancer and the prevention. And also, I would like to thank Dr. Nanda for involving me in this program. We all know that 90%, more than 90% of the cancers are sporadic, but there is a significant percent where the genetic risk factors plays an important role. So around 5 to 10% may have a familial history, and there can be the reason for cancer. It's evolving because we are identifying more and more genes. With the more research, more genes are being recognized. And we have important is when we are seeing a patient, we have to take a thorough family history because identifying the cancer syndrome, genetic risk factors plays a major role in either preventing or detecting the cancer at a very early stage. I think Dr. Govind Babu is a very senior medical oncologist and academician, and he is not available. I think we are going to present is a recorded video of his presentation. Kindly go ahead. Yeah.
So today I'm going to talk about the family history in cancers, and the question is it significant? So greetings to you from Bangalore. So what I'm going to do is give you 2 case scenarios, and then from there I'll walk you through why history taking is important. This case 1 is a 21-year-old lady with 3 weeks history of abdominal pain, which was associated with nausea and reduced appetite. She has a past history of asthma, social history, she's a smoker, family history, nothing significant. She was investigated for this and found to have malignancy, hepatic flexure lesion. Biopsy was taken, that came out as adenocarcinoma. So she is staged as stage 2B colon cancer, and the pathological staging is T4A-N0 adenocarcinoma. Now, the other case is another 35-year-old lady who has been seen for a breast lump. She's undergone a wide local excision and a sentinel node biopsy. And here, the important history is that her mother had breast cancer at 50 years and aunt had ovarian cancer at 60 years. So this biopsy comes out as triple negative breast cancer with some of the features which are significant. Axillary lymph nodes were positive. And because she had a family history of breast and ovarian cancer, she was tested for what is called a BRCA1 gene, and that was found to be mutant. So these two examples are given you because this underscores the importance of taking a family history. So this is how we look at recording the family history. This is the parents at the top, mother and father, and the next generation. If this is the affected person, then how the inheritance happens. And this is how we actually chart it, and this is called the pedigree chart. And this is an easier form of representing the same thing. Here the red one is what is the inherited one. This is from the male, and this is how the inheritance is charted, and this is what again we call as the pedigree chart. So this is what is important to record, because this is what we call as inherited disease. So this is just to show you what we mean by inherited disease, that we get chromosomes 23 from the mother and from father and 23 from the mother, and this is equally distributed among the siblings. And if we have one of the defective genes, that gets passed on, and depending on how this is passed on, we call it an autosomal dominant, autosomal recessive, sex-linked, and so on. So this is the basis for what we call as inherited disease. We have something called as the genetic disease. Again, this is to show you how the inheritance happens of the affected gene. And genetic disease is where the disease we know is because of the genes. So important thing for us to remember here is many cancers are genetic diseases, but all of them are not inherited diseases. So they can be sporadic. So when we look at various aspects of a disease, this is just to show you that there are several factors that are interlinked. And one of the important things is the genetic family history. So that becomes important for us to ascertain when we look at a patient, take the history and the importance of the family history. So this is what the US Surgeon General's Family History Initiative was. What the statement they made, that most diseases are due to interactions of multiple genes and environmental factors. Although we gain important new genomic tools, family history still remains highly relevant even today after many years. And family history helps predict risk for varied health concerns such as heart disease, colorectal cancer, breast cancer, ovarian cancer, and many others, including type 2 diabetes and surprisingly suicide as well. Yet, many people are unaware of relatives' medical histories, and many health professionals underutilize this information in advising patients how to maintain good health. So this is, do people care about family history? And this is a survey taken of over 4,000 individuals. 97% of these 4,000 thought that the knowledge of family health history was important, but surprisingly, only 30% actually ever collected health information from their relatives to develop a family health history. So one of the important papers that was published in New England Journal almost some years ago, but still is very relevant, and the title was "The Family History. This is more important than ever." This is a very nice paper, and I would advise, if you are interested, to go through this in detail. So now there are a large number of studies. I will quote a few of them to show you why this family history is important. This is a network of case control studies, and this was a network of looking at Italian and Swiss case control studies of 13 different cancer sites between 1991 and 2009, of more than 12,000 cases. And what they came out was that this paper shows several potential cancer syndromes that appear among close relatives and may indicate the presence of genetic factors influencing multiple cancers. So this is just to show you that it's important in oropharyngeal cancers, stomach and colorectal cancers, laryngeal cancers, ovary, breast, and renal cancers as well. This is another paper which looked at specifically characteristics of breast cancer and correlation with family history. And again, this was in over 10,000 patients. And this again concluded that patients with first-degree relatives having breast or ovarian cancers were older and diagnosed at later stage than patients with second or third-degree relatives with cancer. This is again showing family history and its relevance with age. This is showing different age groups, 40 to 44 and up to 80. And this actually shows that from 1996 to 2012, the family history is very relevant, whatever the age group of the patient is. So coming back to our two initial cases, these two cases exemplify a syndrome called the Lynch syndrome, which is seen in approximately 5% of colorectal cancers. And why is this important? Because if a person has Lynch syndrome, they're at an increased risk for other malignancies as well. And I have listed all of them here. So what is Lynch syndrome? It's an autosomal dominant inheritance syndrome, which involves the mismatch repair gene for the DNA repair. So this gene is important in proofreading DNA, and it picks up any mismatch that occurs during cell division. And if that is not repaired because of the absence of this gene, the abnormality gets inherited into the subsequent daughter cells, and that leads to tumorigenesis. So there can be different forms of this, and almost 40% of cancers are associated with this microsatellite variations, and microsatellite instability with high molecular signature of Lynch is associated, as I mentioned earlier, with several cancers. So this is some more details about Lynch syndrome, which I will not go over. So this is looking at cancer risk in Lynch syndrome. And this is specifically showing you the colon and endometrial cancers are the important cancers that are increased in Lynch syndrome. But this is a list of all the other cancers that are at a higher risk when Lynch syndrome is present. So we today look at something specifically called the hereditary breast and ovarian cancer. And this is again important because family history is in these two cancers are common, but in less than 10% of breast cancers and less than 15% of ovarian cancers, these are inherited genetic mutations. Like I told you earlier, cancer is a genetic disease, but all are not inherited diseases. So when you have this hereditary breast and ovarian cancer, these are inherited cancer gene mutations. So this BRCA1 and 2 gene mutations, which is responsible for an increased risk of breast and ovarian cancer, was actually put into forefront and limelight because of Angelina Jolie. I'm sure all of you know about it, which we fondly call it as Angelina effect. There are several other celebrities who are also having this problem. And because of these celebrities, this entity has come into limelight. And now there are more and more women coming forward to get this gene testing done. So this lady is Julia Louis. The second one is Jane Fonda. And the third one is Christiane Applegate. So it is not just Angelina Jolie. Many others, I've just shown you 3 of them. And all of them have actually come forward to fight for the cause for this BRCA1 and 2 effect. So characteristics of this BRCA1 and 2 is that there are multiple cancers within the same family. The age of onset is very early. Many of them have bilateral breast cancers. Synchronous cancers are present, and they're associated with malignancies in patients and the family members. And also, male breast cancers are common when these 2 genes are mutated. So these are what we call as tumor suppressor genes, by which I mean that if these genes are normally functioning, patients will not get cancers. But if they become suppressed, the tumor suppressor genes are not active, then they lead to cancer formation. So we today have understood a lot about these 2 genes, where they're located, what are their exact functions, and this is helping us in a large extent to help these patients with these mutations. So the cancer risk for BRCA1 and 2, ovarian cancer with BRCA1 is 60%, 59%, and BRCA2 16.5%. For breast cancer, BRCA1 is 60% and BRCA2 is 55%. Contralateral breast cancer is 83% for BRCA1 and BRCA2 62%. And also male breast cancer and prostate cancer are also associated with these 2 genes. So the other cancers which are associated with this BRCA1 mutation is cervix, uterus, fallopian tube, primary peritoneum, pancreas, esophagus, stomach, and prostate cancers. And BRCA2 is stomach, gallbladder, bile duct, esophagus, stomach, fallopian tube, primary peritoneum, and skin. So this underscores the importance of taking a family history, because if there are some specific clinical features which I've already mentioned, then it's imperative that we look for these two gene mutations. Now, testing for these gene mutations is very well in place, and these are some of the pointers as to whom we should test, when we should test. And management post-diagnosis is very important, but before we test, they must have a family genetic counseling. This is also important in surveillance prevention in terms of risk reduction surgery and considering what we today call as chemo prevention. And the implications for treatment for these cancers, chemotherapy is important. An important role is for what we call as platinum compounds. So with this important information that I've told you, let's go back and see what we can do to our initial two cases. So this patient underwent a genetic counseling, but he refused for any further treatment or any other counseling. In fact, here what is controversial is the adjuvant chemotherapy. If he had undergone genetic counseling and done some more genetic tests, maybe we could have advised this patient better. Now, coming to the second patient, the chemotherapy was the standard, but she had to undergo counseling. And the implications for this counseling was that consideration of bilateral mastectomy, salpingo-oophorectomy, and genetic counseling for family members, and the role of a newer group of compounds called the PARP inhibitors. So to conclude, documenting complete family history is very, very important. I think through the two case history summaries and their implications of how we go about and the data I've shown, I think it's important that family history needs to be stressed upon. It helps in making important diagnosis. It's important for treatment for the index case, including prophylactic therapies. It's important for counseling our family members. And as I mentioned, it seems to be one of the most neglected aspects in the history taking of for our patients. I think I have shown you why this is very important with two specific case summaries and all the data that is there in world literature today. With that, I think I will stop and thank you very much.
Thank you very much, sir. You actually covered most of the matter related to the genetic related factors. So it's very, very important because the family history is very important, because we cannot do genetic test on all the cancer patients because 90% are sporadic, but we have to identify those 10% who may have a genetic mutation. So it's very, very important. Even they behave differently also. Their presentation is different, and treatment is also, now newer drugs have come in genetically altered patients. So I think it was an excellent topic, and I think a lot of people will be benefited with it. Thank you, sir.
Thank you, Dr. Govind, and thank you, Dr. Mahesh, for chairing the session. We'll move on to our next session. Topic for next session is early detection of precancerous condition. Speaker for the session is Dr. Ravi Gaur. He's an oncopathologist and is a principal advisor, Spice Health, founder of Dr. G Path Labs in New Delhi.
And to moderate this session, I would like to invite my good friend, Professor Dr. Narsimaya Srinivasaya, who is a professor of colorectal surgery at Apollo Hospitals, Bangalore, and he also runs the Bangalore Bowel Care. Welcome, Dr. Narsimaya.
Thank you, one and all. Vasudhaiva Kutumbam goes the say. I think the world is one place, and the healthcare we provide probably should be on par with every aspect of geography. Living is one thing, living well is another thing. I think it is better to live well rather than live and not live well. This aspect is extensively covered here at SPOC. I think it is a much needed, timely organization which is putting the importance of alternative therapies, complementary therapies, lifestyle variation changes, and looking at practice of medicine as a whole. So congratulations to the SPOC team, Dr. Nanda, and the rest of the members. Psychoneuroimmunology. This is what was talked about in yoga. Much talked about, less practiced so much, at least in this part of the world where yoga took its birth. So rightly starting off with all this that is much needed for cancer care. Prevention is probably the best cure. And we have with us Dr. Ravi Gaur, who is a pathologist by himself and also an entrepreneur. Let us hear to him about how medicine, how pathology, how cytology can help us pick up the precancerous lesions and try and get an early cure or try and prevent these cancers. Welcome, Dr. Ravi Gaur. The platform is yours. Thank you.
Good afternoon, Dr. Narasimha, and it's my pleasure to be here at this very, very important event that is run by Society of Oncology for Cancer Prevention. And I think today this is one of the era when we get everybody talking about prevention of disease when it comes to infections and the COVID. I think this is probably a very important time for all of us to understand that the first and foremost thing, if you are aware and if you can of certain symptoms, and if you really know, how the cancers actually emerge, grow and present themselves, probably if you detect them early, if you're aware of what are the signs and symptoms and what is the the precancerous condition, probably this is a cure. Because that's in India, the biggest problem is about 60% of the cancer patient, when they come to the oncologist, they are almost like stage 3 and stage 4. But I think in the worldwide, it's almost the other way. Only about 30%, 40% people come to stage 1, to stage 3 and stage 4. One of the important, the mission of the oncology community is to make sure that the more and more people come to early stage of cancer and probably maybe the stage 0, stage 1, or even precancerous condition. Today, I'll be talking about what is a precancerous condition. So what is a precancerous condition? I think that's something that you define. A precancerous condition is a condition of lesion involving abnormal cells which are associated with the increased risk of developing cancer. It's not yet developed into cancer. They can develop into cancer if they're not attended well to. A precancerous lesion is basically nothing but a collection of cells from the body organs that may appear and to be the same as cancer cells, but may not have properties of cancer cells or metastasis and growing or creating a havoc and break through to the membranes and organs and spread to all other organs. That's basically a precancerous conditions are this collection of cells which appears like cancerous cells, but they really not have the properties still to break through. Clinically, there are many precancerous conditions, and I probably will just touch upon as we move forward from here. Now, what are the benefits of, I think before we go to the common condition, what are the benefits of early detection? I think prevention is the cure problem. Today, we are talking about predictive, the benefits of prediction, benefits of prevention, and of course, the early detection, and then of course, even early, the prognosis and early detection of the relapse or the cancer. That's equally important today. So benefits of early detection is cancer is large extent avoidable, and many cancers can be prevented because if we detect early. Because they may not pursue stage 2, stage 3, patient may not require some even therapy, and many a time they don't even require a surgery because if you just do initial treatment, they're taken care of. Others may be detected early in the development, treated and cured. If you detect in stage 1 and stage 0, probably cure is almost there. Millions of cancer patients should be saved from premature death and suffering if they have timely detection. Otherwise, everybody, probably most of them come to stage 3, stage 2 and 4, and they have a lot of suffering. So sooner is the natural history of the cancer detected, more effective the treatment is likely to be. And that's the important. That's the importance of early detection in cases of cancer. Now, what is the aim of early detection? Or how do we, as a pathologist, what we're really talking about, and as a community kind of a thing, spreading awareness. The aim of early detection is to detect the cancer when it is localized to the organ of origin. It is not gone beyond. If it is the skin, probably the superficial layer of the skin. If it's the GI tract, probably located to absolutely the epithelium or located right there, well circumscribed. and before it invades the surrounding tissue. And that's the aim of detection. And for some sites, to detect a precancerous lesion. There are two strategies for early detection I think we can follow. One is early diagnosis. Early diagnosis often involves the patient awareness of early signs and symptoms. Because patient is aware these are signs and symptoms, something like a breast lump, something having a regular non-healing ulcer or something. These are some symptoms. Probably they can patient aware of these things. Something he's having a lump, is growing slowly, is creating problem. It's a non-healing ulcer. Then they can go to the consultant providers, which probably looks into the examines and confirms the diagnosis by biopsy or whatever methodology and start the treatment. And secondly, these are the symptomatic, but there can be a screening of asymptomatic patient, apparently healthy individuals, detect precancerous lesion or an early stage of cancer. And that's where preventive health plays a very, very important role. The common precancerous condition, I think I like to enumerate because probably we may not be able to go into detail because there are so many conditions of many organs. The common precancerous conditions are, please go on to the next slide. Suppose one of the commonest things is the skin. We have the skin, I think, to enumerate the actinic keratosis, because there's something also called as solar keratosis, and because of the ultraviolet rays which is there. Then and second is the Bowen's disease, where the cancer is not moved beyond the top layer of the skin. It's more or less also called as in situ carcinoma, intraepidermal carcinoma. If it's detected early, probably there's a cure. And the disc keratosis congenital, this is basically can say a telomere disorders, which has got almost 3 is a kind of a symptom. We have dysplastic nail, lacy reticular pigmentation, chest and over neck. But I think all 3 may not be there. But these are the 3 common conditions of the skin, which if you detect and if you're aware, probably we can always take care of them if the biopsy or the diagnosis is done earlier. Coming next is one of the common thing is a breast carcinoma. Any breast lumps, I think we have Dr. Govind Babu spoken about the breast angelina effect. I think that's really there because there's a lot of awareness in the breast cancer. But if there's a nipple discharge, if there's a disfigurement, if there is a lump, even the smallest lump. So I think that's something, or go back to the doctor and you have a lot of focus is being placed by doing radiologists and the community by mammography or self-examination. I think, but in pathology, I think we have to be very careful. The fibroadenosis sometimes can lead to, not all, but about some few cases percentage of cases can lead to the early malignancy. Fibrocystic disease can develop hyperplasia, dysplasia, and endoplasia. Then sclerosing adenosis, this is something extra growth of the fat between the ducts, and that's something also can lead to, and this is basically, if the finding is a sclerosing adenosis in a lump, probably twice the risk of getting a breast carcinoma. So these are the one need to be aware. These are the pathologic findings and impression of the reports, the patient himself, and of course, I'm sure the doctors are aware, they have to do a close follow-up so that before the cancer is actually developed, treatment can be done and patient can be cured off. The common cancers in India is head and neck and oral cavity cancers. I think this is something which is probably one of the largest concern in our country, where of tobacco eating and a lot of unhygiene, dental, and they have the sharpened teeth. These are a lot of injuries keep happening on tongue and in the mucosal oral cavity. I think it's very important to go for all of us to go back, look into the mirror and see, and if there's any lesion or any abrasion or any abnormality on in the white or spot. I think these small lesions, they may be early, but they're very, chances are like oral submucous fibrosis, is the pathology diagnosis, erythroplakia, lichen planus, leukoplaskia, and of course, stomatitis nicotina, that's probably having recurrent ulcers and effect of the smoke, the nicotine. Then gastrointestinal, we have like Barrett's esophagus because of acid reflux, repeated kind of acidity, atrophic gastritis, colonic polyp, probably one symptom can be like when West colonoscopy is very, very common as a part after age of 50 years, but India, this is still not practiced. But anything, stool for occult blood, probably if somebody finds some kind of a symptom and stool on the occult blood in the stool, probably one must be investigated, and that can lead to very early detection of the colonic cancers, ulcerative colitis, Crohn's disease. All these patients who are suffering from, they should be followed up very closely for the cancer development. Respiratory, you all know, bronchial pre-ligament lesions and the lung, and it's already there. I think anybody who has got chronic cough, or maybe the smokers, they are absolutely very prone to develop the cancer. So I think a follow-up is very important. I'm not going to pathology part. That's long chapter by itself. Reproductive organs, we have cervical dysplasia. Cervical cancer is one of the common thing, which is a regular pap smear is the answer for it. Then vaginal intraepithelial neoplasms, anal dysplasia, especially HPV, can also be cause for this. Bowen's disease or erythroplasia, where this is the penile disorder on the penis, we can have any abnormality on the surface of the skin should be taken care of. Blood, regular blood test is the screening. CBC itself and ESR can work out. And probably you can always have monoclonal gammopathy of undetermined significance, which can progress multiple myeloma, myelodysplastic syndrome. And that is if you have this refractory anemia and MDS in early stage, is definitely good. Now, normal to cancer, pre-cancer to cancer progression, that's the journey what happens. We have normal state of, we have cells out here, then we have cells are growing from normal hyperplasia. Mild dysplasia, cell outlines are slightly disturbed. That's because, and once they're disturbed, they start growing haphazardly, and that's dysplasia. And finally, the whole stack falls and the cells start invading. That frontally leads into malignancy. Our aim is to have somewhere controlled hyperplasia, check into hyperplasia and mild dysplasia, and if at all, into carcinoma in situ. And that is probably a early detection can really help leading to further invasive cancers. Now, pathologically, cancerous lesions can range from benign neoplasm, which are tumors which do not invade neighboring tissues or spread distant organs. So, which involves collection of abnormal cells in one cases have increased risk of progression to anaplasia, invasia. So, it's hyperplasia, dysplasia, anaplasia, and finally. But sometimes the term pre-cancer is also used for carcinoma in situ, which is non-invasive cancer and is not progressed to an aggressive invasive state. As with all other preconditions, all carcinoma in situ will progress to invasive disease. That's very well aware of that. So let's focus on carcinoma in situ and dysplasia. Anyone have hyperplasia, we can detect. Now, the pathophysiology of precancerous lesion is, it's very clear. If cancer detected preceded by a clinically, normally cancer is preceded by a silent phase, during which oncogenetic and the epigenetic alterations accumulate. Duration of the pre-ligament phase can vary from cancer to cancer, from individual to individual. So it's based on the site to site even. So it's very, and again, it's all depends on the immunity also. One need to be very careful and have to monitor it very closely. Various pathology techniques what we use in cancer detection. I think the common gold standard is the, next slide please. The gold standard is the biopsy. Can you move on to the next? Yeah. Gold standard is the tissue biopsy. So histopathological criteria, I mentioned hyperplasia, dysplasia, degree of dysplasia, and of course, ultimately leading to anaplasia. It's the most gold standard which is practiced all across in oncology. The tissue which so obtained should also be kept and preserved because we use today for molecular analysis and provide much additional and deeper information that will be useful in malignant lesion early diagnosis. Now, this is tissue biopsy. Today, we're also talking about cytology and oral exfoliative cytology, or even liquid-based preparation and conventional smears and like pap smear. Cytopathology is basically examination of cells collected from surfaces obtained by smears or scrapings or washing or lavage, and by even final aspiration. It was the first design for cervical cancers early detection. And today, of course, is being used almost any lump or any even like breast lump secretions or FNACs or oral cavity, probably imprint smears are also being in open wounds. It's performed by using a cyto brush. We obtain the smear that includes from the deeper layers, and of course, studied slide is stained, immediately fixed, stained, and high cellularity. It's seen, and we can identify the cells. The cells obtained from explorative cytology can be used for molecular analysis that will be useful in malignant lesion for early diagnosis. Now, today, we also have, when we talk about computer-assisted analysis, brush biopsy, cytomorphometry. Again, the same thing we have done. slides are prepared, and of course, the computer analyzes them and comes with negative, benign, or positive or atypical. I think that definition is done by computer. After that, we can probably go back and go to pathologist and take his opinion. Now, this is the era of the genomics. We're talking about the cell-free tumor DNA testing is another technology which is now being used. But there are multiple questions. What is the firstly cell-free DNA? Cell-free DNA is the short fragment of DNA that circulates in plasma and other body fluids, such as saliva, lymph, breast, bile, urine, spinal, amniotic fluid, and all over. But there have been many questions to it. Can circulating DNA be detect an early stage cancer? Probably yes, but probably we need a lot of validation. Can it be used to distinguish between benign and malignant lesion? Can it be used to detect cancer screening programs, probably pre-detection or very early detection, defined risk population, and ethical aspect? These are all questions which are evolving. I think with time, a lot of work is going on. I'm sure next 5 years, we'll hear a lot more about this. Now, cell-free DNA testing, in conclusion, it appears to be feasible. However, there are numerous biological and technical challenges which need to be addressed. Large-scale studies need to be done. More knowledge of dynamics of ctDNA is required. The improved techniques that enable a broader analysis of various types of genetic aberrations are also need to be developed. A lot of R&D is happening. A lot of bigger labs, a lot of diagnostics, a lot of oncologists, oncopathologists are working together. And finally, developing a fine-tuned algorithm and standardization of protocol. I'm sure circulating free DNA is going to be a very, very potential tool for early detection or even pre-cancerous condition, which is nowadays they're using sometimes for prostate carcinoma, urine sample, oral cavity washings, and even, of course, BRCA is one of the things which is probably can example for it. Now, lastly, we talk about a lot of biomarkers. I think. Now, let's talk about biomarkers, not only in cancers, but also in the wellness. And these biomarkers take for all. I think this is my probably the last slide. Use of biomarkers are important from the screening point of view. Other things are almost multiple use. The emergence of the new biomarkers, basically what are coming out is the emergence of highly powerful omics technology. Maybe the backbone toward discovery of novel cancer biomarkers and panels, distinct advantages over the currently used biomarkers. And what are these omic technologies? We have something genomics, we all know. It's been very well practiced, and we work very closely with the oncologist as a companion diagnosis provider. Probably what we talk about DNA and other mutations, what's happening in the tumor, or otherwise in the hereditary cancer can be predicted. Early detection of cancer, early prediction of cancer, that's already been practiced with the new technologies, NGS and other technologies, which is evolving day by day. Epigenomics refers to the heritable changes of gene expression. They're not attributable to the alterational sequence of DNA. Proteomics is another area which is developing very fast, which is based strategic disease identification is considered as a dynamic and innovative tool that could confirm, complement, or quite often supply more elaborate information beyond which is obtained by the genomic transcription or epigenomics. Metabolomics is a cancer biomarker, which can be a metabolite, which is secreted by the tumor metabolic pathway or process and may be employed. And it is, I think, one of the very important technology through proteins. We can really have the biomarkers, which can that can be diverse as molecular, biochemical, physiological, and anatomical. And I think they can be very helpful in early prediction. All these markers have strong potential and can be now utilized for diagnosis to identify early stage prognosis, that means assess the lethality and prediction of patient response to treatment of cancer. I think that's with this. I'd like to thank everybody, and I wish we all work together. And I think the way Dr. Nanda and his team has put up this show together, I think it'll be a great way to go ahead. And thank you so much.
Dr. Ravi, thank you. I think it was a very informative session. Have we got time for 1 or 2 questions, or? Yeah, okay. We will open the floor for a couple of questions, Dr. Ravi. Anybody?
Hi, Ravi. Recently, Google started doing something called artificial intelligence in picking up the pathologically the precancerous cells and atypical cells in the breast cancer. Actually, that's where they started, but I think they're not progressing. What is the challenge and why they couldn't do it, and what could it be done as a pathologist who has so much experience?
I think yes, I think the good question you have asked, because there's a lot of work going on with the artificial intelligence. Because I think the biggest challenge today having the right kind of data and the genomic diversity probably this unless you have the right kind of data, and you have, because if you study one group of population, you have studied another group of population. Probably the way one population, because there's genomic diversity, there's environmental changes, there's a lifestyle and cultural practices, all put together. Maybe the one data set we have, the another data set they have, I think they probably will not be able to. And in any case, in healthcare, unless it is a perfection. So you really cannot say somebody has my data says 40% of risk of cancer or 50% of risk of cancer. Because if you tell somebody they're going to have a 40-50% of cancer risk, probably they will die because of the fear of the risk, not even forget about the cancer. I think that is the reason they put in hold, and I'm pretty sure a lot of work is going on probably. I am aware of that. So it's very important for the clinicians, the pathologists, and the patient together, provider, all have to put together data in a really systematic way. Because, and all kind of a population across geographies, because we have seen in our experience, what works in West may not work in our country. What works in East may not work in that other part of the country. I think this geographic or location-specific studies are very, very important, and that really helps to refine our data and come back to the. And of course, in any case, AI can never, there'll be an augmented intelligence. It has to work close in hands with the providers, diagnostic providers and the treatment providers.
Well said, Ravi. I think you're absolutely right. I think technology and tools, if they're in the hands of a fool, there's still technology and tools. And for patient decision making, as you rightly said, I think it's the clinician input, it's the multidisciplinary approach, it's the patient factors. Otherwise, these IT companies, Google, Microsoft, IBM Watson, would have cracked the pot by now. What happened to IBM Watson? Look at it, it's down in the gutters. So I think at the end of the day, clinicians cannot be replaced. I think the human intellectuality cannot be replaced. I think the clinical decision making still takes a very high stake when it comes to decision making. Any more questions? Okay, I will ask one final question and probably close this, Dr. Ravi. What are all the pitfalls you see in pathology when it comes to early cancers? What sort of pitfalls you come across?
I think if you're asking from the pathologist's point of view, biggest problem in my lab when the sample or something comes to me is the patient history. I think that's something the patient details are missing.
Fantastic.
So I think that's where I say I've been saying all pathologists should work closely and they should rename themselves as a clinical solution provider, work with clinician, not really behind the microscope, come in front of the microscope and talk to the clinical friend.
Absolutely. I think that is, you hit the nail on the box. See, I think without the history, I think we forget about the history, the virtual consults, the Google doctors, and not to forget the examination findings, not to forget talking between specialties, the dermatologists, the colorectal surgeons. I mean, so much has been talked about VI and AN, and we a lot of the times miss out on them. Polyp cancers, big dilemma. I mean, the inter-observer variabilities, the pathologists, what you say is carcinoma in situ is for somebody a high-grade dysplasia. For another pathologist, it's a low-grade dysplasia. I think the history, the risk factors, putting the story together probably is the most important thing. No, I think you are the watchdogs for what we do as surgeons. I mean, you guys do a phenomenal work. And if you do not have any questions, I truly will take this opportunity to thank you for this excellent session, Dr. Ravi. Any questions at all at the end? Let us all give him a good round of applause. Thank you, Dr. Ravi. Thank you for your fantastic.
Thank you so much. Thank you, everybody. I think wish everybody. Thank you. Bye-bye.
Thank you, Dr. Ravi and Dr. Narasimha for that wonderful session. So we move on to the next session. All of us will agree that radiologists do play an important role, an integral part of our cancer diagnosis and treatment, and also in precancerous conditions. So here we have a very eminent speaker with us, Dr. Govindarajan, who is the head of Onco Imaging at Apollo Hospitals, Bangalore, a dear friend of mine, an excellent radiologist, very approachable and very meticulous, and request him to give his talk on role of radiologist in detection of precancerous conditions.
Moderator for the session is Dr. KG Kalur. He's one of the senior most nuclear medicine physician with more than 30 years of experience. He's right now head of nuclear medicine department at Bangalore Institute of Oncology, and at CG, he's director of molecular imaging at CG Cancer Care Center. So I'll hand over the session to you, sir.
Thank you. Good afternoon. I thank SPOC and Dr. Nanda for inviting me to be the part of this wonderful scientific deliberations. And we know in our day-to-day practice, cancer is usually detected late. Moment it is detected late, it has a lot of morbidity and mortality. Is there any way we can detect it early so that the scenario will change? And to talk about this, there can be always a precancerous condition. Suddenly it will not become stage 4. It will always start early. So is there any way as a radiologist, we can detect it early so that it can make a lot of difference for the morbidity and eventually the mortality of the patient? To talk on this, I invite Dr. Govindarajan, a good friend of mine. He is one of the top radiologists of the city. He's the head of Apollo Hospital now. Stage is yours, Dr. Govindarajan.
Thank you, Dr. Kalur, for those kind words. The topic is role of radiologist in the detection of precancerous conditions. The preamble is well set because the previous speaker talked about technology and artificial intelligence. Of course, artificial intelligence is actually taking over natural stupidity of our human beings. So So there are three things in this. One is cancer, pre-cancer, the other one is imaging. Cancer definition, we know. Pre-cancer is the one we want to understand. That means as a radiologist, I want to know if I see something, it will invariably become cancerous. At this point of time, it is not cancer, it will become cancerous. That means I am seeing this lesion and this is invariably going to become a cancer irrespective of the conditions in the body, unless it is taken out of the body. So now I need to look into this lesion on imaging because I'm a radiologist. I believe in seeing. So now what are the factors that are the variable factors associated with these cancers genesis? Time, place, and the unloved one, which is the carcinogenic agent. All these factors are not very, very particular or specific for each cancer. It's very, very variable. So as a radiologist, I am really not very well versed with these things. And also the carcinogenesis is arising at the gene level. It's all about the balancing between the TR genes versus regulatory genes. Again, why I have put up this slide is when we know that we can identify some precancerous conditions on imaging, we know that those precancerous conditions are already quite advanced when we compare it to the genesis of the whole process. These are some of the precancerous conditions which are known. However, as a radiologist, we don't look into all those things because we can't see them on imaging. So there are very few conditions where a radiologist looks into those lesions and says, yes, this is a precancerous condition. There are two categories in this. One is a radiologist is actively involved in chasing down those lesions, as in these validated screening tests where breast cancer screening is very well documented. Lung cancer screening, yes, of course, it's very useful, particularly in high-risk people. Colorectal cancer, again, there is a significant role of screening CT colonography. However, the maximum effect of a radiologist in detecting precancerous conditions is actually when we detect those incidental lesions when the patient comes for some other scans, not exactly related to a particular cancer. A patient comes for PET CT scan for a colorectal cancer, I identify a polyp. Or a patient comes for staging CT scan for a breast cancer and identify a pancreatic tumor, which is a precancerous condition. So this is the place where a radiologist plays a huge important role or impact on the patient management, because most of those, for example, pancreatic cystic cancer tumors, they are precancerous to start with. They have got a range of 15 to 30% of cancer
progression to cancer in some of those lesions. So if you don't recognize those conditions, patient is going to go for a big problem. So breast, as I said, very well documented screening protocols are available. We have got mammography, digital breast tomosynthesis, ultrasound, MRI, different tools. Biopsy is, of course, the mainstay. Positron emission mammography is one of the recent additions, even though it's not routinely used for screening. So what do we identify in breast screening? Patient is not a patient, actually. The asymptomatic person comes for screening mammography. I identify some tiny microcalcifications here and zoom it up. We know these calcifications are suspicious and biopsy is very, very important. The biopsy shows DCIS, that is ductal carcinoma in situ, high grade. Another example, a patient, high risk person, the patient has got a family history of breast cancer. So screening MRI is done. Screening breast MRI is performed, showing some amount of enhancement in one particular area. We use all our kinetics and other technologies to assess whether it is malignant or not. In this case, it was not showing to be an invasive cancer, but it turned out to be ductal carcinoma in situ again. So now what will happen if these ductal carcinoma in situ lesions are not treated? If it is high grade, more than 50% of them become invasive cancers over a period of 5 years. If it is low grade, less than that percentage will become cancerous, but over a period of prolonged period of time, up to 40 years. So the idea is to detect these lesions before they become mass forming lesions or before they become invasive cancers. That's the whole idea of identifying them. And some of these lesions may not be fitting into the diagnosis of precancerous, but particularly the fibroadenoma one. But we have seen on occasions fibroadenoma turning on to cancer. But the theory there is that a cancer is developing adjacent to the fibroadenoma and engulfing this. So when you are seeing a fibroadenoma, better to follow it up over a period of time. These are some of the examples. As I said, many of these lesions look similar on imaging. But one thing which is common to all of them is all of them require biopsy and or surveillance. So screening aimed at detection of DCIS or early invasive cancers. Imaging features help in identifying an abnormal focus for biopsy guidance, help in targeting biopsy, as I said, and also they help in monitoring those cases. Let's come to lung, where again, it's validated to have screening, CT scan screening for lung cancer. Low dose CT scan is performed. Here, again, this AIS, that is, adenocarcinoma in situ or minimally invasive adenocarcinoma, these are the ones which we do not routinely come across. However, these are the precancerous conditions. The main difference is in the size. So CT scan shows either a small ground glass nodule or a nodule surrounded by ground glass opacity or a proper nodule. The moment we see these lesions, if it is more than 8 millimeters in size, we have to go for further imaging like PET CT scan or a biopsy. If they are smaller than that, we follow them up. Follow them up to know if they are progressing for a period of 6 months to 1 year. So colorectal cancer is another area where screening is recommended for those who are beyond 50 years of age. Screening using CT scan is performed for CT colonography, which is an equivalent of colonoscopy, which is conventional colonoscopy, which is an invasive procedure, whereas CT colonography is a non-invasive procedure. Whereas other precancerous conditions like chronic inflammatory disease like ulcerative colitis and Crohn's disease or hereditary syndromes, generally we don't screen them for as images, we don't screen them. However, polyps, yes, we do screen them. When we use the CT scan for this particular test, which is called CT colonography, we prepare the patient and look into the lumen of the colon as though it is a real colonoscopy picture. It's a very non-invasive way of looking at the entire colon of a person and identify if there is any polyp. If there is a polyp, colonoscopy has to be performed and taken out if it is more than 10 millimeters in size. So it's a very simple technique, but very useful one. The benefit of this CT colonography is that apart from looking at the lumen, we can also look at extraluminal area, which is not possible with CT colonoscopy. Conventional colonoscopy. And also the non-invasive nature itself is very, very appealing, because nobody wants to put a large tube into their rectum and looking at the images. The flip side of this CT colonography is that unfortunately it uses ionizing radiation, and also it cannot take this biopsy sample from the polyp. Apart from this, as a screening tool, this is a wonderful technology. Now, MRI can also detect these kind of polyps. However, MRI is not recommended as a screening tool for colonic polyps. Occasionally, incidentally, we radiologists come across some of these pictures. This is a patient of rectal cancer, came for staging. We identified some uptake in a sigmoid colon. Then when we see the CT scan picture, there's a well-defined filling defect in this region, which is a polyp. Benign polyps take up a lot of activity. So the moment I identify this, a colonoscopy can be performed and the polypectomy can be done. And if it's a villous adenoma, again, it has got a high potential for becoming a cancer. So as I said, CT useful for measurement of the size, identifies the lesion site as well. It can identify extraluminal components, which is not possible to assess by conventional colonoscopy. Of course, it uses ionizing radiation, which is a limitation. Other areas where incidentally we come across precancerous conditions are in pancreas. For example, this is a patient, CT scan was performed for some other purpose. A patient with breast cancer, CT scan was performed. Unfortunately, the patient had a lesion, a big lesion in the pancreas, which was asymptomatic. Now, we have to identify whether this is a serous cystadenoma, which has got a 0% malignancy risk, compared to a mucinous cystadenoma, which has got a very high risk of malignancy. Similarly, there are other cystic lesions in the pancreas, like for example, intraductal papillary mucinous neoplasm, which has got variable degrees of malignant potential, depending upon whether it is side branches or the main branch, or even pseudo mucinous tumors. Sometimes we come across carcinoid tumors. Carcinoid tumors, generally, we don't categorize them either as benign or malignant based on imaging. However, sometimes, as in this case, we can tell them that it is more of a low-grade tumor. This is a person who was a potential liver donor for her husband. During the workup, she was diagnosed to have a lesion, small focus in the pancreatic head, suspected to have a neuroendocrine tumor. We did a Dotanok PET CT scan, which is very, very specific for neuroendocrine tumors, and it confirmed that it is a neuroendocrine neoplasm. And the biopsy was performed. This grading was given as 1. So it was a benign type of neuroendocrine tumor. Even though imaging is not used for categorizing the grade, many times we can tell whether it is low grade or high grade because of these uptakes. Other areas where it is not exactly a malignant tumor, but it is a borderline tumor in ovary, for example. However, unfortunately, I cannot differentiate between a malignancy and benign lesion or a borderline tumor. The moment I see this kind of a picture, it has to come out by surgery. Barrett's esophagus, another common condition. Almost 15% of them will have 15% of the patients with GERD, that is gastric esophageal reflux disease, will have this. The most important factor here is there is a 30 times lifetime risk of adenocarcinoma in these cases, although the annual risk is very, very less, 0.1 to 2%. We as radiologists occasionally come across these conditions when we do double contrast barium study. So as in this case, it's a very, very clear-cut finding. Of course, the moment we identify this, endoscopy should be performed and biopsy should be done. So to conclude, the carcinogenesis process and the carcinogens, they are poorly understood. Many proposed pathways are available. Radiologists helps in a few of those conditions. Majority of the screening tests, which are already documented or recommended, are aimed at identifying early cancers rather than precancerous conditions, except in the case of colon polyps. However, major role of radiologist is actually in identifying those precancerous conditions which are identified as incidental lesions when the patient comes for some other scans. Biopsy and follow-up is recommended in almost all these cases, and most precancerous conditions, as I showed you in some of those pictures, have similarities in appearance with those of cancerous conditions, and specific radiological features have to be evolved out of these studies. Thank you very much.
Thanks, Govindarajan. Any questions? In our day-to-day practice, I think we see a lot of incidentalomas when we are doing a PET scan. I'm telling you the routine practice. We do pick up incidentalomas which are metabolically active, and we bring it to your notice of the clinician, and it is usually detected. And they usually come for some other malignancy, and we pick up another malignancy, or very rarely it may be a solitary finding. And there are, of course, many screening procedures which Dr. Govindarajan has elaborated very nicely. And any other questions? Dr. Govindarajan will be happy to.
Gastroenterologist. We have a lot of liver patients who have small lesions in the liver, and they undergo CT and then MRI. And then at the end of the MRI, say for ultrasound correlation. So do you think we are underutilizing ultrasound for characterizing these lesions?
Yeah, to a certain extent, I would agree with that. But the problem with ultrasound is when we do a routine ultrasound, it's more of a screening test. When we are recommending a correlation with ultrasound, it's more of a targeted test. Same thing happens with breast ultrasound. Routine breast ultrasound, we might not see certain lesions. When I do an MRI, I find a lesion. Rather than doing an MR-guided biopsy, I would recommend a relook ultrasound. Similarly, liver lesions can also undergo these stages. So I won't say we are completely underutilizing the ultrasound. The scenario in which the ultrasound is ordered, so that makes all the difference. So if it's a relook ultrasound, yes. In ultrasound, there are limitations, like it's in the next to the dome of the diaphragm, or it's somewhere very inferiorly placed or very posteriorly placed. To look at those lesions, it becomes extremely difficult. So if it's a targeted lesion, yes, additional efforts can be made there to look for those particular lesions. A routine ultrasound, there is a high chance that we might miss. So that's the answer.
If there are no more questions, we'll close this session. Thank you very much for this.
Thank you.
I'll talk about Dr. Ashwini.
Thank you, Dr. Govindarajan and Dr. Kallur, for a nice session. We'll move on to our next session. A speaker for the next session is Dr. Siddesh. He's a former professor and head of the department, JSS Medical College, Mysore. He's right now a medical director, endoscopist, and a laparoscopic surgeon at Sigma Hospital in Mysore. He'll be speaking on stomach and pancreatic cancer prevention and detection of precancerous conditions.
The moderator for the session would be Dr. Ashwini Kumar Kudri. He's a GI surgeon and right now heads the Department of Gastroenterology, Gastrosurgery at Narayana Health. He was formerly at MS Ramaya as well. He's very, very famous and is very good senior colleague of mine as well. Please come. Welcome, sir.
Thank you, Dr. Rajiv, for his kind words. And I thank SPOC and Dr. Nanda for the invitation. I invite Dr. Siddesh to deliver his talk on a very difficult topic, I feel, is stomach cancer, stomach and pancreatic cancer prevention
and detection of the precancerous condition. Dr. Siddesh.
Well, good morning, everybody. I think we are running late. Am I audible, Chairperson?
Yeah, you are audible.
Yes, thank you. You can see my slides, I suppose, right? So we are running late, I know. So I'll try to keep it short. But my chairperson has already warned me it's going to be a difficult topic. That topic, I was looking at making it simple and short. And let us leave it to the discussion of the hall if there are any queries. We have very eminent people there to contribute. I am not a trained oncologist or an oncosurgeon, but my primary area of interest is endoscopy and GI surgery for long been my practice. And now that I have taken up additional responsibility of being elected as the president-elect of the Association Surgeons of India, I'll be taking over the office in December 18th or 19th. So I will have this part, what Nanda has really taken up a challenge. Today I can see she has done a wonderful job. Kudos to her team and her having organized such a wonderful conference. And we had an opportunity to listen to so many stalwarts and putting forward their views in the cancer prevention and early detection and various other things. So I take this forward to congratulate her and ask her to take up this continued job at the ISI so we can formulate probably to make a national registry of at least certain diseases. They have a very good group of surgeons group, which Nanda is a part of it. They can take it up as at least creating a registry of breast cancer at the ASL level. So let us see where we can proceed with this. I thank the organizer for giving me this opportunity to share some of my views about stomach and pancreatic cancers. Now, I had during my postgraduate days in Davangere when I was doing my MS way back, there was one very interesting study which was brought forward by one of the volunteers group headed by one Dr. Hiramat, who with some of the doctors who are there in Davangere, they conducted a study of two cohort groups, one in the upstream of Harihar and one in the downstream of the river Tungabhadra, where the effluent of the factory, which was located there, Harihar Polyfibers, which was directly pumping the effluent into the river. So the village down with a similar number of population, with all other habits being remaining same, cultural, social, dietary habits being same, they found that the incidence of both stomach GI, upper GI cancers was very, very high prevalent and in the downstream village, which I vaguely remember. And this study really made an impact at the level of the government to implement certain rules which can regulate the release of effluent from this. So what I just wanted to say is that, you see, we as clinicians see at the other end of the spectrum of this disease, how best we can detect them early, how best we can treat them effectively, having detected. So, well, the other end of the spectrum, we need to be looking at where our government and policymakers should involve actively the experts, what Nanda has brought forward onto the platform in bringing down the incidence of cancer at the society at the other end of the spectrum. So these are my initial views. So coming to the topic, gastric cancer is one of the most common cancers worldwide. And the mortality remains high in spite of the advancement which we have achieved in endoscopy, operative techniques, and detection of early the precancerous conditions, etc. Early detection, as been told by many of my predecessors in this meet, is the only way to decrease the morbidity and increase survival. Our goal should be to identify precancerous conditions and treat them effectively. Let us just briefly look at the risk factors. Like any other cancer, gastric cancer has multifocal in pathogenesis. It has both environmental and genetic factors playing a role. If we look at the migrant population to the West, the incidence of gastric cancer almost remains same in the migrant population as that of the country of origin. But their subsequent generations, siblings, they are found to be having an incidence almost matching to the host country. So this always says there is a strong environmental factor as well, in addition to genetic factor, which plays a role in causation of these cancers. Familial predisposition has been found to be causative, been significant factor, whereas these are associated because of the common dietary habits, high incidence of H. pylori in familial atmosphere. And when it comes to the H. pylori infection itself per se, it is the metaplastic polyps which have been associated with higher incidence of malignancy, where they are infected with H. pylori infection, associated with H. pylori infection. Familial adenomatous polyposis and hereditary non-polyposis colonic cancers have been associated with increased incidence of gastric cancer as well. So they come into the high risk group. Of course, the diet, which has been already highlighted by the earlier speakers, so they play a major role. Pernicious anemia, smoking, and alcohol again been highlighted by a lot of speakers earlier in the day today and yesterday. I don't want to touch upon that. As a surgeon, I will definitely say partial gastrectomy status and a bypass gastrojejunostomy, a patient having undergone. See, in my student days, we used to see for benign peptic ulcers, a lot of these surgeries being done. If these patients having followed up over course of 15 to 20 years, they fall into the high risk group. Fortunately for us, we have understood the pathophysiology of benign peptic ulcer disease. It is an infective etiology, and they are now being treated adequately early with the advent of endoscopy also. This part of the risk factor of gastric cancer has gone down drastically, even in our country. Now coming to the gastric cancer pathophysiology, we know that it is of essentially two types, intestinal and diffuse, though it appears that they have a different pathway of origin, but there are a lot of common things. Basically, we need to understand both types arise from the basic common cell, that is a gastric cell. And also there is an overlap of these two, and then there is a type called as a mixed type as well. I cannot escape without mentioning the chorea cascade, which was described way back in 75, the sequence of inflammation leading to metaplasia, then to dysplasia and cancer, which is similar to the one described in the colonic cancer of adenomatous polyp, so adenoma carcinoma sequence. But here the difference is this inflammation sequence which leads to cancer is the atrophic, not the hypertrophic gastritis. So this is substantiated by the study. Nobody can dispute Japanese as far as the gastric cancer is concerned. They have very large number of series. They say 95% of these cancers are associated with atrophic gastritis. H. pylori, though, has been found to be associated, as I mentioned earlier. The studies in India, it is very difficult to be conducted to be how exactly H. pylori the pathophysiology leads to cancer. It becomes very difficult because of the long latency, the gap between the H. pylori infection to arise and leading to cancer. The length of the time it takes is so long. And again, it becomes very difficult to establish that by eradicating H. pylori infection, one can stop gastric cancers, because reinfection is very common in our country. Eradication before the onset of metaplasia is one thing which is very well understood that helps in decreasing the risk of gastric cancer. I just want to mention a word about Barrett's at this stage, Barrett's esophagus, because we find the proximal gastric cancers even in India is going up. I'm sure my chairperson will agree that though the incidence of distal gastric cancers are remaining the same or maybe partially coming down, whereas the incidence of proximal gastric cancers have gone up very significantly. So that makes it imperative to understand what causes this, and let us talk about it a bit later. H. pylori infection leads to chronic gastritis, and that is supposed to be starting the process of inflammatory cascade, which I mentioned earlier. We need to understand essentially this cascade has two forms of atrophic gastritis. The multifocal atrophic gastritis predominates in the patients in cases of intestinal type of gastric cancers. Body or corpus predominant atrophic gastritis, which spares the antrum, is autoimmune in origin and is associated with antibodies to the parietal cells and intrinsic factor. Now, just coming back to Barrett's esophagus, a lot of advancements have happened, both because of the help of technological advances in endoscopic techniques, as well as in the understanding by describing, in fact, different stages of Barrett's esophagus have been described, especially the one classification which divides the Barrett's into short segment and a long segment. And it is this long segment where the Barrett's mucosa is more than 3 centimeters in length. They need to be looked in very closely for any changes, dysplastic changes, and also to be followed up more carefully. And that again brings us to the point that an adequate training is required, not just a cursory, just a fast endoscopy, but whenever we come across to identify these Barrett's, and especially the long segment Barrett's, and how to look for the dysplastic segments and targeted biopsies, where to take targeted biopsies. This all ends up in a point that we need to get trained well before we can pick up the early lesions. And there has been a description called as prakyria, which has come in now, which has described, you can look into the various factors which come into the play when you evaluate a Barrett's esophagus. So again, makes it more intricate and necessity for adequate training to pick up, to make this endoscopy as an useful tool in detecting early cancers. Again, you can see such beautiful pictures of not so beautiful lesions like the atrophic gastritis and chronic gastritis can be easily picked up endoscopically. In bare eyes, you have a good high resolution endoscope of the present day. So again, technology plays a very important role in this, where we have the newer advances of narrowband imaging and other technologies, which I will talk a little later. Now, coming to the few words about the screening recommendations, which I would like to put across. The identification of pre-neoplastic conditions early in and detecting them early is important. Mass screening of asymptomatic population has been carried out in various endemic areas, especially in Japan and China. They have made a big difference in the outcome of survival. Surveillance program in high-risk patients with pre-neoplastic lesions is recommended. In Japan, mass screening has led to increase in detection of early cancers and reduction of nearly 50% in the mortality in this particular population. So what is problem in India is not only socioeconomic, but also the number of centers where we can take up these programs is to be looked in. And that is where I, being a surgeon and now going to head a institution of Association of Surgeons of India, would love to take up this job of training surgeons as endoscopists so that they can be trained further in picking up these lesions early, and they can be useful in detecting early cancers. Screening recommendations should include positive family history, those with positive family history. And as I mentioned earlier about the certain group of patients, the HNPCC and familial adenomatous polyposis. Pernicious anemia patients having diagnosed, they need to be followed up closely. Post-gastrectomy status, as I told earlier, and also post-GJ status to be followed up. Multifocal atrophic gastritis with the other associated genetic and environmental factors, if they are present, they are form the high risk group which need to be. And what is the modalities which are available with us? As I mentioned, upper GI endoscopy remains a real keystone in the screening program, and high magnification endoscopy, chromoendoscopy, and narrowband imaging. Added now, the ultrasonography in endoscopy has come a big way in screening methodology. There have been non-invasive screening approaches like estimation of pepsinogen and gastrin 17, but they are not been, they are still in the experimental stage. See, what I just wanted to show you in this picture is, you can see how narrowband imaging can make a big difference in the appearance, and we can have a more well-targeted biopsies to pick up high degree of sensitivity in detecting early lesions. So what is narrowband imaging? You know, this the light has a component of multiple, the white light what you use for endoscopy has a component of multiple wavelengths. So out of which we leave away the wavelengths of red and yellow and keep only the ones which is blue and green, and you can see what difference it makes in the same picture. You can see above and below the vascular pattern and the mucosal architecture becomes more well defined, and one can the pattern of this, if understood well before, can pick up early lesions. I would like to again show this, the picture of the mucosa. You can see how a narrowband imaging in the picture B, and then chromoendoscopy in the picture C, and further advancement in endoscopic technique, that is the cytology. Endocytoscopy will help you, but again, this will lead to another thing is about training the endoscopist in cytology. So we cannot afford to have a cytologist to be present by the side when you are doing endoscopy. So that adds a new challenge to this dimension. Now, again, you can see the narrowband imaging, how an intestinal metaplasia looks like in a gastric epithelium. Again, a well-directed biopsy can help in picking up these precancerous lesions. The other emerging developments include microRNAs and volatile components found in exhaled breath and identified either by gas chromatography or other methods can be of help, but I think further advancement and understanding is required in this. In a nutshell, I just want to sum up here. You can see the cancer, gastric cancer goes through from the cascade from the left to the right. You can see starts from an inflammation basic to the metaplasia and dysplasia, but you should see that the level where it becomes irreversible. So if at all we need to prevent cancers, we need to act early at the stage of reversible stage where we can intervene and prevent cancers occurring. Coming few words about pancreatic cancer. The problem with pancreatic cancer is that pancreas is an organ which is remotely placed. It is not fairly inaccessible compared to the stomach. So hence that makes it more difficult to access as far as picking up early lesions. So this has been associated with poor prognosis because of the late presentation, because the symptoms also remain non-specific unless otherwise they are strategically situated close to the ducts where they can produce obstruction and symptoms. 5-year survival is hardly 5%. We are not able to improve even with the advances in the technique of surgery. Of course, the risk factors include the same thing as I mentioned earlier with the stomach, except in the fact that in the diet, high intake of saturated fatty acids and cholesterol is found to be associated with increased incidence of pancreatic cancer. Alcohol plays a major role. Chronic pancreatitis, though this is not very common in many parts of our country, but in areas like Kerala where tropical pancreatitis is common. So we need to know that these types of chronic pancreatitis, both hereditary and tropical pancreatitis, are associated with increased risk of pancreatic cancer. What is important to understand is about these certain syndromes, especially the Peutz-Jeghers syndrome, which is found to be associated nearly up to 15% incidence of cancer in pancreas being found. So there are other syndromes which need to be aware of. Whenever they have been found, these are the patients we need to be followed up because they have a high risk of pancreatic malignancy. There are certain mutations which have been found to be associated with cancer, pancreatic cancer, like KRAS mutation is one such mutation we need to keep in mind. So I want to just add, there is a lot of research which is going on at genetic level. I have found that in one of our premier institutes at Hyderabad, Asian Institute of Gastroenterology, they are doing, there's one of the centers where genetic study is being performed, association with pancreatic cancers, and they have found that a SPINK mutation associated with one type of genetic abnormality associated with even hypogonadism as a syndrome is found to be associated with higher incidence of gastric cancer. So further results are awaited in this. So we can even have a local, that is what is relevant to our country, we can formulate the guidelines. Precancerous conditions like mucinous cystic neoplasm is found.
Overshot the time, sir. If you could.
I will just finish. This is the last 2 slides. If you give me 1 minute, else I can wind up. No problem. So I would just say these are certain neoplasms we are associated with pancreatic cancer. Now, what is recommended in screening in pancreatic cancer is we need to identify high-risk group and use the imaging modalities to pick up this and follow up those lesions which are highly suspicious, like the cystic neoplastic lesions. Screening recommendations I would recommend is considering the low incidence of pancreatic cancer. Routine screening of population is not recommended. We need to screen only the high-risk individuals. I last 2 words about prevention of cancer. We know now much has been already spoken about it. I would not say again about all this, but one thing is sure, in India, to bring in modifications in the diet consumption and habits is very difficult. What takes us is public education taking up in a bigger way can only help in bringing up these changes. So thank you very much for giving this opportunity. As for the constraint of time, let us have, if there are any queries to be answered. Thank you.
Thank you very much, sir, for comprehensively covering the factors responsible for development of gastric and pancreatic cancer and also the screening recommendations. Any questions from the floor? Any questions from the audience? What I feel is there is a dissociation between what we know and what we practice. Why I am saying is every now and then I read in the newspaper that the sales of ITC has gone up by 30%, 40%. The sales of Zomato has increased. The sales of Burger King has increased.
Yes.
And the advertisements of burgers and pizzas on the television and the passive promotion of smoking and alcohol use in OTT platform are more attractive than the knowledge of the risk associated with this.
Thank you. That's correct.
What
That's
is
correct.
what is your opinion as a president-elect and of ASI, and
Absolutely.
how do you want to take it forward December onwards as a president of ASI?
A very, very difficult question. I know it's a big challenge. We need a collective effort to bring in legislations to that effect. The basic thing is, has been told yesterday by Vishal, is about the tobacco. Tobacco is a very major contributor, which we all agree now. It is proven beyond doubt. I don't know if we can achieve in prevailing upon policymakers to stop tobacco. I think it's the biggest achievement ever can be done in cancer prevention. I will just add one word about I being an agriculturist for the last 4 or 5 years. I have been trying to do something called as organic farming. It is a real myth. If we don't use the chemicals, we find my productivity goes down to 20%. Can you believe 80% of my crop is gone? So I will tell you the amount of chemicals which are used in growing in a common vegetables is so high. I get afraid to use vegetables. We encourage, I also spoke right now, increase the fresh vegetable intake to decrease cancer. But I will tell you the chemicals I have seen being used, I am very hesitant to recommend usage of vegetables unless you grow it in your backyard. So this is one message I just wanted to convey. Thank you.
Thank you very much, sir. And I think we'll conclude this session. Thank you, SPOC.
Thank you. Thank you.
Thank you, Dr. Siddesh. Thank you, Dr. Ashwini Kumar Kudri. The next topic, Dr. Vishwanath will be introducing the speaker.
Yeah, it's my pleasure to introduce a good friend of mine, Dr. Kiran Abhijit Kulkarni, who is an associate professor in the Department of Gynec-Oncology at St. John's Medical College, Bangalore. And she has several awards and publications to her credit. And she will be speaking on ovarian cancer prevention and role of hormones. And I request Dr. Rajiv to introduce the moderator.
The moderator for the session is Dr. Monica Pansari. She's a women's oncologist. She deals exclusively with breast and gynec oncology at BJ's Global Hospitals. She's a good friend and an able partner in our work. Please come, Dr. Monica.
Hello, Dr. Kiran. Dr. Kiran is a very good friend of mine. She's a gynec oncologist at St. John's Medical College. Without wasting much time, because we are running out short of time, we would like you to start the session.
Good afternoon, everyone. I hope I'm audible to everyone. And at the outset, I would like to thank SPOC, especially Dr. Monica, for this opportunity. I think they are doing a great work and great initiative here. I'd like to share my screen.
You are audible, Dr. Kiran.
Is my screen visible?
Yes, it is. It is. You can go ahead.
Yeah. So greetings from St. John's here. And ovarian cancer has always been the evil one amongst gynec cancers. And almost 150 years earlier, the person who came up with the theory of causation of CA ovary, that is theory of incessant ovulation being one of the factors responsible for ovarian cancer, quoted this. Note his words, to be humbled by the consciousness of the narrow limits which circumscribe the resources of our art. He told this 150 years back. Even today, we find this to be to a certain extent true, though we have come a long way in certain aspects to treat and prevent ovarian cancer. The basic problem with ovarian cancer is, as we all know, it has the highest mortality, least probability of early detection, does not give us any warning, and has no easily identifiable precancerous lesions, unlike CA cervix, CA endometrium. And the screening strategies which are available are not so good. So all put together, it is a major problem. And the incidence, as per as the Globacon 2020 data, in India, it's the third leading site of cancer among women. And unfortunately, the incidence is increasing over time. A majority of the chunk are sporadic cancers, but around 10 to 15% of them tend to be hereditary. to understand how to prevent ovarian cancer, which is a very, very difficult task, I must say, we need to understand who is at risk. So like in any cancer, the risk factors can be modifiable, non-modifiable, but there are certain elements which probably some kind of intervention could change the path or course of the disease and help the patient. So that's why we are here to look at those options. So advancing age, we all know the hormonal impact of menstrual early menarche and late menopause, obesity adding onto the problem, infertility, endometriosis, basic ethnicity, and hereditary breast ovarian cancer syndromes, other genetic syndromes as well. But the modifiable ones are mainly obesity and smoking. So these are the two things. If at all we are going to bring about a change with active lifestyle and a responsible behavior, I think they can help to a certain extent. But we need to identify who is at risk. So MSKCC has come up with this risk stratification, classifying women as averages. That's when most of the general population falls in, wherein the relative risk of developing ovarian cancer during the lifetime is less than 3 times that of the general population. Increased risk, wherein the relative risk is around 3 to 6 times, and inherited risk, wherein we have identified a known genetic mutation. So these are the 3 categories wherein risk stratification of women has been categorized. And based on these risk stratifications, what preventive measures or recommendations are to be followed is what I'll be discussing. So in an average woman, that is wherein the relative risk is almost comparable to that of general population, these are all the women who fall into that category. Though seemingly known as risk factors, just a mere history of infertility or history of endometriosis or use of HRT does not warrant for a screening like some people think. So these are also the things which we need to keep in mind, but definitely does not warrant an annual screening with TVS or CA125. Screening, we all know, is a very poor modality. Has to be reserved for women who are at higher risk. So even a history of breast cancer at a later age with no significant family history, so no major screening is recommended. However, as a part of routine preventive health care, an annual exam, gynae pelvic examination is definitely can be done. Why are we not recommending screening when we say that the ovarian cancer has such a high mortality? The problem is with ovarian cancer, we have, I think, various very strong RCTs and data with us with the PCLO trial, with the Shizot cohort studies, and now the UK talks. I think they have spanned decades of research here. And what they have found, unfortunately, with so many years of strong data, we do not have a mortality benefit with ovarian cancer. To some extent, maybe the stage of identification of ovarian cancer can be slightly lower, but ultimately it does not really translate to a mortality benefit. So that's why there is no screening recommended for lady with average risk of ovarian cancer. So just this year, the Lancet has published this data wherein a follow-up of almost 16 years of these women who are enrolled in the UKHC talks trial. And as you can see here, a significant number of them were identified in stage 1 and 2 disease, but ultimately that did not translate into a mortality benefit. And that's why there cannot be a recommendation to do screening as a routine based on this study. So coming to the next segment, wherein women are at increased risk, that is 3 to 6 times the relative risk of developing ovarian cancer. Who are these women? A lady who has a first degree relative with ovarian cancer, a personal history of breast cancer at a younger age, personal history of breast cancer diagnosed at about 50 or above, but a family history of breast or ovarian cancer, 2 or more close relatives who have breast or ovarian cancer and these ethnicity, and also individuals who meet the genetic testing criteria, but the test results have been negative. So these are the women whom we classified as increased risk for developing ovarian cancer. But again, various studies are there. Here, there are no clear-cut screening recommendations. We can only offer annual transvaginal sonography and CA125 after having explained to the patient of the possible fallouts of this. So unnecessary surgeries, whatever after having detected a small cyst, or a raised CA125, which can be a false alarm because it's a very non-specific marker. But however, these women should be on watch and they can be offered these two tests. But again, if you go at the data and the literature, there is no clear supportive evidence, unfortunately. The only criteria where there is a recommendation for screening for ovarian cancer is in the inherited risk class. That is, there is a significant increase in the relative risk of more than 6 times the general population. And these are the women wherein we have identified a deleterious mutation in BRCA1 or 2, and also in the Lynch when we have identified a DNA mismatch repair gene mutation. So here, we have supportive studies with the UK familial ovarian screening trial and the GOG 199 and the CNG trial, which says that there is a possible role of screening these women with annual transvaginal sonography and regular CA125, followed by RRSO, risk-reducing salpingo-oophorectomy. The whole point of screening is only up to the phase wherein they ultimately undergo RRSO. There is no recommendation to go on with only screening by these modalities and not offer RRSO to these women. So the present guidelines, various bodies have come up. So all agree with the fact that in women who have an inherited risk, that means we have identified deleterious mutation, the screening should start at the age of 30 to 35 years or 5 to 10 years earlier than the index case in that family. So how do we screen? We screen with CA125 once in 6 to 12 months and annual transvaginal sonography. And after the age of childbearing, or roughly around 35 to 40 years for BRCA1 and around 40 to 45 for BRCA2, we offer risk-reducing surgery in these women. So the role of this kind of screening is only limited up to the age where they reach for risk-reducing surgery. The various strategies for prevention of ovarian cancer can be broadly divided as lifestyle modification, pharmacological agents such as oral contraceptive pills. That's where the hormonal therapy comes into picture. And another chunk is the risk-reducing surgeries. But most important is we need to identify these women. So somewhere we need to increase the genetic testing of course, in women who meet the criteria, so that we identify these women and take the necessary steps. So in modification, as I mentioned earlier, obesity, hormonal milieu which it changes, or the ongoing inflammation it puts the patient at. So we need to somehow try to achieve ideal weight and follow a healthy lifestyle, physically active lifestyle, though easier said than done, especially coming from a person like me. So what best we have next is that we can offer them pharmacological therapy, mainly hormonal therapy. The most studied pharmacological agents for chemoprevention in ovarian cancer are the combined oral contraceptive pills. And these are quite rampant in use otherwise in the general population. And usually it's a combined estrogen and progesterone oral contraceptive pills. And they have shown that they offer a significant reduction in ovarian cancer, especially the high-grade serous ones here, with the ever use of at 30% reduction. And if 5-year usage of these oral contraceptive pills offers a significant risk reduction of almost 50%. Studies have noted that there is no difference between the older high-dose OC pills versus the newer low-dose. So whatever benefit of ovarian cancer prevention is not dose-limited. It is seen with the low-dose oral contraceptive pills as well. Now, how do these oral contraceptive pills prevent ovarian cancer? So we all know that repeated trauma during ovulation or a prolonged reproductive phase is one of the causes. So it basically prevents ovulation. Oral contraceptive pills prevent ovulation, prevent that trauma, prevent that opportunity of a repeated DNA damage repair. And also it reduces the gonadotropin milieu exposure around the ovary during what happens during the ovulation. And it promotes progesterone-induced cellular apoptosis and somehow decreases the inflammation. So by these various mechanisms, oral contraceptive pills have shown to have a benefit in reduction of ovarian cancer. But as any good thing, it does not come without its own problems. So risk of thrombosis and a possible risk of increasing the incidence of breast cancer are the two important things which weigh on a women's mind when they're taking OC pills for a longer time. Short term, yes, there is no major risk of thrombosis or increase in breast cancer, but we are looking at years and years of these oral contraceptive pills. So that's when we need to think about these two factors. What is the recommendation as far as hormonal therapy with oral contraceptive pills is considered in inherited risk women? So definitely we know that they are at a higher risk. So somewhere before they reach the age of RRSO, what are the things apart from screening that we can do? Can we offer oral contraceptive pills to these women who are already at a higher risk of breast cancer? What studies have shown is that the benefits outweigh the risk. So it is reasonable to use, especially the low dose ones. So the higher dose ones and a longer duration usage of oral contraceptive pills have known to increase the risk of breast cancer. So that probably needs to be avoided. But low dose ones and with a lesser than 5-year duration can probably be recommended for these women who are at a higher risk of developing ovarian cancer. And what good thing about OC pill usage is that the benefit outlasts the use of these oral contraceptive pills. Even after the stopping intake of these oral contraceptive pills, the benefit continues to be there for some time. Any alternatives to these oral contraceptive pills? We have seen that tamoxifen aromatase inhibitors, there is no supportive evidence for their use in chemo prevention upfront. However, they have shown to be a role in recurrent settings to prevent, especially in low-grade serous cancers. So there is no role for upfront use of these medications as chemo prevention in general population or average risk women. Coming to other pharmacological agents, as I said, inflammation is one of the key factors for cancer. Somewhere reducing that inflammation, can it help? So studies have looked into NSAIDs, especially low dose aspirin, acetaminophen, COX-2 inhibitors. But unfortunately, the data at present is not really strong enough to make this a recommendation. Problem with chemo prevention with these pharmacological agents is that we need a very strong data over decades to really understand whether they prevent ovarian cancer. That's kind of, it is a challenge. Other agents which have been studied in chemo prevention for ovarian cancer are these retinoids. So here they have a benefit over hormonal pills, because unlike estrogen and progesterone pills, they do not increase the incidence of breast cancer. But as I said again, the data what we have right now is not strong, so we need to wait for further studies. However, again, they have shown a role in low-grade serous tumors. Over the last few years, our understanding about ovarian cancer has significantly changed with the idea that was put forth that it is a fallopian tube which is the primary culprit and not the ovary, which has taken the blame all these years. So as we can see here, with each ovulation, there is a disruption in the surface epithelium, but the main culprit is the fimbrial end of the fallopian tube, wherein reactive oxidative species ultimately bring about a mutated TP53, and this leads to proliferation of the cells. Now, the mechanism by which these cells kind of can result in ovarian cancer are two. One is these cells kind of get into the ovarian stroma and form an inclusion cyst and ultimately lead to cancer, or there can be direct deposition of these cells onto the surface of the ovary, which ultimately turns out to be a tumor mass in the future. So main culprit being fimbrial end of the fallopian tube, which various studies have shown that there can be a in situ lesion, what we call as a stick lesion. So with this understanding, a major change has been brought about in prevention of ovarian cancer, that is offering risk-reducing surgeries. Risk-reducing salpingo-oophorectomy is definitely a very key event in preventing ovarian cancer in women who have an inherited risk. It is not a recommendation for women at average risk, but definitely it is a game-changing step in women who have a identified deleterious mutation. So women with BRCA1 mutation should be offered RRSO at the age of 35-40 years. And women with BRCA2 can wait for a few more years before they undergo this surgery. So risk reduction to the tune of 80% is significantly, it's a game-changing thing. So it has to be offered to these women. However, in women who do not are not willing for this, so only in those women do we offer oral contraceptive pills or the screening modalities which I have earlier mentioned. Apart from reducing the incidence of ovarian cancer in these women, they also have a beneficiary effect on CA breast, which these women are again prone for. But again, it does not come without its own problems. If we are removing the ovaries at a young age, we are looking at a state of premature menopause, so which again comes with its own problems because of ovarian hormone deficiency. Can these women be offered hormone replacement? I'll come to that. So osteoporosis being common with these, cardiovascular risks being enhanced post RRSO. So that's why we should not offer this to women at average risk, because what they have found is that removal of ovaries below the age of 45 years, the all-cause mortality is much higher than the benefit what it offers. So that's why it is to be offered only in women who are at an inherited risk of ovarian cancer. Post RRSO in indicated cases, HRT on a short-term basis can be given, but again, progesterone in the HRT may increase the risk of breast cancer, so we need to be watchful. And without progesterone, if only estrogen is being given, it has a problem of increasing risk of endometrial cancer. So we need to weigh the things. But if hysterectomy is done along with RRSO, estrogen only can be given till the age of natural menopause. Is there any role of removing only the tube? So we say that the fimbrial end is the culprit, the fallopian tube is the culprit. So how about removing only the tube? So opportunistic self-injectomy is being studied, and it's a very simple procedure, does not really come with the risk of ovarian hormone depletion like how we see with oophorectomy. So as a practice, I can say that we are doing this on a routine basis when hysterectomy is being offered for some other reason and the ovaries need to be preserved. We remove the tubes in those women. So that is what we call as opportunistic self-injectomy. And studies have shown that it does not increase the operative time or complications associated with surgery. There is no detrimental effect on the ovarian function also. So some people have looked at removing the tubes if the lady is not really willing for removal of the ovaries in inherited risk. So is there a role of doing interval risk reducing self-injectomy? Then once they complete the family or whatever, or they agree to to undergo the surgery, then RRO to be offered later. But there are no RCT saying that. So right now what I can say is that we as a routine are doing opportunistic self-injectomy, and there is a German guideline also now which has come up warranting the same. Another simple surgery which is done very commonly is the tubal ligation. So tubal ligation also offers to some extent protection against ovarian cancer, basically known to prevent ascent of the carcinogens, or in fact even in endometriosis cases, the blood and blood products which have a retrograde spill on the ovary and into the peritoneum. But this has shown no benefit on mucinous tumors or the borderline tumors. So coming to the last step, that is, we have to identify women who are at inherited risk. So that's when we can really offer these risk reducing surgeries, and which ultimately turn out to have a mortality benefit as far as ovarian cancer is recommended. So basically in all women, I think NCCN has come with extensive guidelines. Women with a personal history of breast cancer or ovarian cancer, there are various guidelines, and those who fit this criteria, we should definitely offer genetic testing in these women so that we can identify not only the increased risk of other cancer in that particular individual, along with that, we can alert the family members so that they can take necessary steps to prevent ovarian cancer. So in this thing, all high-grade serous ovarian cancers are the ones who should be referred for genetic counseling and testing irrespective of a family history. So that's the area which we can look at. So just trying to summarize whatever I told now, I think I am keeping very much in time. Chemo prevention with oral contraceptive pills can be offered, and it is quite rampantly used also. We have to counsel the patient, especially in a lady who has had a BRCA mutation identified, So till the age and phase of RRSO, we can offer chemo prevention with oral contraceptive pills. Unfortunately, that's the only agent which has been tried and tested and is available right now. Other agents are not so good, and we do not have evidence of prescribing these on a routine basis. Risk reducing surgeries are the game changing things. So RRSO should be offered to all who are at inherited risk of breast and ovarian cancer. And risk reducing self-injectomy in an opportunistic setting, I think, is a good practice to follow in average risk women. And tubal ligation offers protection to some extent. But more importantly, as I mentioned, identify women at increased risk. So enhanced genetic counseling and testing of women who meet the criteria. Unnecessary testing also should be avoided. So in women who meet the criteria, we should do this somewhere. I think the cost and financial constraints come in the way, especially in a center like ours. But somewhere we try to overcome that and offer testing in these women so that we can identify and offer risk reducing strategies to these women. So when it comes to cancer, we are all looking at a cure as a miracle. But I think I found this, a small write-up wherein it says the cure is not the miracle, rather prevention. But unfortunately, the impact of curing a disease is much more than preventing. In prevention, it is like the person was normal and continues to be normal. So there is no sea change visible, but ultimately, quest for a miracle should be to prevent ovarian cancer and not cure. So with this, I'd like to end my talk. Thank you so much. I'm open to any questions which are there.
Thank you, Dr. Kiran. Is there any question from the audience? So we would move on. Dr. Kiran has covered almost every aspect of prevention in ovarian cancer, including risk reduction surgeries, use of oral contraceptives, and the side effects, what we can have with the continuous use of oral contraceptives as well. So we'll wind up the session. Thank you, Dr. Kiran, for taking us through the entire detailed discussion of prevention of ovarian cancers and the use of hormones in prevention. Thank you.
Thank you so much.
We move on to the next session. I would like to invite Dr. Anil Kamath, good friend of mine, and he's a senior consultant surgical oncologist at Apollo Hospitals, Bangalore. And his topic is also interesting. Is promiscuity an often undiscussed topic in cervical cancer? I invite you, Dr. Anil Kamath, to give this talk and to moderate this session. Another friend of mine, Dr. Vinay Ural, and who is a senior radiation oncologist with Apollo Hospitals, Bangalore. He'll be moderating the session.
Thank you, Dr. Vishwanath. Thank you, Dr. Nanda and SPOC for giving me this opportunity. Dr. Kamath, stage is yours to light some fire.
So I'm given this rather raunchy topic of promiscuity in this thing, and I have to speak it along with a very boring topic of cervical cancer. So let me see. So I'll be covering various aspects. First, I'll be speaking a bit on the role of HPV in cervical cancer, because when we talk of sexual promiscuity and cervical cancer, it means sexual promiscuity and HPV infection. Then I'll be speaking on how HPV will spread, since the main route is sexual. So I'll be talking more on this. Then I'll be going to the actual topic of sexual promiscuity. And this I'll be dividing into female promiscuity and male promiscuity. And in the end, I'll be talking about prevention. So these are the various headings under which I'll cover this topic. So let me just start with a question for all those for this one. So if I make a statement that those the speakers and the audience, that more than 50% of these have contacted HPV at some point of time, would I be right or wrong? So the answer is, this is by no means any judgment on the character of any of this one, but this statement is actually true, and the numbers are much higher. We don't have any studies in India, but at least in US, the quoted this one of HPV infection during their lifetime is as much as 80%. So invariably, even if we claim that we have been with only one sexual partner, the chances of getting HPV is more than 80%. So if we see the global burden of cancer, India used to be in the red because of the high incidence of this thing. The incidence has come down quite a bit in recent years. But India still continues, cervical cancer continues to be a major problem in India. And the main culprit is this, this virus, or the human papilloma virus. As we all know, almost all cervical cancers can be attributed to this one particular. Actually, it's not one virus, because there are more than 100 different types of HPV. But the viruses which do cause the virus which does cause cervical cancer is the virus 16 and 18. The less aggressive ones, 6 and 11, cause anogenital warts. As we know the roots of this one, there are only two known routes of spread of HPV. One is sexual and other is from mother to fetus at the time of birth. In sexual, it can be due to by various ways. Even one is the known vaginal intercourse. Oral sex, even kissing, or this one, that also can lead to spread of this thing. So all methods of sex, even non-penetrative sex, can also lead to spread of HPV. This is something that we should know. And it's highly contagious. Even with one single sexual intercourse, the chance of getting HPV is very, very high. So every person who is sexually active will, as I put up in the initial statement, every person who is sexually active is at high risk of getting HPV. But fortunately for us, it's not a very aggressive type of virus. It doesn't cause cancer or even any of these things. It's quite a harmless virus in majority of the cases. And many of the people would just clear the virus. Say in a year or two, they would just this thing. But it's not always so. There is this thing that few of them get persistent infection and the viral genome gets integrated into the host genome. And this is where it causes the cancer. So the incidence is so high that sometimes it is difficult to tell whether it is just a casual association, like in this picture, whether it's just, or whether it is the causative factor. So till this one, there was debate whether HPV is just an innocent bystander and the other factors are actually leading on to the cervical cancer and this one. But that to a certain extent, it has been settled. HPV is not an innocent bystander. HPV is the culprit in majority of this one. It can lead to non-cancerous, this one, respiratory papillomatosis in infants born mothers out with HPV and genital warts. And when we come to cancer, there is a whole range of it, which includes cervical cancer, precancerous conditions, which form a bulk of the cases caused by HPV. Oropharyngeal cancer is a very upcoming topic. Nowadays, it's almost as a routine. We do check HPV in all patients with oropharyngeal cancers. The incidence is on a major rise in developed countries. Anal cancer, vulval vaginal cancer, and penile cancer. So HPV is associated with this many cancers. And the way it does is that it colonizes this genital system, and it usually enters through the transitional zone. The basal cell of the basal layer of the cervix is where all the multiplication occurs. The viral genome gets into this, and then it starts multiplying. So, but what is important is the period from infection to development of cancer, which is as much as 15 to 20 years. And in between, all these changes occur, CIN 1, 2, 3, carcinoma in situ. So this is why cervical cancer is something which is very amenable to screening and early detection, because of the large time gap between infection and actual development of cancer. And only a very, very small percentage of those who get HPV infection will actually end up getting cervical cancer. So this much about this thing. Now coming to India, unfortunately, we don't get much statistics about the sexual habits, as Indians are not very forthcoming about these issues. But if we see the general prevalence, which has been quoted, it has been quite high. As I said, almost 70 to 80% of in hospital setups, when it was tested, the HPV was found in as many as 70 to 80% of the cases. So as internationally known, HPV is a very common condition in this thing. So Next, coming to the actual topic of sexual promiscuity. So if you look at the origin of the word promiscuity, it is this one where miscus is mix. And when you mix without this one indiscriminately, that is what is this thing. It is, we have grown to use that word in terms of sexual habits, but it means to indiscriminately mix. The perspectives of males and females towards sexual promiscuity is very different. So we have to see it differently. So first I look at female sexual promiscuity and male sexual promiscuity and how it can lead on to this thing. So I think that is it is a no-brainer that sexual promiscuity leads on to this one, because once when a person is sexually promiscuous, he is at increased risk of getting HPV. In this, the 1618 virus, which is the high risk, this one invariably it will be higher. So 1618 being the carcinogenic, this thing, there is a higher chance of getting cervical cancer and also the other penile cancer, vulval cancer, and these issues. Again, this one very difficult to get proper statistics in Indian this thing, but there are a few this thing which conclusively proves that this is again not from India. This thing, as the number of sexual partners increases, the chances of being HPV positive goes up. So right from 21% at one sexual partner to as much as 70% when there is lifetime this thing of 10 or more partners. This is one of the major studies on sexual behavior in US. So what this study showed is that the upper line shows the male this thing, and the lower line shows the female this thing. So when a male is more sexually promiscuous, he has got a higher chance of getting HPV as compared to a female who is sexually promiscuous. So that is there is a major difference between this thing. So male sexual promiscuity is more dangerous than female sexual promiscuity. The only data which we get in India is from studies done in commercial sexual workers. So this particular study where they have studied the prevalence of high risk HPV in commercial sexual workers, this study is from Chandigarh. So when this was done, what is this thing is that you can see that the highest incidence is in the lowest age group. So when a female is sexually active at a very young age, which we see in commercial sexual workers, especially between 10 to 15, her chances of getting HPV and even the high risk HPV is very, very high as compared to females who are in the older age group. There are, so this much about female promiscuity. Coming to male promiscuity, there are some studies, these are not from India, they are from other developing countries. So the same holds good, whatever holds good for females also, the chances of HPV, the penile HPV is higher as the number of sexual partners goes up. And the age of first sexual intercourse also has a role to play in the males getting. So whatever I said in females, the same thing holds good in males also. So, but what is probably not discussed when we take history of cervical cancer and this thing, we invariably take the sexual history of the female, but not so much of her husband. Whereas many of these studies show that males play an important epidemiological role in terms of spread of cervical cancer. And for this one, most of the males get this HPV from high risk HPV from commercial sex workers, especially in lower socioeconomic strata. Again, this will be an undiscussed topic. So the HPV males significantly contribute to the development of cervical cancers in the females. And very often it is seen that the female may have a single sexual partners, but the husband may be having multiple sexual partners. So this aspect is again not very well discussed. So the males are both themselves at risk of getting penile cancers and they are at risk of causing cervical cancers in their partners. Circumcision to some extent has been known to be protective against HPV. This is one such study, which not many studies about the husbands of females who have got cervical cancer, but one such study from Thailand, which showed that these females who had got cervical cancer, the husbands had more frequent habit of visiting commercial sexual workers. So this much about sexual promiscuity and this thing. Then a few words about prevention. like in any prevention, there is primary prevention and there is secondary prevention. Cervical cancer is both, we have effective primary prevention and effective secondary prevention. Use of a condom, it's not 100%, but to a great extent reduces the chances of HPV. This is because HPV even spreads through the other exposed skin areas, and through oral fluids also can lead to spread of HPV. Now, delay in first sexual intercourse, as I said, the earlier especially in both males and females, the earlier the person has sexual intercourse, the higher chances of getting HPV. Having lesser number of partners, smoking has this one. And the last one I'll go through because it's an important topic, vaccination for HPV. Now it's almost 10-15 years since the vaccine was introduced. Initially, a lot of doubts were there regarding the vaccine, but we have now data about how countries which have implemented this vaccine, how are they doing? So if you see secondary prevention, it's pap smear. I'll not go much into it. It's another separate topic of its own. So vaccine, now we know that countries which have effectively got a good vaccination program have brought down their rates by quite a bit. Australia is almost on the verge of this one extinction of cervical, eradication of cervical cancer. And even other countries like UK and all, which have implemented a proper vaccination program, have seen a significant reduction in not just cervical cancer, it has seen reduction in 16 and 18 infections and the precancerous lesion, almost to the tune of 80 to 90%. So I think whatever doubts were there regarding the vaccine, it needs to be laid to rest because the vaccine has proven to be active. It's not just in females. As males play an important role in this thing, even the males need to be vaccinated against this one. So earlier there was there were two companies making, one was Gardasil and the other was Cervarix. One was a quadrivalent vaccine and other was a bivalent vaccine. But in terms of efficacy, both were the same, because the other two, 6 and 11, which is more effective against anal warts, genital warts. So this thing. So in the end, I would like to summarize what I have already. This one, HPV is a highly contagious, sexually transmitted virus. Not very aggressive, but it has a role to play in cervical cancer. So multiple sexual partners or sexual promiscuity leads to high chance of getting HPV, getting high risk HPV, and therefore getting cervical cancer. And males have a very important role to play in getting HPV and also getting their partners infected, leading on to cervical cancer. And vaccine is very effective, but equally important is education and safe sexual practices in the prevention of cervical cancer. Thank you.
Thank you, Dr. Anil, for making the topic interesting. Now, thank you once again for keeping time also. We have got a lot of time now, 3 minutes. So if you have, I think we can take one quick question from Dr. Vishwanath.
Dr. Anil Kamath, you made the topic very interesting. So I have a question. So why do you think in India, the HPV incidence or what is reported is only some 20% as compared to 80% in the West? One is probably underreporting, or what do you think are
there
the other
are
reasons?
no proper studies. We don't have proper community-based studies regarding HPV. It's very difficult when I put HPV in this one. Most of the studies are in hospital setups. We don't have population-based studies. I couldn't get a decent article which says the general incidence and prevalence of HPV in the general population. So probably they find it very difficult to do the test and take a proper sexual history, especially in the higher socioeconomic strata. That's what I would feel. Whatever data we have in India are data, hospital-based data or data from these commercial sexual workers, where some NGO has gone and done the study and this. And we don't have population-based studies. So whatever data which we are quoting, it may not be very accurate or this one.
And are you regularly recommending HPV testing in your oropharyngeal, penile malignancies and cervical malignancies?
Yeah, that is recommended in almost all this one, but general population-based testing for HPV is not recommended because it's such a harmless virus. Even if it is picked up, there is high chance that the person will eradicate it within the next few years. So there is no role for general testing, but for those who have got this one, oropharyngeal cancers, this one, it is because nowadays even the treatment differs somewhat in those who are HPV positive as compared to those who are HPV negative in oropharyngeal cancers, at least.
Being the second largest cancer in women, do you now recommend that you start giving vaccination to boys, like after your presentation?
It is started. In developed countries, it is started. In India, we don't have a national program for this one, but considering the burden, I think we should look at it. Earlier, there were doubts regarding whether it is really effective or this thing. But if you see the countries which have implemented and the benefit which they have got, I think India should make it a point to include it in the national vaccination schedule, both for males and for females. I feel the problem is it's outside the schedule, so the cost is still very high. And the people who actually require it, that is as we all know, it's a disease of the lower socioeconomic strata and this one. These patients may not be able to afford the vaccine because it's not government sponsored. But that is something I think public health, this one should look at because it's a very effective vaccine. Thank you.
If there are no more questions, I think we'll go to the next topic. Thank you.
Actually, that's a very, very interesting and tough topic that you've actually chosen to talk about. That's a tough topic. We were expecting a good amount of fireworks.
But you made it very simple. So we'll move on to our next session. Speaker for next section is Dr. Adarsh. He's Chief Gastroenterologist, Hepatologist, and Advanced Therapeutic Endoscopist at BGS Gleneagles Global Hospital. He's a colleague of mine and Dr. Rajiv as well. He's going to be speaking on detection of precancerous conditions and prevention of hepatobiliary cancers.
He's a Chupa Rustum nevertheless. And to as the moderator chairing the session is Dr. Amit Yelsangikar. He's a Chief Consultant Gastroenterologist in GI Oncology and Clinical Nutrition at Aster CMI, Bangalore. He also happens to be a very fantastic cricket player. We both played cricket together when we were in MBBS. So, well, he does have different game plans right now.
I thank Dr. Nanda and all the organizers of this wonderful meeting for inviting us. Liver cancer is something of interest to gastroenterologists, liver transplant specialists, surgeons, GI surgeons, interventional radiologists, epidemiologists, medical oncologists. I think the list goes on and on. So prevention of liver cancer is something that is close to all our hearts. I ask others to give us talk.
Thank you. Thanks, Dr. Monica and Dr. Raji for introduction, and thanks, Dr. Vishwanath, for inviting me. And I would like to congratulate SPOC for the grand success. So topic for today's my discussion is detection of precancer condition and prevention of HPV, hepatobiliary cancers. Why is this important? That's because one, the incidence and mortality of these cancers are on rise, and two, less than 5% or in some of the case series, less than 1% of these HPV cancers are treated with potentially curative therapies. I mean to say almost 95 to 99% of the time, by the time you're diagnosing these malignancies, they are already inoperable. So we need to catch them early and we need to prevent these malignancies. So today, okay, it's like changing here, but it's not changing here. Okay. Okay. Yeah. Yeah. So today I'll be presenting, I'll be discussing mainly on HCC, CAGB, and cholangio-CA. Even though hepatobiliary, usually we include pancreatic. I think here there was another speaker for pancreatic malignancy. So I'll limit to HCC, CAGB, and cholangio-CA. HCC, this is something, one of the commonest malignancies we see as a gastroenterologist as well in our daily routine. It is the sixth most common cause of cancer worldwide. However, this is the second leading cause of cancer-related death. So even though this is sixth most common, it's second leading cause of cancer-related death. And one thing is 80%. One thing is 80% of these hepatocellular carcinoma happens in background of liver cirrhosis. So only 20%, or in some of the studies, only 10% of the malignancy of HCC happen without cirrhosis. So coming to the risk factors for HCC or hepatocellular carcinoma, cirrhosis per se is a major risk factor. So cirrhosis of whatever cause is a risk factor for HCC. And sometimes, as I mentioned, HCCs can happen in non-cirrhotic liver also. So other risk factors are viral hepatitis, especially B and C, NAFLD or NASH, again, environmental toxins, aflatoxin, betel nut chewing, alcohol, tobacco, genetic susceptibility, hemochromatosis, alpha-1 antitrypsin deficiency, and also there have been case reports of hepatic adenoma turning into HCC. So as I mentioned, apart from cirrhosis, there are non-cirrhotic causes, which I mentioned again, viral hepatitis. This is very important because we usually screen only cirrhotic patients for HCC. I think we need to screen non-cirrhotic patients as well for HCC if they have these sort of risk factors. So who are the patients that are highest at risk? Basically, it's the Hep B cirrhosis, wherein the incidence of HCC is 3 to 8% per annum. And Hep C cirrhosis, the incidence is again 3 to 5% per annum, and stage 4 PBC. These three category of patients have highest risk of HCC during their follow-up. So, and HCC doesn't happen overnight. There's a natural history of HCC, usually especially in patients with cirrhosis. If there are 100 patients with normal liver, almost 30% of them will end up with hepatosis, steatosis, or fatty liver. Again, 15 to 20%, 25% of them will progress to have NASH, fibrosis. These stages are still reversible. And 5 to 10% of these advanced NASH end up with cirrhosis. And amongst these cirrhosis, 2 to 25% of these patients end up with liver cancer. However, fatty liver and NASH fibrosis are still reversible. And once there is cirrhosis, it may be irreversible. So precancerous condition of HCC, these were the risk factors. If you ask me precancerous condition, there are only a couple of them. That is dysplastic foci and low-grade dysplastic nodules. So in patients with liver cirrhosis, usually what we see is regenerative nodule. And once they develop dysplastic nodule, that is when they are at risk of developing HCC. Those are the patients who require monitoring and screening, because the natural history is low-grade dysplastic nodule turn on to become high-grade dysplastic nodule. Again, then it goes on to develop well-differentiated HCC, moderately and progressive hepatocellular carcinoma. So this is in patient with liver cirrhosis. However, without liver cirrhosis, they can directly develop HCC. That's a different thing. So to detect these dysplastic nodules, or which nodules are at the risk of developing HCC, I think this is one thing in all cirrhotic patients we need to look at. If this is the from one of the recent studies, clinical radiologic morphologic features useful to predict neoplastic evolution of dysplastic nodules. Which nodules can go into develop HCC? If the size of nodule is more than 1.5 centimeter, the probability is high. Again, in arterial enhancement, if there is hypervascular lesion, again the chances are high. Again, similarly, diffusion weighted imaging, hyperintensity in this thing, then the chances of it turning into neoplasia is high. Similarly, increasing size or acquired hypervascularity. So if there is synchronous HCC as well as histologic diagnosis. So these are the things which can tell whether the dysplastic nodule is at risk of developing HCC. So this is another thing with the various phases of MRI, which I will not go into too much of detail. So with gadolinium enhanced MRI, we can differentiate dysplastic nodule versus regenerative nodule versus HCC. So some of the few things I would like to discuss: hepatitis B, especially in India, because India is endemic for hepatitis B with the incidence of almost 5%. Almost 400 million Indians are affected with hepatitis B. And natural history of hepatitis B is such that if there is acute infection, 90% of children and less than 5% of the infected adult will go on to develop chronic infection. And as much as 30% of patients with chronic infection end up with liver cirrhosis. And among them, almost 4 to 6% of them will end up with liver tumor or HCC. So since we have a highly endemic population for Hep B, chances of they developing cirrhosis, the numbers will be very high. And again, the number of HCCs will be very high, especially in India. And also Hep C, even though in India the prevalence is not very high, it's around 1%. However, in difference here is hepatitis C. Majority of them will go on to develop chronic hepatitis C, whereas in hepatitis B only 5% of adults. So here 70% to 80% will have Chronic hepatitis, again, the incidence of cirrhosis is almost the same, around 30%, and 2 to 7% of the patient will develop HCC per year. And it's also this may be accelerated by older age, obesity, immunosuppression, or other alcohol. So the transmission of hepatitis B and C, this is important because, I mean, in general public, if they are watching, how does it transmit? That is only by sexual transmission, mother to child, sharing needles, receiving blood products, infected blood products, or needle stick injury. And this is more important, how it does not spread, because we see a lot of patients coming with a lot of taboos and myths. They have not touched their children for many years and all those things. It does not touch by, I mean, it does not spread by sneezing, coughing, food and water sharing, playing with kids, hugging, or handshake. So how do we prevent HCC? Firstly, I mean, we all know there is primary prevention, secondary, and tertiary. Primary is we avoid normal liver to going with further progression into chronic hepatitis. That is basically by hepatitis B vaccination, or by preventing NASH. That is basically maintaining good weight and healthy lifestyle. Secondary prevention is by HCC screening. Once they develop cirrhosis, you do screening, and then for hepatitis B and C, you would give antiviral therapy, anti-inflammatory, anti-fibrotic, metabolic disease treatment, and molecular targeted therapies. So prevention of hepatitis C, prevention of hepatitis C, for especially if it is prevention of hepatitis B and C related HCC. For hepatitis B, we have hepatitis B vaccination, which has dramatically reduced the incidence of Hep B, cirrhosis, and HCC after it's been implemented in the universal immunization program. Few of you here, I mean, how many of you have been vaccinated with hepatitis B? All of you. So how many of you know the titers? So some of them don't know. So I think for doctors especially, I think many of you all must have got vaccinated, but I think we need to check the titers, that it's been, we have enough titers. Otherwise, we may be in false assumption that we are vaccinated, but however, you are still at risk of developing hepatitis B. Another important thing, people, what we are doing here now is screening for hepatitis B and C viruses, because India, as I mentioned, in some of the states, the incidence is more than 10%. So education, awareness regarding hepatitis B and C, safe sexual practice, avoid needle sharing, and more importantly, once they are diagnosed with these viruses, antivirals prevent the progression to develop liver cirrhosis and thereby HCC. So for NASH, even though I did not speak much, the prevention of NASH or NASH related HCC, most important thing is exercise, weight reduction. And this is one pyramid which shows that if there is fatty liver, NASH, and liver fibrosis, if they reduce weight by around 3%, steatosis can reverse. If they reduce weight, if they reduce weight by around 5%, even the ballonic inflammation in histopathology can reverse. If they reduce weight by 7%, NASH can resolve. And if they reduce the weight by around 10% of their original weight, even fibrosis can regress. So once there is regression of NASH, the progression to cirrhosis stops, and the risk of HCC also would come down. Dietary modification, address metabolic syndrome in patients with NASH. Again, metformins and statins have been proven to be useful to prevent HCC as well. And now we have saroglitazar and VOCA, which can prevent progression of NASH. And most important thing in general public is stop alcohol and smoking, which are risk factor for liver cirrhosis. And what is the screening modality? The usual screening modality in all these high-risk patients is 6-monthly ultrasound plus or minus alpha-fetoprotein. Whom should we screen? That is the next question. Not only cirrhosis, even in Asian male hepatitis B carriers more than 40 years, or Asian female with hepatitis B carrier more than 50 years, as well as all liver cirrhosis patient and patients with alpha-1 antitrypsin or hemochromatosis, they should be screened for HCC. So every 6 monthly with ultrasound, if required, alpha-fetoprotein. And in a patient who has high risk, maybe sometimes we may use CT or MR as additional modality as well. Coming to the next malignancy, gallbladder CA, which are the risk factors? Yes, gallstones. Even though 90% of the CAGB has gallstones, only 1% of them with the gallbladder stone progress to develop CAGB. Porcelain gallbladder, again, in some of the case series, 5% to 60% of the porcelain gallbladders can harbor malignancy. GB polyps, primary sclerosing cholangitis. If there is a GB mass in patient with the PSC, 50% of the time it can be malignant. Chronic infection with salmonella, choledochal cyst, or anomalous pancreaticobiliary drainage, carcinogen exposures, oil, paper, chemical, textile, this thing. And also we all know that Indo-Ganges belt they have high incidence of carcinoma gallbladder. That's probably related to the high arsenic level in the water, obesity. These are the common risk factors for carcinoma gallbladder. So gallstones, as I mentioned, 90% of the CAGB would have gallstone. However, the incidence of CAGB in patients who have gallstone is only 0.5 to 3%. So we really don't know whether one person should undergo directly prophylactic cholecystectomy just because they have gallstones without symptoms. And precancerous lesions of gallbladder polyp, adenomatous polyp of size more than 1 centimeter, and the risk increases with the increase in size. If the size is more than 2 centimeters, the probability of they having malignancy will be more than 80%. And associated PSC, as I mentioned, 50% of the GB polyps would be malignant. And again, there are studies that segmental adenomyomatosis in elderly can be pre-malignant. And again, porcelain gallbladder, again, it's of various type, of which mucosal type can be pre-malignant. So actually, this is one flow chart for gallbladder polyp. I'll just go through this. Gallbladder polyp, if they are symptomatic, they require cholecystectomy. If the polyp is more than 10 mm, yes, they require prophylactic cholecystectomy to prevent CAGB. If the polyp is less than 10 mm, we have to look for the history of PSC. If there is PSC, if there is associated cirrhosis, or if the polyp size, even if it is more than 8 mm in PSC, they require polypectomy. If they don't have PSC, then we look at if the age is more than 50, Indian ethnicity, or sessile polyp with focal thickness of gallbladder wall more than 4 mm. In those sort of patients, if it is more, if there is 6 to 9 mm, they require cholecystectomy. If they're less than 5 mm, they need to be screened annually. So preventing gallbladder CAGB, as I mentioned, gallbladder polyps with those risk factors, or sessile with gallstones, rapid increase in size, they require polypectomy, PSC more than 8 mm. Or even in patients with primary sclerosing cholangitis, we need to do annual ultrasound to look for the gallbladder mass. Coming to the last few slides, cholangio-CA, the risk factors, one common risk factor for one of the important risk factors is PSC, that is primary sclerosing cholangitis. In those subgroup of patients, the annual incidence is as high as 0.6 to 1% per annum. So, and also another important risk factor is fibropolycystic liver disease, which include choledochal cyst and congenital hepatic fibrosis. Other risk factors are hepaticolithiasis, viral hepatitis, genetic syndromes, and liver flukes. So PSC, the 10-year incidence is 7 to 9%. The risk factors are elevated bilirubin, variceal bleeding, if there is history of proctocolectomy, associated IBD, or genetic polymorphism. These patients with PSC are at a higher risk of developing cholangio-CA. Choledochal cyst, again, the overall incidence in untreated cyst is as high as 30%, 28 to 30%. The most common type of choledochal cyst which can progress to develop cholangio-CA are type 1 and type 4. Type 5 has got moderate risk, and type 2 and type 3 has low risk. Again, 20 to 34 increase of risk of cholangio-CA. Incidence increases with age. Less than 18 years, the risk of cholangio-CA is 0.4%. If the patient age is more than 60 years, then the risk is almost 38%. Again, presence of APBD is another risk factor for cholangio-CA. To prevent cholangio-CA, any patient with choledochal cyst, we do excision, PSC, annual ultrasound or MRCP, or annual CA99, manage hepatitis B and C, and treatment of liver flukes. Thank you.
Thank you, Adarsh, for that elegant talk. I'll set the ball rolling. There's a paradox that always comes to my mind. Now we've had 20-25 years of universal hepatitis B immunization. Hep C is almost curable now with antiviral therapy. Hepatitis B, we've had treatment now for 20-25 years. But somehow the incidence of HCC seems to be on a rampant rise, unlike Taiwan, where they had 80% reduction with universal immunization. What do you think is the reason for this in our setting?
So I think one is genetic. I think nobody can change the genes, and Indians, they have higher this thing, one. And two, definitely we have seen decrease in this thing, but then antivirals may or may not decrease the chances of HCC. In some of the studies, yes, antivirals have decreased. In some of the studies, antivirals have not decreased HCC. And now I think with more reporting or more awareness, we are picking more HCCs.
And in your practice, are you seeing NAFLD to be the predominant cause of HCC compared to hepatitis B and C nowadays, or do you think it's the same as what is
Yeah,
reported?
it's a very, I mean, if you see to overall incidence, yes, Hep B, Hep C will come first. But if you see the compare what was 10 years before and what is now, I think yes, NASH with HCC, we are seeing more often than what we were seeing before. Previously, unless proved otherwise, it was Hep B or Hep C. Now we see a lot of non-hepatitis viral cirrhosis with the HCCs.
Yeah, Dr. Vishwanath. So, great talk, Dr. Rajesh. I have a question. So previously, I don't know, during my MD days, was teaching that if you have that, even if you're fully immunized, and subsequently your antibody titers comes to less than 50 or whatever. 10. They say memory cells will take care of your.
No, we would prefer booster dose.
Booster dose. Okay. So what is the cutoff?
10.
10.
To be on safer side, people tell 20, but 10 is
Anything
minimum
different for
desired.
healthcare workers?
Usually we think we take 20 nowadays. Of late, there is no studies as such, but yes, especially in transplant setting, we think of 20.
Total revaccination schedule or just a booster?
One booster dose.
Thank you.
If at all you have not taken vaccination, I mean, if you have already taken one full 3 set of vaccination, then boosters. Otherwise, you have to take 3 set again. And if you have taken 3 and then the vaccine antibody is less, then we give double dose, or we can be given intradermal or subcutaneous instead of intramuscular.
And is there any difference between that accelerated schedule and that 016?
016 is what is universal. In a person who is planning for pregnancy on those sort of patients, we do add one more 0126 so that there is accelerated antibody response. Otherwise, it's 016.
So the non-responders are at risk, or
yes, they are at risk. It's false illusion that they have been vaccinated. That's all. I always tell COVID vaccine, even though you have antibody, you can still acquire COVID, but hepatitis B antibodies, if you have good amount of antibodies, 100% sure that you will not acquire hepatitis B.
Then 2 questions to both of you all. We find a large incidence of gallbladder cholangiocarcinomas from the Bengal, Orissa, Northeast belt.
As I mentioned, it's the Indo-Ganges, this thing, high arsenic content within the water is one of the proposed hypotheses.
Diet, I think diet there.
Uh,
They use too much of milk products, and the vegetables and all is little less there compared to the south.
That could be one of the
They
confounding
eat
factors.
a lot of meat and milk products, too much.
I mean, it's
lot of
common
sweets,
even in
you know.
UP, Bihar.
Sweets, they're very, very popular. You ask them every day, they eat lunch sweet, dinner sweet, breakfast sweet. I've been, following that.
So there are multiple hypotheses. I think there's a large study done by TMH itself in the Gangetic belt. And they found that some of the dietary grains that they use, sattu is something that is used a lot in that part of town. And again, a lot of contaminants in the water, right from Varanasi to Buxar in Bihar, there is a big chain.
belt.
But what is interesting is similar incidence is noted in Mexicans. Although you have the entire US, they don't see that much of gallbladder cancer, but the Mexican Americans, they see a lot of gallbladder cancer. There may be some shared genetic problems.
Genetic problem.
Most of
That's another thing.
So contentious issues.
Most of the cases that we handle are locally advanced. So any new screening tool available for cholangiocarcinomas and SCCs?
Screening tool in the form of?
To identify it early.
Ultrasound is the only thing. Along with that, for HCC, we had alpha fetoprotein. For cholangiocarcinoma,
Any target population we can identify and go through the process.
That's what Adarsh alluded to. If you have a patient with primary sclerosing cholangitis, then they do annual CA19-9, and there is a cutoff of 126 where you start doing more selective screening in case they have a high CA19-9. That is especially for PSC. Especially if you have
for
IBD,
general
PSC,
public, there is not for general public as such. It's only those high risk population or colorectal cyst wherein the chances are high. Prophylactic excision would be done.
Thank you. Thank you to the organizers.
Thank you. Thank you.
Thank you, Dr. Amit, and thank you, Dr. Adarsh. It was very, very interesting session. The next speaker is Dr. S.K. Raghunath. He will be talking about the prevention of urological cancers and early detection of precancerous conditions. He right now is director and head of uro-oncology at HCG, and he's one of the directors and co-founders of Trustwell Hospital, Bangalore. He's active in both the places. He, of course, is academically very well embellished. So he is an editor-in-chief of the Journal of Robotics in Oncology, and he has other designations as well. Welcome, Dr. Raghunath.
Thank you, sir. Thank you for
moderator for the session. The moderator for the session is a good friend and colleague of mine, Dr. Nataraj Naidu. He's a consultant surgical oncologist and chief of thoracic and GI oncology, uro-oncology and gynae oncology. He's also a high-spec specialist. So we work together at BGS Gleneagles Global Hospital and at St. Philomena's Hospital as well. Welcome, Dr. Nataraj Naidu.
Thank you, Dr. Rajiv. Thank you for the team SPOC 2021 and Dr. Nanda for giving me the opportunity to moderate the session. Dr. Raghunath is well known, and I would like him to start the session. Sir?
Yeah. Thank you, sir. Very good afternoon to all of you. At the outset, I would like to thank Dr. Nanda for this opportunity. That's number one, and for starting this great initiative. We are all clinicians. We know how to treat. We know how to take care of patients. But it is our social responsibility and commitment to prevent some diseases and to create awareness. In this endeavor, this conference is in the forefront. I compliment and I congratulate Dr. Nanda for this initiative. So my talk is prevention of urological cancers and early detection of precancerous conditions. I'm a tail ender. I don't want to waste so much of time. So coming directly to urological cancers, because I'm not going to discuss many aspects because it has been covered by many previous speakers, because most of the etiological factors are common for most of the cancers. I will specifically mention which is relevant to urological cancers. We deal with prostate, bladder, and kidney cancers. When it comes to prostate cancer, it's second most frequent cancer. In Delhi, Pune, and Bangalore, amongst men, it is second most commonest according to recent Globocon data. And of course, fifth leading cause of cancer death in men. When it comes to India, I must mention the mortality from prostate cancer is around 70%. Whereas in the West, it is very, very less, maybe around 15% less than that. Why it is so high? Because most of our patients, because of lack of awareness, and initially they will not have any symptoms. Patient will not have any symptoms. They present with stage 3 or stage 4, which becomes incurable. So it's very important thing to understand. And most frequently diagnosed. Hello?
Sir, can you full screen the thing, sir?
All right. Yeah, can you see now?
Thank you, sir.
Okay. So when it comes to bladder cancer, is 10th most commonest cancer, and 14th most commonest cancer is kidney cancer. A detection of known premalignant condition is possible only with penile cancers, whereas there are no premalignant conditions which we can detect in other urological malignancies. So coming to urological cancer prevention, these are the general principles. I will not go into the details of smoking and alcohol because these are being dealt extensively by previous speakers. Regular exercise, smoking, and alcohol cessation is very important. Exercise plays a major role. Dietary modifications. There are a lot of dietary advice has been given by previous speakers. Reduction of fats and red meat is very important for prostate cancer, and increased intake of lycopenes is going to prevent prostate cancer in particular to some extent. And all of our household, we use turmeric. Turmeric has something to do with decrease in the incidence of prostate cancers. That could be one of the reasons why in Indian subcontinent we see low incidence of prostate cancer. According to recent publication, the pesticides use, through the food chain is implicated in the incidence of around 12% of general oral cancers. Whether the same is implicated in the etiology of urological cancers, we don't know. So, but previous speaker, I think Dr. Siddesh mentioned this, how to prevent use of these pesticides through the food chain. My suggestion is grow your own vegetables. We grow our own vegetables. 70% of our requirement is met by our terrace garden. It is very difficult to do it, but it is possible. In Bangalore, saying in Bangalore, it's possible. I recommend and I urge all of you to probably practice that, because the incidence is around 12%. And screening for early detection of prostate cancer is very, very important. This has a lot of data on screening, which that is the only way where we can identify or detect prostate cancer in the first and second stage, because first and second stage prostate cancers are almost curable, close to 100%. I would say 98 to 99%, which are curable. And screening is the only way to detect this prostate cancer. Whereas very good screening programs are not there for other cancers, other urological cancers. The concept of cancer prevention has already been dealt again, primary, secondary, and tertiary preventions. I will not go into the details of this. I would like to highlight this, the modern concept of cancer prevention. Okay, we must understand the carcinogenic exposure, lifestyle issues to genetic and molecular aspects of cancers. Then only we can understand how we can prevent these. The population-based to individualized-based strategies, the multifactorial risk stratification based on the family history, genetic history, all those things, and cancer prevention by precision medicine and genetic engineering. Though we are at very infancy stage, we need to understand these things. These are the emerging concepts. So I will discuss briefly on every cancer. When it comes to first, that is renal cancer, it represents about 3% of all cancers, annual increase of about 2%. Tobacco use is implicated. Hypertension, obesity, diabetes, end-stage renal disease, and hereditary and familial risk factors are implicated in the etiology of or pathogenesis of renal cancer. Up to 50% of patients with kidney cancer have modifiable risk factors. That's where primary prevention is most cost-effective, and we should advocate the public, not the patients. The smoking cessation and de-addiction of other tobacco products are very important. Lifestyle changes, particularly physical activity, which indirectly prevents obesity, hypertension, diabetes, and all other metabolic syndromes which are implicated. The public awareness plays an important role for most of the cancers. Probably we as a clinicians, we should go one step ahead to urge the government. Instead of blaming the government, at our own level, we can do some activities to create awareness about this. We have formed one Global Prostate Cancer Foundation, through which we create awareness almost in a month. We conduct 2 camps just to create awareness and early detection of prostate cancer. When it comes to early detection of RCC, there are some problems with screening for RCC because of its low incidence, non-availability of reliable markers or screening tests, unlike in prostate cancer, and CT scan is not cost effective. Routine screening for general population is not recommended. However, if you do ultrasound after the age of maybe 35 to 40 years, most of the early RCCs, that is stage 1 cancers, we also call it as incidentalomas, we can detect. So by detecting when it is less than 3 to 4 centimeter, it is potentially curable. Most of the cancers, T1 cancers, that too T1A cancers, can be curable by doing partial nephrectomy. We don't have to do even radical nephrectomy. Any specific recommendations are there? Yes. Whenever ESRD patients are there or acquired renal cystic diseases are there, probably they need to go for regular follow-up with ultrasound, if required CT scan. And any family history of VHL, that is von Hippel-Lindau disease, tuberous sclerosis, and other forms of familial RCCs, definitely specific recommendations of getting into ultrasound routinely every yearly once is recommended. When it comes to upper tract urothelial carcinomas, epidemiology, upper tract urothelial carcinomas are very uncommon. It represents 5 to 10% of urothelial carcinomas. Probably it may be less than 1% of all cancers put together. Genetic predisposition is there as a part of Lynch syndrome or hereditary non-polyposis colonic cancers. So whenever any Lynch syndrome family is there or patient is having any of these cancers, probably we should evaluate for upper tract urothelial carcinomas and even bladder cancer for that matter. There are a lot of environmental factors are implicated in the etiogenesis or pathogenesis of this upper tract urothelial carcinoma. Again, tobacco is the foremost. Occupational exposure to aromatic amines, those who are working in chemical industries, dye industries, their exposure to aromatic amines are very high. Aristolochic acid nephropathy is not very common in India. It's in particular parts of China, it's very common. Arsenic use, somebody commented gallbladder cancers are more common with arsenic use. Again, high arsenic content in the water is probably one of the risk factors for upper tract urothelial carcinomas. Recent study says that even Bangalore water arsenic content is very high. So it's alarmingly high. So we don't know the implications of that. Analgesic use, chronic inflammation and infection, alcohol consumption and history of bladder cancers itself will have higher incidence of upper tract urothelial carcinomas. When it comes to the bladder cancer etiology, we know it's 7th most common cancer, smoking, hair dye. I must stress upon this. In 2016-17, we did a study where commonly we see bladder cancers in smokers. So 34 of our patients during that 1 year period, they were not smokers. They were using only hair dye. There can be other causes, but hair dye is one of the leading cause of bladder cancer. How it causes? When we apply hair dye, it gets into our skin and it gets into our system. It gets excreted through the kidneys, and when the kidneys throw out urine, it will be stored in the bladder. That's where it exerts its carcinogenic effect, and it causes hair dye. So better to avoid using hair dye. Ionizing radiation, schistosomiasis infection, it is found only in endemic areas, that too in Egypt. We don't see this schistosomiasis infection. A lot of drugs can cause carcinogenesis of bladder cancer. That's particularly pioglitazone and cyclophosphamide. And risk factors like upper tract urothelial carcinoma itself is one of the risk factors for bladder cancers. The primary preventive strategies for both upper tract urothelial carcinoma and bladder cancers, these are the modifiable risk factors: smoking and alcohol cessation, reduction of occupational exposure or change of occupation sometimes may be required, reduction of analgesic use, stop using hair dye, consume more fluids. So these are the modifiable risk factors. And whenever history of Lynch syndrome is there in the family, better to go for evaluation and regular screening. Coming to most important, prostate cancer. It is the second most diagnosed prostate cancer in men. The incidence is probably second commonest in Bangalore, Pune, and Delhi. It's really alarming. When it comes to familial and hereditary causes, the pathogenic variants were most commonly identified. That's BRCA2, CHEK2, ATM, and BRCA1 genes are implicated in this. We don't have exact Indian statistics. Age itself is one of the important parameters because we don't see prostate cancer in less than 40 years or 45 years. So age itself is a very important etiological factor. Chronic inflammation and infections, obesity, smoking, alcohol consumption. Vitamin D plays a very important role. At least according to recent study, 90 to 95% of doctors are vitamin D deficient. So we don't get exposed to sunlight. We don't, the dietary requirement will not be met by our diet. So I would strongly urge all the doctors to check your vitamin D and take accordingly preventive or precautionary measures. Other environmental and occupational factors, exposure to cadmium and estrogenic insecticides are implicated in the genesis of prostate cancer. Diet, red meat is one of the etiological factors as against lycopenes, which reduce the risk of prostate cancer. And I must mention, I will probably talk in my subsequent slide, various trials are there, PCBT trial and REDUCE trial, designed to investigate the effect of finasteride and dutasteride. These are 5-alpha reductase inhibitors, but none of them were found to be approved by the European Medical Agency for chemoprevention. These things are not going to be useful to prevent prostate cancer. Coming to the SELECT trial, again, they studied the efficacy of selenium and vitamin E. Results suggested that neither selenium or vitamin D or vitamin E or even the zinc should be used to prevent the cancer. Coming to metformin, statins, and sexual practices, metformin not advisable as a preventive measure. In the STAMPEDE Arm K, it's ongoing study. it did not show any preventive effect of statins on prostate cancer. However, there is a one study published recently, a year back, increasing the frequency of ejaculation or sexual activity, maybe more than 20 times ejaculation in a month, will prevent prostate cancer to some extent. This is the only one study which we came across, and they studied over a period of 35 to 40 years. It's very, prospective, controlled, prospective trial, population-based trial. So having ejaculations more than 20 times may be helpful to prevent this prostate cancer. When it comes to screening, it is very controversial, but ERSPC study from Europe, it showed that it decreased the mortality rates, but the difference between screening and versus non-screening is quite small compared to large number of men diagnosed with prostate cancer. However, the recent updates suggest that the screening for prostate cancer reduced the risk of metastasis by almost 32%. Hence, it's going to reduce the cancer-specific mortality by more than 32%. When it comes to risk-adapted strategy, offer early PSA testing to well-informed men at elevated risk of having prostate cancer. The men from 50 years of age or men from 45 years of age and families of prostate cancers are very important. Men of African descent from 45 years of age, men carrying BRCA2 mutations from 40 years of age. These are high-risk category where you should advocate PSA screening from the age of 45 to 50 years. Offer risk-adapted strategy based on initial PSA levels. So whenever men with a PSA level of more than 1 at 40 years of age or men with more than 2 PSA at 60 years of age, they should go for at least once in 2 years PSA screening, because PSA screening is the only way to detect or early detection of prostate cancer can be made, which is potentially curable. Coming to genetic testing for family, I would not, because of lack of time, I would not go into the details of this. Germline mutations can drive the development of aggressive cancers, and testing is advocated in all these patients. Coming to penile cancers, the risk factors are phimosis, chronic inflammation, BXO, that is balanitic xerotic obliterans, smoking, and HPV infections. Early onset and multiple sexual partners have been dealt by Dr. Anil Kamath in detail. These are the pre-malignant conditions, that is penile intraepithelial neoplasia, cutaneous horn, lichen sclerosis, condyloma acuminata, and Bushkilowski tumor. So these can be just by clinical examination, either patient himself or a person himself can detect, or if they come for any screening evaluation, probably clinician can just examine and identify these lesions, which doesn't require any investigations. Early prevention of precancerous lesions and its malignant potential and treatment. Phimosis, neonatal circumcision is the only way to prevent penile cancers to some extent. HPV immunization and sexual practices, vaccines have been discussed in detail. Smoking cessation is going to be helpful in prevention of penile cancers. Coming to the last, testicular cancer. These are the risk factors. Testicular cancers represent 1% of adult neoplasm and 5% of all urological tumors. At diagnosis, 1 to 2% are bilateral. Predominant histology is germ cell tumors, around 90 to 95%. Less than 5% are NSGCT. And these are the risk factors: white race, cryptorchidism, personal history or family history of testicular tumors, and presence of intratesticular germ cell neoplasia when we do biopsy. Testicular self-examination is proven to be effective in identifying the testicular tumor in the early stage, maybe once in a week or once in a month. Person himself should examine their testes and can understand the difference in the difference between the two testis sizes. There is no specific preventive strategies available for testicular tumors. The role of precision medicine and cancer genomics in cancer prevention. The definition of this precision medicine is given by US NCI. It's a form of medicine that uses information about person's genes, proteins, environment to prevent, diagnose, and treat disease. This is basically proteomics, genomics, and metabolomics based identification of cancers. So personalized medicine opens a new aspect in the treatment of different malignancies of urological cancers. Considering personalized medicine in urological cancers not only can predict the outcomes, but also can improve the treatment efficacy. So I would like to acknowledge my colleagues, Dr. Raj Patel and Dr. Ravi Tawari, who are our fellows with me. Thank you. Thank you for this opportunity. Thank you, Dr. Nanda, for this wonderful conference. Thank you.
It was a wonderful
I'm happy
talk.
to take any questions.
It was a wonderful talk, sir, as usual, by Dr. Raghunath. So, along with being doctor as profession, we are farmers by art. So the session is open for discussion.
Absolutely. What we eat, we're all sitting in Bangalore. It's so much polluted. We have to take care of ourselves.
Terrace gardening is a very good initiative, sir.
Yeah. Thank you, sir.
You recommend routine PSAs in general health checkups? What is your thing? Because it had come in, it went out, came back, again went back. Routine PSAs or 6-monthly general health checkups, which so many labs offer. What's your take on that?
Unfortunately, a lot of controversy is there. Controversy is about overdiagnosis, right? But in India, probably we must do screening. We must do PSA screening after the age of 50 for all men, because the incidence of high-grade tumors are very high. The PSA screening may not be relevant in America because 30% of the cancers do not require any specific treatment. They qualify for active surveillance. However, in India, less than 1 to 2% qualify for active surveillance. Most of our prostate tumors are high-grade and higher stage tumors, where screening can definitely prevent a lot of lives, because cancer-specific mortality in India is around 70%, which is unacceptable. So PSA screening is more required in India than in any other places because of this.
Frequency that you suggest?
Yearly once. Yearly once.
That's a very apt thing, Dr. Raghunath. That's very, because that's something like you mentioned, it's a very big controversy whether it should be included into the guidelines of on routine screening or not. That's something that's good that you mentioned, that we're having it once in Indian scenario, we're having it as a very high grade tumor. Hence, we need to do it. We can't follow the American guidelines on that.
Exactly.
Thank you.
Thank you, sir.
Thank you, Dr. Raghunath, and thank you, Dr. Nataraj Naidu, for chairing the session. With this, we mark the end of the scientific program for SPOC 2021. So it's been a long and arduous task headed by the able Dr. Nanda Rajneesh, where she's marshaled all her resources at her disposal to ensure that this becomes such a successful meeting and a convention. The planning for this went for almost 4 to 5 months when the organization was started around 6 months earlier during the pandemic, and then after which the planning for this was done very meticulously over the last 4 months. A lot of every detail, attention was paid for every single detail, and then everything was meticulously planned. There was responsibilities were allocated for different people, and then all of us got we had so many meetings which we failed to attend many times, but nevertheless she took all of us into her stead and took all of us through this as one single unit. Commendations to your leadership qualities, Dr. Nanda Rajneesh. Also, I'd like to thank all the people, the media, the press, the sponsors for the program. The sponsors for the program are?
Sponsors for the program were Mylan Pharma, Sun Pharma, Seronix, Staples and Surgicals, Alchem Pharma, Merrill Lynch, and Farmit. So we thank all the sponsors for making it possible for SPOC conference. We would also like to thank Mr. Seshadri and his team for managing things so well. Probably without their support and without their coordination, it wasn't possible. And also we would like to thank Taj West End for giving us this opportunity to host the event here. And it has become a successful event because of everybody's cooperation. Also, at the end, we would like to thank all the speakers, all the moderators who were here and they took continuous sessions. So we are really thankful to all of them.
We would also like to thank all the founding directors of Society for Prevention of Cancer. We'd like to thank all the executive advisors, all the patrons, and all the well-wishers of SPOC, without whose help and without whose support, this would not have been a possibility. This cannot and can never be a one-man show, and this has been due to the collective effort of all of the people who are involved with SPOC. Thank you again, and next year.
We would have another conference next year, probably under guidance of Dr. Nanda. Looking forward for all of that. Thank you, one and all.
That will be another scientific feast, and we'll have more research and we'll have more publications by then, we hope. Thank you so much. Jai Hind.